he's going to do it from there. He said he's joining. I spoke to him 5 minutes back.
We are live, please.
So, good morning, a very good morning to one and all. Welcome to the first session of the Moscon Mid-Term 2025 after a very vibrant cultural night in yesterday's program and wonderfully curated sessions yesterday. We are all set to start the next session for today, that is dilemmas in refractive surgery. And as with all the sessions, we have a really good group of faculty, speakers, panelists, and we have two wonderful chairpersons who are going to be overlooking this session. We have two veterans in the field of refractive surgery, two pioneers really. Dr. Rupal Shah, ma'am, she requires no introduction, and Dr. Shashi Kapoor, sir. Dr. Rupal Shah is from Baroda and also practicing in Mumbai. Dr. Shashi Kapoor from Mumbai. And we don't want to get into too much of introduction of all the people. I request Dr. Natasha to introduce the panelists, and then we'll kickstart all the cases so that we can have more time on discussion. So thank you, Dr. Rupal ma'am, Dr. Shashi Kapoor sir, for joining us on Sunday morning.
Okay.
Dr.
Thank
Natasha,
you,
you can
Zain.
just
Warm
welcome, sir.
welcome.
Yeah. Dr. Natasha, just introduce the panelists quickly, and then we'll go ahead to the cases.
Thank you, Zen. So just I'm going to name all the panelists, and we're so blessed to have such fantastic panelists, a mix of young and senior. Well, who doesn't want to be called young? But yeah, well, all of us together. So here is Dr. Pawan Chauhan, Dr. Neeraj, Dr. Tanvi Haldipurkar, Dr. Nikhil, Dr. Dhruven Shah, Dr. Viraj, of course, Dr. Shashi Kapoor, a very senior panelist with us, Dr. Adlakia sir, uh, a fantastic refractive surgeon, Dr. Kenya, my personal favorite, Dr. Sangeeta Wagh, and Dr. Vardhaman. I'm rooting for Pune here. So, and me. So, without further ado, I think we'll start with the first speaker, Dr. Yash Gala. So Dr. Yash would be speaking on refractive dilemmas, vision impossible. Yash, you have 5 minutes, and then we have 2 minutes for discussion.
Ma'am, am I audible?
Yash, over to you. Yes, you are.
Yes.
Good morning, everyone. I'll just share my... So, good morning, everyone. So my case is a refractive dilemma in my young refractive surgery career. So in my early days, like not so early, 2 years back. So let's see whether the vision was impossible or vision was saying I am possible. So here is a case of a 27-year male IT professional who came for LASIK inquiry. His best corrected visual acuity in unaided visual acuity in right eye was 6/18, in left eye 6/18 parts, which improved to 6/6. His spectacle correction was stable since 2 years. His anterior segment examination and fundus examination was unremarkable with no peripheral lesions. Uh, Topography showed a thinnest pachymetry of 478 and 481 in right and left eye, and there was no evidence of keratoconus. His Shermer's value was 25 and 20 in right and left eye. So since the pachymetry was low, we decided to go ahead with both eyes PRK. So the examiner machine that I had done PRK was on Vizex Star S4 or by Johnson & Johnson, no financial interest. So the epithelial removal, the technique which I had used was alcohol assisted, after which the examined laser ablation was done, and intraoperatively mitomycin C 0.02% was applied for 10 seconds. Post-operatively, as routinely we give antibiotic, a soft steroid, and a lubricating drop. So day one, patient was okay, but he had complained of little more pain in the right eye than the left eye. So, and everything was okay, no infiltrates. BCL was in C2. So I called the patient on day 4 for BCL removal. So on day 4, on post-op follow-up, patient complained of severe pain, redness, watering in right eye. So on examination, I noted severe circumcorneal congestion, There was a focal subconjunctival hemorrhage, a central 3 by 3.5 epi defect with irregular edges, dense DM fold, BCL was in situ, left eye BCL was removed as epithelial had completely healed, and there were few punctate epithelial erosion on staining with no infiltrates. So we still continued the same drops and asked the patient to follow up the next day. So next day, to my nightmare, the symptom worsened in right eye. There was more marked circumcorneal congestion. The epi defect had increased in one meridian by a 0.5 millimeter. The dot infiltrates, as we can see here, were seen along the inferior edges of epithelium. There was marked striakeratopathy, AC reaction plus 2 cells. So there was a dilemma whether it was an infective origin, which we are seeing, or a very heavy inflammatory non-infective origin. So I'd asked the patient for some history that any chemical or anything had gone inside his eye or any trauma. As such, he denied. He just said some fingernail injury, but that was not significant. He just said it just touched his eye. So the BCL that time I had just removed and sent for culture on a blood agar plate. So the diagnosis, the dilemma was whether it was an infective or a non-infective keratitis or some superimposed viral keratoconjunctivitis or toxic keratopathy, but no chemical injury, so toxic keratopathy was ruled out. So the dilemma was there, and then we went ahead with the instinct of having non-infective keratitis and we started prednisolone acetate 6 times a day. Just to cover, we had started even gatifloxacin ointment or cycloplegics for his pain and AC cell reaction and increased moxifloxacin dosage to 10 times a day. On 6th day, more or less status quo, but there was marginal symptomatic relief and there were sloping of epithelial edges as we can see in the picture here. So we still continued the same treatment. On day 7, there was marked symptomatic relief. All his symptoms in terms of signs in terms of circumcorneal congestion, the ED, the striakeratopathy was healing well with a central subepithelial stromal haze, and the dot infiltrates had also gone down along the inferior edges of ED. So we continued the same treatment. I reduced the dose of antibiotics to 6 times, and I'd kept Gatiflox ointment at night and continued topical steroids. On day 10, his visual acuity was better, 618 parts, which was improving to 612 parts with pinhole. There was again marked decrease in all his signs. Epithelium was healing well. It had reduced to 1.5 to 1.5 millimeter. The dot infiltrates were also still present along the inferior edges, and the healing was taking place with a bit of central subepithelial scarring. And there was no striakeratopathy, which we had seen before. So it had all come down. So the results of the BCL over the blood agar, it had showed no growth. We continued the same treatment. Post-op 3 months, patient visual acuity recovered to 6 by 9 parts in right eye. The scarring was central and paracentral, which was very faint. I don't have the anterior segment OCT picture. I am not able to find out, but the scarring which was present was at a depth of 165 to 170 microns. We started the patient on cyclosporin and continued lubricating drops. Post-op 11 months over the year, patient recovered further to 6 by 6 parts with a very, very faint nebular scarring with a AR reading of plus 0.5 as we can see as what I could recover. So patient happy, I was happy, and the nightmare had resolved. So yes, vision says I am possible. So my learning points according to my case was timely decision of starting topical high potent steroids helped in preventing significant scarring and thereby visual recovery in this case. Thorough saline wash during alcohol spillage, during debridement or during MMC application is essential to avoid post-op inflammation, thereby delayed epithelial healing in our case. Although there was no spillage in our case, probable thing which we were suspecting. And always, as a cornea person, I always say, when in doubt, need for corneal scraping for grams or culture should always be done to rule out any infective etiology. So patience, calmness, empathy towards the patient, and if required to take expert opinion when in doubt is essential. Thank you very much for your kind attention.
Thank you, Dr. Yash. Now this is up for discussion. Dr. Pawan and Dr. Shashi Kapoor, sir.
Yash, very well managed.
Yes, sir.
Just a question. Hello.
Yeah, sir, you can you repeat it? We couldn't hear you. I think
Yeah, I didn't hear. I
so your network is a
lost.
bit poor.
I think just in a minute or so. We don't have time. Okay, I think just carry on. Yeah.
We can hear you now, sir. Can you can ask the question? Okay, is Dr. Pawan here? Okay, so Yash, that was really a nightmarish kind of situation, and something that you don't want after routine refractive surgery. When you started off the case, I thought it's going to go towards haze because that is what all the PRK cases discussed go towards. But this was really something well managed, and it was an interesting case. Rupal Shah, ma'am, can you give some inputs about whether you've seen something like this in your career, and what are we supposed to do when we see this?
Yeah, so epithelial healing response is sometimes a problem in PRK or any form of surface ablation, especially if we have used alcohol, because we don't know how alcohol will react to the remaining epithelium. Sometimes it just sends them into a shock and it really makes the healing response slower. Also, what type of BCL is used is important because some of the BCL which claims to be having oxygen permeability doesn't really allow it, and therefore it causes delayed healing response. We had an episode of almost 10, 11 patients where we had delayed healing. Unfortunately, there was no infiltration or anything, but I just want to ask, were you putting NSAID over those BCL?
No, ma'am.
No NSAID and no steroid also over the BCL.
No, no. I started steroid. Matlab, we generally start steroids only after BCL removal.
So over the BCL only the antibiotic, right?
In this case, ma'am, yeah. The soft steroid was started from day one. Sorry, I
So,
made a yeah. We start soft steroid from day one over the BCL.
so
Yeah.
what do you mean by soft steroid?
I mean
Chloromethylone?
chloromethylone or loteprednol.
Okay. So we were avoiding that because we were afraid of infection. But we did have cases of BCL which were not really that permeable and therefore wound healing response. And then those epithelium would heal but break down after a few days. And then we needed to do a PTK. That's how I learned my PTK procedures because I did that for in the very beginning in 95, 96. So but very well managed. And I'm glad that you thought of taking a swab and not just go on the path of infection, because that's very easy to think that this is infection and treat it accordingly. And you would have missed out on the steroid part. So
Yeah.
well
And,
done.
yeah, and I
I
took
don't think I would have done anything differently.
Dr.
Uh,
Sangeeta, ma'am?
Yeah, I think you've managed the case excellent, and the final outcome is what matters both to the surgeon as well as the patient. And I'm really happy for both of you. But I would have erred on the side of an infection because, the eye is staring at you. You can see the congestion, which was not there in the other eye. You can look at the edges, which are not looking very healthy. And the fact that there are folds and there's chamber reaction, I would have put infection on the top of it. And I think you did very well in giving 1 hourly moxifloxacin. And after 48 hours, where you know that there is no obvious infiltration, hypopia, no worsening, your rationale to start steroids was absolutely right. What I might have done differently is scrape the edges and plated that on the blood agar and put the contact lens in either sterile saline or, if you keep a liquid medium, that is what will give you a good growth. Putting a lens on the blood agar itself, unless you manually rub it, may not give you enough of an output. So all in all, I think, you've managed it really well, but maybe just the investigations
Yes,
Have
yes.
been slightly different. And of course, till he responded, I would have had sleepless nights, which I'm sure.
So, ma'am,
Congratulations
I
for a
Yeah,
very well managed case.
since
Natasha,
Yes,
uh,
sir.
Yes, sir. Yes, sir.
yeah, am I audible? Yeah,
Yes, sir.
now?
Yes,
You're
sir, you
I
are.
audible.
think I got this. I want to ask Yash, what was his assumption on day 2, 3 when he started aggressive steroids? It was non-infective or infective?
yeah, sir. So that was I was coming to when ma'am said that I would have scraped when we saw that type of reaction on day 4, probably. Because after day 1, he came, like generally we see on day 1 and then we call for BCL removal. He didn't come in the middle with anything uh, like aggressive and turn to us immediately that it is worsening or something. I was thinking of scraping, but that time, as I said, sir, I was too
No, that's okay.
I was terrified that time. And then I
Mm.
spoke to one of my senior colleague, and after discussion, he said, just don't scrape and just start steroids on that day.
So, when you decided to start steroid, did
Yes.
you take a decision that this is not infective?
Yeah, so maybe it was not coming from me, but then that senior opinion
Yeah,
where I got this
but
response,
but
he said it looks inflammatory,
okay,
just to you start like
okay.
that.
In that case, why did you increase the antibiotic to hourly?
So just to be on the safer side, sir, just to cover up if there is anything like
So basically, you have not decided either way. You have made the antibiotic one hourly, thinking it could be infective, and you have increased the steroid, thinking it could not be infective. So you want to, so assuming it's not infective, you want to prevent scarring and non-inflammatory will respond, non-infective will respond better to steroids. Correct?
correct.
In a way, yeah, yeah.
Yeah, he's covered all
So
bases,
yeah,
sir, I think.
I'll cover all. Yeah, that's just what they wanted to know. That the only thing he didn't do was start an antifungal. Yeah, that's true.
No,
Yeah.
All right, we'll go on to the
Thank you,
next
Yash. Well
case.
done.
Thank you, sir.
thank
Thank you, Sangeeta ma'am, for summarizing it. Thank you, Rupal ma'am. We'll go to the next case. Dr. Praful, could you load up your presentation while we introduce?
Yeah, sure.
Dr. Praful is from Nagar, and he's going to be talking on PRK, the haze defaced. So just taking a leaf from what we discussed earlier. Praful, over to you.
Yeah, the screen is visible.
Yes.
Just a second. Okay, fine. So today we'll be discussing basically, I had two such cases in last 6 months where I was very worried that after Trans-PRK, doing Trans-PRK since last 1.5 years, and lately I got two cases where we had a haze which was bothersome in term visually. So thought of presenting those two cases here. So as everybody knows what Trans-PRK is, it's basically a no-touch surface ablation where the epithelium is removed by the laser ablation followed by the PRK. So this procedure gives you an advantage of not having any other side effects of particularly alcohol or other things which will be touching the surface of the cornea. Usually, this procedure is preferred in cases with thin corneas and patients who are involved into contact sports athletes. Nowadays, it is more accepted because the procedure seems to be very easy and I almost have no learning curve. Even general ophthalmologists can easily shift to refractive surgery practices by procuring such machines. Generally, it is supposed to be safe with minimal complications. However, rare cases of reticular epithelial scarring and haze is a nightmare in such cases. So basically, this is a subepithelial fibrotic scar which look like a reticular in a reticular fashion, usually in the central 6 millimeter zone. And sometimes it may resemble as a atypical haze or a delayed epithelial remodeling case in early 1 month phase. When does it occur? Usually the time period is 2 to 4 weeks or sometimes in late post-op. It may persist for months and often stable but visually significant if it is central. So these are the various causes and risk factors. Amongst the ophthalmic, the main causes are aggressive healing response from the eye, inadequate use of mitomycin C during the procedure, poor epithelial closure leading to prolonged inflammation, cases with high refractive error more than 6 diopter, environmental factors like dust and UV exposure, and sometimes if epithelial defect doesn't heal more than 5 days post-op. There are systemic association if the patient has a tendency of keloid or any skin disorder, and cases with deranged immune system. So the clinical features patients may present to you with a best corrected visual acuity with less than 6/9. They may have glare, photophobia, and halos. On slit lamp, you get a net-like scarring on slit lamp, and usually there is no vascularization. So to prevent this, most of the surgeons do use mitomycin C 0.02% for 10 seconds per diopter for depending upon the refractive error. We do give tapering steroids over a period of 2 months. To enhance the epithelial healing, we give a lot of lubricants, sometimes vitamin C. We advise to put bandage contact lens for more than 5 days, and UV protection is must for at least 6 months. So these are the standard Trans-PRK procedure protocol. So I will not go into this. In this only, the thing which is worth mentioning is in the Schwinn platform, you have a Trans-PRK mode which comes for free of cost. So most of the surgeons prefer to use and remove the epithelium with the help of laser itself. It also gives an advantage, as previously said, the PRK because of alcohol and otherwise used to have more scarring. And Schwinn claims because of this Trans-PRK technology, they have some module which helps you having less scarring. So this is my first case where 1 month post-operatively in the right eye there was a grade 1 scar, and in the left eye there was visually significant grade 2 to 3 scar. This is a serial OCT of the same case. The left one is a pre-op AS OCT, and the right one is a 1 month post-op where you can see there is a atypical haze and delayed epithelial remodeling in this particular case. And at this moment we realize that something is not going right, although there was not typical reticular haze at this moment. So at the 6 months, if you see, this haze disappeared with the treatment which we gave. Right eye almost disappeared, and left eye it was very subtle, and the patient improved, had a very good vision later on. So again, this is a post-op 3 months and 6 months ASOCT showing that the scarring has settled and the cornea has become more compact and clear. The pentacam images after 6 months were very healthy, and the right eye uncorrected visual acuity was achieved up to 6/9, and the left eye was BC up to 6/9 with -1 diopter of myopia. This is another interesting case where this female was apparently all right till last 5 months of the surgery, but suddenly after on the 6th month, she developed haze in the left eye. Again, it was a grade 2 scar. She had a decreased vision in the left eye, although there was no scarring in the right eye. So I was surprised why there was a different response in the either eyes. So what we did in our two cases, like we studied all the immunological mechanism, we did all the workup for the immune system. We started all these patients on loteprednisolone tapering over a month, almost over 3 months with the good IOP monitoring. We started this patient with the help of my mentor, Dr. Rohit Shetty sir. He advised me to start because I had never seen such cases before. So he advised me to start the patient on high dose of curcumin and to start the patient on losartan. Although losartan is not available, we used it as off-label compound made from some pharma company, which was given 6 times a day for 4 months. Later on, the pharma company refused to give us this drug, so we shifted the patient to Sika, which is liftigrast. Initially, the cost of liftigrast was very high, approximately around 11 to 12,000, and apparently they decreased their price recently, so we shifted the patient to liftigrast in last 2 months. After stopping the losartan, the patient was continuously on sodium hyaluronate 0.1%, 4 to 6 times for 6 months. We advise the patient to use UV protective glasses strictly for 6 months. So the take-home message is haze is rare but important complication of trans-PRK. Prevention via multiple MMC use and with aggressive epithelial healing support is important. UV protective goggle is must during the post-operative period. Ruling out all the systemic diseases pre-operatively like deranged immune system or skin tendency of keloids, and to avoid trans-PRK where refractive error is more than 6 diopter. So these are the key questions. I would like to acknowledge here Dr. Natasha. She helped me to manage this case telephonically, and I had also sent the patient to her in Pune to study this case, how we can manage. And we were also in touch with Dr. Rohit Shetty for the same. He helped us to procure losartan eye drop also. And but there were a lot of dilemmas how to deal with this patient, when to intervene, because initially in the 1 month period time when it was appearing like a poor epithelial remodeling, so we were confused what to do. Then losartan was not available easily, so how to procure losartan? Uh, the cost of lifting cluster was very high, although there are no claims whether it helps in decreasing scar, but there are recent studies which are saying that it might. And then what to do for the, if there is no improvement with all these drugs. So I would like to take opinion of everyone here, how you would have approached this case if you had to treat this.
Dr. Neeraj and Dr. Adlakia, over to you.
If I may just add, am I audible?
Yeah.
Yes, you are.
So during our fellowship days, when Dr. Natasha will be able to explain much better than me. See, more than PRK haze related to laser, because you mentioned that in Schwind cases, the haze is slightly less as compared to the other machines. I think it is more at the molecular level. So what happens is, can you stop your screen sharing, please?
Yeah, sure.
So, during the fellowship days, I remember there were 110 cases, the epithelium which was scraped off, that was stored in a biorepository, and then a study was done on them, which showed that at the molecular level, all the inflammatory mediators like IL-6, I think TNF alpha, and the other mediators, they were all increased. So it is more at the molecular level, number one. Secondly, your second question, to prevent uh, haze, I think there are three things which we were taught. First is OSDI. OSDI is one of the most simplest thing which is available in your OPD, OSDI scoring, which has a vision component and a discomfort component. Again, apart from that, eye rubbing is the second thing, which is IgE. So you have to test IgE in eye rubbers because, again, inflammatory, and contact lens intolerance. That is very important because this is a big red flag in PRK haze, which leads to PRK haze, because basically contact lens intolerance is because of inflammation. Lastly, another thing which is important is vitamin D. Again, Dr. Natasha will be able to explain much better, which is important in wound healing. So haze is also because in these patients, vitamin D is on the lower level, so wound healing doesn't take place faster. So I have no experience with losartan yet, but these things are important. Also, MMC to a certain extent kills the keratocytes. So there was one drug being studied called as vorinostat, Saha, which I believe was not killing the keratocytes and not reducing the myofibroblasts, which is still under study going on. So maybe MMC is important, of course, but there are better drugs in MMC which will come into the market soon, hopefully.
Dr. Adlakia, sir. Thanks, Neeraj, for that. Can you unmute yourself? Yeah.
Am I audible now?
Yes, yes, sir.
Yes, sir.
May I know how whether you use this NSID soaked lenses are there?
So I didn't get you, sir.
Prevent pain?
Did you use ketorolac soaked lenses?
Ketorolac
No,
soaked
no, I
lenses?
did not. I used chilled BSS and chilled BCL.
Chilled BCL. Okay. I think the corneal haze might be due to the use of these. Hello?
Sorry, sir, your voice is cracking.
So you are muted.
Probably when you use the mitomycin, might be it's not that much effective, or the time might be less, or the whatever whenever you prepare this mitomycin, might be not of that percentage, which may cause this type of haze in early stage.
Right, sir.
I think
Actually, yes, sorry to interrupt. Actually, when I went back and saw what exactly went wrong in my particular two cases, because I was doing this procedure since last 1.5, 2 years, and initially none of my cases had all these issues. So when I went back and saw the videos of those procedures, so I saw that the mitomycin sponge, which I was keeping on the surface of the cornea, was probably not wet enough to soak the stroma of the cornea to prevent this haze. That's what I realized when I went back and tried to analyze why these two particular cases had this issue. Although, as I had referred the patient to Natasha to have a look once, Natasha also found one interesting fact, which patient didn't tell me initially before the surgery. That patient had small keloid somewhere in the arm, which probably I missed preoperatively. Although anywhere in the skin, there was no signs that she probably had any skin issues or tendency to scar, which in fact, even after asking many times, she never told us. But lately, since last 6 months, what I've changed and seen that which is helping me is adequate application of mitomycin probably is one of the most important factor to prevent the haze post-operatively. And usage of UV protective goggles is another factor which I feel helps a lot. And I don't know, as everybody says that there is a probably cellular involvement here. But in my second case, typically that case, the patient had haze after 5 months of having clear cornea, clear vision. And I don't know why she has only in the one eye. So that is the time when I've thought of going back and see why this case had haze only in the one eye and not in the other eye. And then I realized probably mitomycin application was the missing link in my case particularly. In first case, obviously, probably the keloid
Keloid.
tendency is also an additive factor.
Well,
Natasha,
it takes a lot of time. Yes, sir.
can I put in quick comments? See, PRK haze, basically, whatever we have seen, the Steve Wilson from Cleveland Clinic has elaborated very well. The early phase haze is from the dendritic cells, and the delayed haze is from the bone marrow derived fibroblasts. So the haze derived from the bone marrow cells is very difficult to amend with steroids, but the early haze can get amended. Now, what I do slightly different in such cases is I do not use the sponge. I directly apply a drop of mitomycin directly onto the stromal bed, ensuring that it doesn't overflow onto the limbus. And that has made a lot of difference. And one more comment, that wearing of UV protected glasses is a must. I tell my patients to wear it for 6 months. Thirdly, I got recently 2 patients referred for very thick reticular subepithelial haze, almost 60 to 70 microns in thickness. And in those cases, both of them had around -3 diopter refractive error after that haze. So what did I plan was a Trans-PRK and then remove that haze. And most important was applying mitomycin for 2 minutes. And post-operatively, the patient is absolutely fine.
Thank you for those key points, sir. I think it'll take for us forever to finish defacing haze. We'll go on to the next topic. Very interesting case by Dr. Reshma Ranade. Incomplete flap does not mean incompetent vision. Reshma, can you share your screen, please?
I request the speakers to stick to their 5-minute time because we have 4 more cases.
Am I audible?
Yes, Reshmi.
Yes, you are.
Good morning, everyone. And thank you, MOS, Dr. Zain, Dr. Natasha, for this opportunity. So I'm going to talk on incompetent flap doesn't necessarily mean incompetent vision. So let's dive in and see what really happened. So this looked like just another refractive surgery day. It was a 34-year-old housewife interested in refractive surgery with a stable refraction for 3 to 4 years. Her refraction was about -6 in the right eye and -6.5 in the left eye. The topography was fairly
Reshma,
normal.
Reshma, can you go to presentation mode?
Oh, yes, sorry. So sorry. Right. Is it okay now?
Yes, yes.
So sorry. So the topography looked fairly normal, apart from the fact that it was a slightly steeper cornea. But otherwise, the Bellins and everything else was perfectly okay. So the flat Ks were about 45 and 46.8. The thinnest Paki was about 555 and 548 microns. And the white to white was about 12.04 and 12.1. So according to the nomogram, we decided to choose a ring of 8.5. And I do wish that we had Nostradamus predicting something for us that day, but sadly we didn't. So anyways, the right eye went off perfectly okay. The flap was complete. We fired the ablation. It was a regular flap cut. Coming to the left eye, what happened was that the microkeratome went about halfway, crossed the pupillary area, and it came right back, leading to an incomplete flap. So this was what the ASOCT looked like immediate post-op. So you can see an incomplete flap cut right there. So what do we do next? There are papers in literature which say that incomplete flap cuts should prompt the surgeon to stop the procedure, not only when the cut is about half completed, but also when the central part of the cornea, or particularly when you have crossed the pupillary area or it has been traversed with a blade. So what are the causes of incomplete LASIK flap cut? It could have been inadvertent suction loss. There was a strong lid closure by our patient in this particular case and distorted limbal or conjunctival anatomy. Now we always make it a point to do a dry run and make the patient hear the sound so that they don't jerk or they don't squeeze inadvertently. And it was quite funny that this happened for the left eye. Usually, the first eye is what typically goes through this problem. Anyways, so we abandoned the procedure for the left eye and we counseled the patient regarding the need to delay the procedure. Now, the devil is in the details, as they say. So how did we troubleshoot? So 6 weeks later, we put her through a detailed evaluation. So she underwent a subjective refraction, a cycloplegic retinoscopy. We repeated the corneal tomography. We also evaluated her Schirmer's 2 and did the ASOCT. So what did her refraction or her acceptance looked like? A -6 with a -1 cylinder, which was not previously there, as you would remember. And the cycloplegic retinoscopy also agreed to the subjective refraction. It showed like a -0.5 cylinder. This was what her corneal tomography looked like. And her dry eye was pretty okay. The right eye was about 17 and 18 in the left eye. T-bar was about 6 seconds. We put her on lubrication post-operatively and sodium hyaluronate 1% and cyclosporin because we didn't want any haze to interfere with the vision. Now, there was no scarring and haze, which we noticed at 6 weeks, and we decided to plan a topo-guided PRK for her left eye. So after taking 5 good scans, we exported them on the Wavelight platform, and this was what we planned. So we treated a -6.25 and a -1 cylinder at 10. The ablation was about 90 microns. Of course, we used mitomycin C in a concentration of 0.02% for 50 seconds. And this is the video of the laser firing. Now, post-operatively at 1 month, she was 6.6 in the left eye with an N6. It was a fairly centered ablation profile and there was no haze or scarring. She recently came back for a year's follow-up and she's doing pretty well. The vision still holds good at 6.6 parts and N6. So post-operatively, our regimen is usually moxifloxacin 4 times a day for 15 days, topical lubrication and eye ointment, and she was pre-operatively already started on cyclosporin, which we continued, and we start soft steroids like fluoromethalone after the epithelium heals completely after removing the BCL. So the take-home points here are that detailed evaluation prior to resurgery is the key. An immediate second pass of the microkeratome at a deeper depth could have been attempted once you exclude suction loss, irregularity of the stromal bed, and MK malfunctioning. Advanced surface ablation or topo-guided PRK treatments could be a safer alternative. Intraoperative mitomycin C can help in preventing scarring, and post-operative intensive steroids and cyclosporin are an absolute must. Thank you for your patient listening, and I would be happy if you would share insights and if you would have done anything differently. My acknowledgements are right here. Thank you so much.
Thank you, Reshma. So, yeah, that was well managed, and we have experts, Dr. Tanvi and Dr. Vaishal. So, you all can just shed light on whether you all would have done the same thing or, done something differently.
So great thinking, Reshma. I think you decided on a path which many people would, think that would be a safer approach. But I just wanted to ask that what was the depth that you took with the microkeratome in the first go?
It was 120 microns, ma'am.
Okay, so probably what I may have done is waited for a month, maybe 3 months even, waited for regularization of the refractive error and gone with a 90 microns blade, because the microkeratome flaps heal very well. They can sit back, and if it was not irregular or a suction loss where there was a ragged margin, you would actually come out with a very crisp 90 micron cut. Also, a second question comes in my mind: was this a blunt blade? Did you use this blade more than one eye? Is that the reason?
No, ma'am. We use a fresh blade for every patient that we do.
Surprising then that it stopped right in the middle, but well
Yeah.
managed.
Thank you, ma'am.
Vishal sir.
Yeah. So Reshma, very well managed. What I would think is when I would do PRK and when I would do a microkeratome. So it all depends on the patient's needs. If I feel the patient is not going to follow up well, then I would err more on the microkeratome based, and definitely the ASOCT would help us to decide the flap thickness. In such cases, I would err more on a thicker flap if the residual bed prefers. Going for a thinner flap can be sometimes really challenging in these steep corneas. And definitely a femtosecond laser-based flap would be much better, though the scar which would be there is very hardly anything. So it would not matter for a femtosecond laser even to penetrate. So you can increase the energies in the femtosecond laser and it can make a very good flap too. So that would be one of the other option. If femtosecond flap can be made, it can be made accurately. You can customize the geometry of the flap, etc. So that is the other option which could be thought of. Definitely. Very well done. Thank you.
Thank you. Thank you, sir.
Thank you, Reshma, Tanvi, and Vishal, sir. So, Mrinmay, you can start sharing your screen for your case, hazy cornea post LASIK. Meanwhile, Dr. Rupal, ma'am, if you would like to add something.
So if you're making a new flap, it's always better to make a thicker and a larger flap so that the original flap gets incorporated in the new flap. I like the idea of doing a femto flap because then you can exactly know that you are 20 microns away from that plane, but you have to make sure that you are away from the plane and not, otherwise the femto laser, the bubbles will go and go in the same flap area. So you would then not be able to do a smooth flap. So just make sure whether you are in front or behind the original flap, to make sure that you are about 20 microns away.
I just had one question for all the seniors. Would you wait for about
Reshma, we'll come back to it later.
Sure.
Okay, we'll do that
Yes,
to
yes.
at the end if you have
Sure.
time. Okay.
Yes. Thank you.
Yeah. Mrinmay, you can start your presentation.
Can you hear me?
Yes, you're audible.
Okay. Good morning. My name is Dr. Mrunmay. I am second year PG resident at Lakshmi Eye Institute, Panvel. My topic is hazy cornea post LASIK, a masquerader. So our patient, 23-year-old male, came for refractive surgery with refractive error of -5 sphere and -1 cylinder in his right eye and -5.75 sphere and -1.5 cyl in his left eye. Our patient was a known case of dry eye with allergy, so we treated him for the same and we plan to operate him in next 2 to 3 weeks time. His preoperative topography and his preoperative Belen-Ambrosio display were normal. His preoperative pachymetry and epithelial maps were normal. So we did contura LASIK in both the eyes. Intraoperatively, we noticed loose epithelium in his left eye before flap making, for which BCL was later inserted once the flap was settled. On postoperative day 1, his right eye was doing absolutely normal with best corrected visual acuity of 6.6. On slit lamp examination, the flap was clear and the interface was clear. But the vision in the left eye was 6.12. The flap was hazy and there was early DLK-like picture. We could also see the epithelial defect inferiorly. On checking the pressures on non-contact tonometry, they were 32 in the left eye. We did his ASOCT raster scan to look for any granularity. We could see a thin hyporeflective line at the interface, which we thought could be an artifact. So what was it? Was it DLK because of the clinical picture? Was it PISK because of the hyporeflective line, or was it any kind of infection? So we were in this dilemma. If it was steroid response, why did it appear so early? Was IOP actually elevated? we thought that it could be DLK because DLK is more common immediately after LASIK. At this point, we had to make one diagnosis because the treatment of both is diametrically opposite. In PISK, we have to lower steroids and taper steroids quickly and stop them. In DLK, we have to continue the steroids. So we made the diagnosis of DLK and we treated him accordingly because we thought that there was a pre-existing epithelial defect, which, as all of us know, increases the risk of DLK. We also thought that the high pressure is because of the BCL on. So we started him on prednisolone and we also gave him anti-glaucoma medications to lower his IOP. Post-operative day 2, his left eye vision had improved. Anterior stromal haze was also resolving and the epithelial defect was almost healed. IOP on non-contact tonometry was 16. So we stopped his anti-glaucoma medications. We removed the BCL. On post-operative day 4, his vision had further improved to 6.6. The flap was clear, interface was clear with mild haze in the stroma, but the pressure had again raised to 22. So we again started him on topical anti-glaucoma medications. On post-operative day 7, this was a slit lamp picture in the right eye. Right eye was clear, but left eye showed diffuse haze. On checking the pressures on NCT, there were 24 in the right eye and 30 in the left eye. We did his ASOCT, which did not show any significant findings. On rechecking the pressures and applanation, there were 14 in the right eye and 16 in the left eye. So our question was the IOP actually raised or no? But because the ASOCT did not show any significant findings, we did not change the line of treatment. On post-operative day 14, his left eye showed gross diffuse haze. There was full thickness flap edema in the left eye with pressure of 9 on NCT and 2 on applanation. His right eye also showed mild flap edema with raised pressures. On doing the ASOCT, we could see a thin hyporeflective line in the right eye, but there was gross fluid in the interface, mostly in the lower quadrants, which also correlated when we did his topography. There was inferior steepening which could be seen. So at this point, we were clear that we were dealing with PISK. So we immediately stopped his steroids and we put him on oral and topical anti-glaucoma medications. On post-operative day 21, that is after 3 weeks, we had a happy patient with clear vision. So when we thought that why did PISK present since day 1, because we were seeing that hyporeflective line since day 1, when we retrospectively look back, we had treated the patient for his allergy with low-dose corticosteroids, that is Lotipred, for 3 weeks. And at that point, his pressures were raised. So he was a steroid responder pre-operatively as well, which we missed. So if we come across hazy cornea post-LASIK, these are the differentials that can be thought of. As we saw that it can be early DLK, which presents immediately post-op. It occurs in different stages. Generally, there is no pain and redness. And we need to lift the flap if it is stage 3. If it is PISK, usually it presents 1 to 2 weeks after use of steroids. IOP is raised and there is full thickness stromal haze and edema. Usually there are no granular haze or deposits and it responds to anti-glaucoma medications. It can also be microbial keratitis, which presents as ciliary congestion. There can be pain, vision loss. There is stromal edema and flap melt. If it is early onset, it is mostly because of gram-positive bacteria. Late onset is because of atypical microbes. So the treatment is flap lift and we have to send it for culture and smear. It can also be persistent epithelial defect masquerade syndrome, where there is a epithelial defect and delayed reepithelialization. The treatment is flap lifting and mechanical debridement. So our take-home lessons are always trust the instincts, document all the findings, and record and note intraocular pressure in refractive patients pre and post-op. Thank you.
Thank you, Mrinmay. So that was truly a masquerader and something that has to be picked up. Quick comments from our panelists for this, Dr. Nikhil and Dr. Sangeeta ma'am.
Very nicely managed, Reshma. steroid, the PISK is not very common entity, but of course it is not that uncommon also. So in one of my case, I had treated like couple of years back. It was on day 3. Probably I would have missed it on day 1. Pressure was rising to the level, and we tend to avoid taking IOP on immediate post-op. So it depends on the previous steroid exposure to the patient. So if patient has been already exposed to topical steroids for some other conditions, the steroid response can be as early. Maybe first time it is, according to book, it might take 3 weeks for proper steroid response, and that's how we check in children when we put them on steroids. But otherwise, yes, this is very uncommon entity, and it is usually neglected and missed sometimes.
So I think this was a very well managed case. It was rather challenging and confusing. So you had two things happening simultaneously. You had a DLK at the outset, and then it got complicated by steroid-induced pressure rise, resulting in the PISK. I had a few questions. Your patient at the outset had dry eyes and allergic eye disease. So I wanted to know what was the protocol you used to manage, and how were you sure that both these were controlled before you started or set up the patient for the surgery? When you say allergy, was it like just a mild form? Did you have GPC? Did you have papillae? How was the tarsal conjunctiva? Because the first thing that you mentioned was the loose epithelium on table, right? Which necessitated putting the bandage lens. So, had we been able to avoid this defect right at the outset, then maybe none of this would have happened. And that's why I would take everybody back to the pre-op investigation and management of the patient, because that would have, helped to avoid this entire story.
So the patient had mild allergic symptoms, and he had intense itching, for which we had started him on olopatadine and lotipred. And about the epithelial defect, we noticed it at the time of surgery intraoperatively.
Right. So if the patient just had allergy, was there a rationale for preoperative steroids? And could it be that 3 weeks of preoperative steroids increase the epithelial fragility in addition to the dryness?
Ma'am, we just have to go ahead because we are short of time. We have two more cases and we have to finish by 10.
Sure.
So we move on to Dr. Shireen, and we'll take both the last cases together and then have a quick discussion with the panelists on that. So Dr. Shireen will be talking on Circle Brings Back the Smile. You can please share your screen and please stick to the 5 minutes of presentation.
Am I audible?
Yes, Dr. Shireen.
Okay. So good morning, everyone. I'm Dr. Shireen. My today's refractive dilemma is about suction loss during smile surgery. So here's a case of 26-year-old female seeking refractive correction with pre-operative corrected distance visual acuity, 6/6 in both eyes, manifest refraction, right eye minus 3.5 sphere and minus 0.5 SIL at 180 degrees, left eye being minus 4 diopters sphere. Serous pentacam was within normal limits, hence smile was planned for this patient in both eyes. Here you can see cap and lenticule parameters. Lenticule diameter was 6.5 mm, cap diameter was 7.5 mm, cap thickness was 120 micron, and small incision position was at 90 degrees. So here's the beginning of the femtosecond laser, you can see in the video. So you can note at the end of the cap interface cut, there was unstable suction, which resulted in the intrusion of conjunctival tissue into the interface. Laser was continued and completed since there was no loss of contact between the corneal surface and suction glass. Creation of the cap and lenticule interfaces had been completed. The only concern was to gain access to the formed lenticule. So what are the treatment options we had? First was to go ahead for surface ablation. Second was thin flap LASIK, or maybe we could go for flap with femto, or using Circle software to convert cap to entire flap, or maybe anything better. So traditionally, Circle software was indicated for enhancement after smile. It allows the conversion of smile cap into flap and provides access to smile interface and allows the surgeon to perform excimer laser assisted enhancement after any refractive surgery. It is used to create a junction cut to connect new incision to old, or create a lamellar ring-shaped extension to existing surface cut and create a flap side cut. So here, decisions are more important than incisions for every surgeon. Suction loss had occurred in our case. Retreatment or restart module could not be used as the laser delivery was completed. We needed access to the lenticule. So we decided to use Circle software to create 50-degree wide small incision only, avoiding the entire cap to flap conversion. So let's see the video. Femto laser had begun. At the end of the cap interface, unstable suction resulting in the intrusion of conjunctival tissue within the contact interface. Small incision was not created. So we decided to use Circle software to create a new small incision only, avoiding the entire cap to flap conversion. So new lamella cut at this depth of 120 micron as original cap thickness, and lenticule could be accessed. Manual lenticule dissection and extraction was then performed. You can see the dissection was smooth. And hence the flapless smile was completed. Left eye surgery of smile was uneventful. Here to simplify, in order to create 50-degree wide, that is 3.2 mm small incision, 290-degree hinge, that is 20.83 mm was designed. Hinge was positioned at 290 degree in such a way that new incision location was superior temporal at 110 degrees, not coinciding with 90 degrees incision. So you can see original smile incision in black and incision created by smile by Circle in red. On first post-operative day, patient's cornea was clear, uncorrected distance visual acuity was 6.6, AS-OCT showed clear interface. So this was the first report worldwide which describes the successful use of Circle software for small incision creation only as a management strategy for suction loss in smile. This unique approach without cap to flap conversion in similar scenarios seems to be safe, resulting in a favorable outcome. So I conclude, Circle brought the smile back even after the loss. I thank my mentor, Dr. Vardhaman Kankriya, for giving this wonderful opportunity to present this unique case. Thank you, Emma. Thank you, MS, for this opportunity. Thank you.
Thank you, Dr. Shireen.
Thanks. I think we'll go on to the last case, which is managing cap perforation in KLEX by Dr. Neha Rathi. Dr. Neha, can you share your screen? And then at the end, we can take the questions and comments.
Am I audible?
Yes, you are.
Just right. Is my screen visible? Okay.
Yes, it is. Yes.
So I'll be sharing, just a minute. Yeah. So I'll be discussing on one of the not very common complication during a lenticle extraction for a very experienced surgeon, but it does happen in the novice and the beginner surgeons. That is the cap perforation during the keratolenticular extraction surgery. So a 21-year-old female came to our OPD for the refractive surgery Her best corrected visual acuity in the right eye with -6 sphere and -1 cylinder was 6.6, and in the left eye with -6 sphere and -1.25 cylinder was 6.6. The slit lamp examination, fundus examination, both the eyes was within normal limits. So we had proceeded for a topography scan. So this was the topography in the right eye, and this was a topography in the left eye. As we can see, it was a very fairly thick cornea of around 573 microns, since we had to correct around -6 of the sphere. So it's an absolute C-green topography with symmetrical bow tie. So we had proceeded for a clear procedure on Z8 platform, that is corneal lenticular extraction for the advanced refractive surgery. So just to brief out a little bit on the planning, since the thickness was around 573 microns, but I had to correct around -6 of the sphere, I had kept the 6 mm optic zone. I have yet till now not taken any cap thickness less than 110 microns. So to say, in just 1 or 2 patients, I may have gone up to 105 microns, but generally I have not gone below 110 microns for the cap thickness. Rest all the residual stromal bed and the percentage tissue altered. Everything was taken care of to avoid any post-operative complications. And a power setting of anterior dissection I had kept on 32%, and the posterior dissection I had kept on 36%. The right eye dissection went off absolutely uneventful. The post-operative vision was 6.6. However, in the left eye, now during the initial stages, so the surgeon who had started with it, he first had made the plane very nicely. It is not visible, but he is making the anterior and the posterior plane separately. Now he had started and chosen the thick blunt instrument to go for the anterior lenticular dissection. Now when he started, it went off very nice at the lateral aspect. But as he was proceeding absolutely at the center, there was a eyelid or a discrete black spots. But still he went on and he had caused a cap perforation straight at the pupillary margin. Now here comes the crux. If in a novice surgeon, better not to proceed or better to convert it later. But I had gone with a thin blunt instrument, which I had preferred in all my cases previously also. And then I started dissecting on the other aspect of the cap first, because I wanted a little free hand on the other side. So the main crux while managing a cap perforation is to go over and above the perforation. And make sure that you don't increase the already existing cap perforation. So the dissection maneuver, as I have started on that side, was similar as what we do during the SICS tunnel formation. That is a very smooth, very careful and very slight dissection piece by piece on the side where I feel there was less or incomplete laser pass or the discrete black spot was there. But eventually I was very successful to completely dissect the anterior part without increasing the cap perforation. Already the size of the cap perforation and the anterior lenticular dissection went off very well. However, and the same, I had followed the standard protocol what we follow for the posterior dissection. That is, I went on for the central first, but I was facing the same challenge where the laser was not completely passed at the pupillary margin, and so had followed the same maneuver of slowly and very meticulously gentle dissection at the part where the dissection had not happened. So once if we feel that that part is not the laser is not completely passed, it's better to have counter traction on both the sides. So I've kept the counter traction on the left and the right side as well, and then started dissecting on that part of the posterior lenticular dissection. And finally, I was successful in a complete dissection. And then finally, the lenticule was removed. It's very important and always to check, and I have checked the integrity of the lenticule. It was compact. Completely fine. However, there was finally as I had gone for the interface wash. I could see that that perforation was there. It was very slight, so I just with the cannula had made it a little smoother, and finally I had kept a contact lens. So this was the post-op day 1. So this picture is not very good, but still there was sterile infiltration at the side where the cap perforation was there. So it was healing very well on that side, even though the post-operative vision was not 6.6. And here is the main thing, that the counseling is very important in these patients because they do expect 6.6 post-operatively, but we have to explain them very nicely that the contact lens has been put, and once it heals, we'll remove it. So post-op 1 week, It was healed well with a very faint scar with 6 parts vision. Patient had absolutely no complaints. So cap perforation happens due to excessive manipulation of the anterior lenticular dissection. The incidence varies from 0.25 to 4.38%, and it depends absolutely on the experience of the surgeon. The etiology mainly remains because of the use of the sharp instrument or a thick blunt instrument, and it is always preferable to have a gentle dissection with a thin blunt instrument. The management remains conservative, and it generally heals with minimal scarring and little impact on the visual outcomes. Thank you.
Thank you, Dr. Neha. Just a quick comment, a light comment by Dr. Vardhaman for both the cases.
Yeah, thank you, Dr. Natasha. So I think in the first case, of course, we had a fully formed lenticule. So the approach is, how are you going to remove the lenticule? The approach can be in the form of, there have been reports where people have actually gone ahead and created actually a small incision with even a blade and gone to that depth and done the dissection. Of course, one can use the circle to create a full flap. But in this case, because the patient was athlete, the most important thing was to retain the flapless nature of the procedure. Therefore, this small incision was designed with circle. And fortunately, the patient has done very well. There is another choice which can be done. This is called as a surgeon-induced suction loss. That means that when actually you start to understand that there is conjunctiva sipping in, one can actually cause a deliberate suction loss by the surgeon, in which you can again come back, redock, and start it like a normal smile. But in this case, it happened too fast to do that approach. In the second case, very well managed by Dr. Neha. Of course, the most important thing is to be very gentle. What I've realized that in this case, the cornea was very thick actually. The cornea was almost, I think, 575, 80 micron, and the cap was 110 micron. Maybe in these cases, I would prefer to have a slightly thicker cap, especially if it is a beginning surgeon, maybe about 120 micron, so that you have slightly more room, and of course, be gentle. Of course, all such things can happen in the early phase of learning, especially for all the KLEX cases, whether it is smile or clear. But I think very well managed as well. So I think because of the void of time, I think we can probably progress. Yes. Thank you again, Natasha. Thank you.
Thank you, Dr. Vardhaman. I think we'll hand over the session to the next session. And thank you everyone for being a part of it and for the wonderful discussion. It was a good morning breakfast for the brain. Thank you.
Thank you, Natasha and Zain, for this beautifully conducted session. Thank you, everyone. With this, we start the next session, which is Dilemmas in Cornea. So requesting Dr. Swapnil Balekar and Dr. Mahesh Sonpekar to please take the session forward.
Hello, good morning to all. Audible?
Hi, Mahesh, go ahead, please.
Hello. Good morning and a warm welcome to all the esteemed faculty, delegates, and participants to this vibrant session on dilemmas in cornea. For the session, we have with us MOS President Dr. Shirish Thorat, MOS Secretary Dr. Viral Shah, Chairman Scientific Committee Dr. Piyush Bansal, Secretary Scientific Committee Dr. Sumit Lahane, and all the respected members of Scientific Committee. Me, along with Dr. Swapnil Balekar, will be moderating, and for session we have a dynamic cornea specialist as the chairperson, Dr. Sandeep Pawar, and Dr. Parul Deshpande. So without wasting much time, we'll head towards our session. I request all the speakers and panelists to respect their time allotted to them. So first, Dr. Asra Salia, if she's there, I would like to request her to speak on the topic, unusual sterile infiltrate following uneventful collagen cross-linking. And the expert panelists for this are Dr. Vinay Agrawal and Ashish Agrawal. Dr. Asra.
Yes, sir. Good morning, sir.
Please share your screen.
Doctor, can you please also start your camera?
Sure, sir. Can you hear me? Am I audible?
Yes, please go ahead.
Good morning, one and all. I'm presenting a case that truly tested me emotionally as well as clinically, titled Unusual Sterile Infiltrate Following Uneventful Collagen Cross-Linking. A 19-year-old female with documented progressive keratoconus with no other ocular history or any systemic illness underwent uneventful epi of CXL with accelerated protocol in left eye. BCL was placed at the end of the surgery. Eye was patched and patient was sent home. She followed up the next day with mild symptom which was expected due to epithelial defect. BCL was still in situ. Patient was advised fluorometholone, moxifloxacin and lubricating topically. She came back on post-op day 5 with mild symptoms. She seemed absolutely fine. There was only pinpoint residual epithelial defect, which was, I thought it would heal on its own, and BCL was removed and medication continued. She was advised to follow up after 7 days. However, she returned on immediate next day with history of severe pain, watering. There was large 4 mm epithelial defect, congestion, lid edema. She was very panicky. I continued the same treatment, thinking that epithelial defect might have increased due to rubbing, that healing epithelial defect might have increased due to rubbing. But the symptom did not resolve. She came back on post-op day 8 with symptom worsened. Visual acuity was finger counting 2 meter, and that epithelial defect now progressed to infiltrate in that eye in following days. I discontinued the steroid, sent corneal scraping. The stain was negative, and I started her on broad spectrum topical and oral antibiotics. There was no response on post-op day 10. So my dilemma started whether it is infective or sterile. As the patient worsened on the steroid, I thought it was infective, but the stopping of steroid did not respond. That's pointing towards sterile. Then I thought the culture is negative. It has to be infective. It has to be sterile. But there was no presence of any history of blepharitis, history of hypersensitivity reaction, history of any autoimmune disease. Then I again shifted towards infective, but the culture was negative and there was no sign of any discharge or hypopia. Again, I pointed towards sterile. But the sterile infiltrates are usually peripheral or mid-peripheral. They are they are ring shaped. So I thought it is infective, and the dilemma did not end there. On post-op day 14, I discussed the case with my senior, my mentor, and we started her on insulin, topical insulin drops, 1 international unit per ml. And magically the epithelial defect healed. Infiltrate was still persistent. So I had to remove the big guns. I started her on oral steroid. There was rapid dramatic improvement in symptoms as well as clinically. Gradually we added topical steroid, that is loteprednol soft steroid, 4 times a day. There was significant clinical improvement. The infiltrate began to heal. There was scarring. And finally, after 1.5 and 2 months, there was complete scarring. There was central corneal scar. The vision was still 6/12 unaided due to keratometric flattening. She recovered without any surgical intervention. That was the most important thing for me. The challenges were whether to stop or continue steroid early on, whether to reapply BCL or allow natural healing, judging the right movement to introduce insulin drops, steroid or any other alternative treatment, when to restart steroid without risking worsening of infection. And what truly helped me in this case was careful observation and close follow-up, senior consultation and broad-minded approach, and not rushing to surgical intervention. The conclusion is this case highlights the importance of clinical judgment over blind protocol, thinking beyond infection when cultures are sterile, and being open to unconventional but safe options like topical insulin, individualizing treatment in corneal healing disorders. And when the infiltrate doesn't defy the rules and the response of protocol, what would you choose? Evidence, instinct, experience. Thank you.
Thank you, Dr. Asra, for excellent case. I would request expert panel to comment on this, their views. Dr. Ashish and Dr. Vinay.
Dr. Ashish there?
Yeah, Dr. Vinay, please go ahead with your comment, maybe.
Sure. Dr. Asra, there are a couple of things which I have observed over the years. I have stopped using bandage contact lenses, at least in my setup, because my impression is that the bandage contact lens occasionally creates more problems than it solves. And the second thing is, why did you use a bandage contact lens when you were using a pad on the day 1?
I usually patch on the day 1 and I keep the BCL for 5 days because patient is quite apprehensive and quite the pain is there
So
because of large epithelial defect.
I would choose either one of the two, Because when you are using a bandage lens, as it is, you're reducing the oxygen supply. On top of that, when you put a pad, you're causing a further depletion of oxygen. So both those things may not be the best interest. And sterile infiltrates can also occur if the machine has not been calibrated appropriately. So that is something which we should keep in mind because of the huge amount of keratocyte loss which occurs with these procedures. Sterile infiltrates can occur. So proper calibration and focusing of the machine is something which I am really almost paranoid about in C3R. Other than that, you've managed very well. Scar is bound to be there if the epithelial defect and the infiltrate last beyond the 24 to 48 hour period, which you could not have avoided. But these are the two things I have learned over the years in my practice, and I implement them.
I agree with you, sir, with regards to. Hello.
Yeah.
Am I audible?
Please go ahead. Yeah, please go ahead.
I agree with sir that there was no need of patching. Either you do PCL placement or patching. That will increase the placement is not patched, and the PCL is applied. You immediately start giving the patient antibiotic and the steroid combination as soon as the CXL is done. And second point that I want to highlight is the presence of antibiotic priorly started. If the thickness was low, then you can have more sterile infiltrate as compared to the full thickness that we normally expect, that is more than 400 microns in a classical setting of a Brazilian protocol or an accelerated protocol.
Can I comment something?
Yes, ma'am.
Yeah. So one thing I wanted to ask the doctor, what kind of broad spectrum antibiotics have she used? Because if you see the literature, in patients who undergo CXL, normally they don't respond to levofloxacin or, our fluoroquinolones. So when you are resorting to any antibiotics and you're
On
not
day
getting a
one,
response. No, I'm saying
on
when
day
you
one,
have. Yeah, tell me.
On day one, she was put on moxifloxacin, and on day 8, when there was the defect and infiltrate, she was put on moxifloxacin plus Ocupol and tobramycin.
So that's what I'm saying. So you need basically a fortified antibiotics when you realize in 48 hours that the patient had infiltrate. Okay. Look at the presentation, it's central. When you look at the infiltrates which are in the peripheral, you probably may think that there is a component of more of inflammation than infection. Now, another thing which you should look at is that if you have scraped and you're not getting any organisms, and second thing, the patient was already on steroids, right, from the day one.
Yes.
And he was still having an infiltrate. So you have to give a benefit of doubt to infection first before you really jump to steroids. Second thing is, if in patients with CXA, you will see a lot of inflammation. You'll see the cornea melts away, even if it's a patient with infection or inflammation. So you have to add steroids very fast if you want a scar to be less. So within 48 hours of your antibiotics, okay, you need to start these patients on steroids. Then only you will get the inflammation down and you will see the scar to be less. And another thing which you should look at is the lids. Okay, so if you find that if you are going back and seeing these patients, look at the lids. If the lids are not very healthy, okay, that's it. Yeah.
Thank you.
Thank you. So, Dr. Asra, what I feel is this is more of immune-mediated keratitis secondary to the apoptotic debris, which is created by the UV rays. So probably I agree with Dr. Parul that you should have continued steroids and treated inflammation more than the infection when you had the corneal scraping negative. So that was an excellent case. Any other comments from the expert panelist, or we can move ahead with the next case?
There's just one thing I would like to share with everybody that, we shouldn't take cross-linking as a casual procedure. And I would do the same care I would for a cataract or any procedure with proper pre-op preparation of antibiotic drops 1 day prior, proper proper preparing of the eye, proper draping. And, we always keep the patient in for an hour or two and we must see him the next day. There are a lot of patients, a lot of surgeons who get patients referred from outstation and they send them back to the referring surgeon. And I would think it's the onus of the surgeon to see the patient at 24 hours so that we can pick up complications. That's all.
Previously, I used to say that to the patient that this is the safest procedure. I no longer say this sentence. I tell them all the complications of CXL.
In fact, the bottom line is that
Yeah.
CXL is treated very casually by our community, which is absolutely an incorrect approach.
Yes.
I would like to add one quick point.
I think we should wind up and go for the next session in the interest of time. Thank you, everyone. Yeah, so may I invite Dr. Saili to present the next case, that is case of an unusual microbial keratitis in a child. Dr. Saili, you're there. Can you please share
Yes.
your screen?
Yes, I'm sharing. Am I
Full
audible?
screen.
Yeah,
Yeah, you're audible. Please go ahead.
Yeah, so good morning, everyone. So today I'm presenting a case of an uninvited microbe in a child. Essentially is a infectious keratitis in a child. So he's a 8-year-old boy presented to me with a complaint of redness, watering, and photophobia in the right eye since 7 days. The parents also had noticed a whitish haze developing in the black part of the eye with blurred vision since last 3-4 days. He gave a history of accidental splash of muddy water in the right eye while playing few days back. So he had consulted 2 ophthalmologists before and was started on moxifloxacin eye drops 4 times per day and a combination of tobramycin and dexamethasone 3 times per day. The second consultation, he was shifted from tobramycin and dexamethasone to fluorometholone and tobramycin combination. But the parents had not noticed any improvement with the current treatment. There was no history of any similar episodes in the past. Patient is a spectacle user for last 3 years with a myopic refractive error and has good vision in both eyes, had good vision in both eyes. There is no other systemic illness. So at presentation, the left eye was absolutely normal with glasses vision was 6.6 and N6. In the right eye, the visual acuity was counting fingers 3 meters, not improving with pinhole. There was eyelid edema, ciliary congestion. There was a corneal infiltrate and an epithelial defect. The anterior chamber had hypopion, which was less than 1 millimeter. The retina was hazily seen, but it appeared attached. So if we see the corneal infiltrate, it is a grayish-white looking, sort of a ring-shaped infiltrate in the central cornea, extending up to anterior to mid-stromal level. And also there was an epithelial defect. We can also see the hypopion here. So let us just briefly discuss different type of ring infiltrates which are described in infectious keratitis cases, and they along with some other signs, they give us clues about the underlying etiology. So the first one here is a very dense looking infiltrate with a lot of discharge, which are typically seen in Pseudomonas keratitis. The second one is a whitish looking ring infiltrate with hyphate edges, a dry appearance suggestive of fungus. The third one is again a grayish white looking infiltrate with a lot of diffuse epitheliopathy, a hypopion, can be seen in acanthamoeba commonly. This kind of ring infiltrate is having a lot of pinhead size superficial infiltrates in a wreath pattern. These type of infiltrates are seen in nocardia. And this is a very, very subtle, faint stromal infiltration, typically seen in immune-mediated HSV keratitis. So coming back to our case, this infiltrate was more like a whitish, dry-looking infiltrate, though at this point of time, my differential diagnosis was acanthamoeba or fungal. After looking more carefully in the peripheral cornea, I could see these linear intrastromal infiltrations along the corneal nerves, and they were more like the typically described lesions of radial keratoneuritis. So combining all the findings, grayish ring infiltrate with the radial keratoneuritis and exposure to dirty water, I was strongly suspecting acanthamoeba keratitis. So as a first step, I discontinued the steroid-containing eye drops. I immediately advised corneal scraping for direct microscopy and culture because though we had a strong suspicion, we needed to establish the diagnosis. I preferred to refer the patient to a tertiary center with a well-equipped microbiology lab and availability of an in vivo confocal microscopy in case required. So the next day itself, the patient underwent corneal scraping, and the scraping material was also sent for culture, including non-nutrient agar with E. coli overlay, which is a typical culture medium used for getting acanthamoeba growth. So on the gram stain, we saw a double-walled cyst with an internal hexagonal sort of shape. It is strongly suggestive of acanthamoeba. So acanthamoeba are free-living amoebae. They mainly are found in two forms: trophozoites, which are responsible for active infection, and cyst form, which are dormant forms, and they are responsible for persistent infections because they are very resistant to any form of treatment. So the most common risk factor in Western literature is contact lens wear with poor lens hygiene practices. But in Indian scenario, the most common risk factors are exposure to contaminated water and soil along with trauma. So this is a very well-described clinical profile of a typical case of acanthamoeba keratitis from an article from Dr. Dart, where he describes pain disproportionate to corneal signs as a peculiar finding in acanthamoeba keratitis. Early signs are very subtle in the form of punctate epithelial keratitis, epithelial irregularity, and these perineural infiltrations. Limbitis can be present in both early and late. In the late presentations, we see a fully established ring infiltrate along with a large epithelial defect. But all these findings are not really seen in Indian studies, and the typical findings of pain, radial keratoneuritis, ring infiltrate are seen in a minority of cases. So this is where I would like to highlight the dilemma in this case. So my case was a typical picture, textbook picture of acanthamoeba keratitis. But in Indian studies, what has been found is that these very diffuse infiltrative lesions, very non-specific nummular patchy infiltrates, epithelial
Can we wind up quickly?
Yeah, epithelial defects and diffuse infiltrative keratitis are the non-classical features which are often misdiagnosed as HSV and fungal keratitis. So we started the patient on a typical regimen of 0.02% polyhexamethylene biguanide and 0.02% chlorhexidine along with atropine sulfate. So the patient was followed up over next 1 month, where he was showing progressive improvement in the density of infiltrate and progressive scarring. There was some improvement in the visual acuity. At his 2 weeks follow-up, he showed severe burning sensation, watering, which was suggestive of drug toxicity because frequent usage of these drugs. At that follow-up, the frequency of the drugs was reduced to 8 times. At the last follow-up, we were starting to observe a deep vascularization in 1 clock hour. So typically, we plan to continue the anti-acanthamoeba treatment for till the entire lesion completely scars, and also continue it 3 to 4 weeks beyond that time. So challenges in this case, as I described, drug toxicity, where we need to reduce the frequency and give a drug holiday if required. The next challenge would be inflammatory component of the infection, which will start developing now in the form of deep vascularization and scarring. So here I would like to take opinion on whether there is any role of topical steroid. And also because it's a child, there will be a lot of scarring in the visual axis, and we will eventually have to think of visual rehabilitation. And also we have to consider chances of recurrences. So take home message from this case is, though it is a very uncommon infection, we have to have a high index of suspicion, because early diagnosis is a good indicator for good visual outcome. Classic findings are not common in Indian patients. So we have
to stop.
Yeah.
Yeah.
Yes.
Can you end your screen share? Let's have a quick discussion.
Yeah.
It is not a didactic thing. We keep very little time for case and keep more time for discussion, please.
All right.
May I request Dr. Bhupesh and Dr. Namrata to comment on this quickly, please?
Nice case. So the only comment is any early corneal ring infiltrate with compromised epithelium should be always treated as infectious unless it is proven otherwise. And starting steroids early can sometimes lead to major loss of eye also. So in acanthamoeba, definitely we can start steroid, but after like few weeks of anti-amoebic therapy. So that should be actually followed. So regarding steroids, we can discuss with our other expert panels.
Dr. Namrata?
Very nicely managed case. I would congratulate you for this because this is especially a pediatric patient. And thank you for highlighting two most important scenarios and presentations in Indian perspective. One is we don't have typically the book line of contact lens usages histories. And the second one is pain is usually not out of proportion. Probably our pain tolerance and threshold is way different than Western world. And along this line, I would also like to just give a quick overview of new treatments for acanthamoeba keratitis, especially the one which is being published from LVPEI group, that is photodynamic treatment with rose Bengal therapy. Typically they give 2 sessions, and the efficacy in initial study, what they have presented, Dr. Bhupesh Baga and et al., the group, is 86%, and they have claimed that it has reduced the need for PKP by 28%. So that is something new in our armamentarium. Then nanoparticles and nanoparticle formulation of PHMB will improve the penetration, and couple of studies have been published. Along with that, PHMB impregnated contact lenses and very refractive cases, one anti-leishmanial therapy, that is miltefosine. That drug is also being used, but of course it has its own toxicity, GI toxicity and inflammation. So it is reserved only for refractory cases. Thank you. Thank you so much for putting up that slide of differential diagnosis for ring infiltrate. That was very perfect.
Thank you, Dr. Amrita. Thank you, Dr. Saili, for an excellent case. We'll move on to the next case by Dr. Nikhil Toshniwal, the case of dry eye with a dilemma. Dr. Nikhil, can you please share your screen?
Thank you, sir. Yes, sir.
I would request you to please restrict, within the time limit.
Sure, sir. Sure, sir.
Yeah, thank you.
Is it visible, sir?
Yeah, it is visible. Go ahead.
Yeah. Good morning, one and all. I am Dr. Nikhil Toshniwal from Solapur. I'll be presenting my case of dry eye saga, one case and many dilemmas. So I had a 68-year-old female with dryness, redness, and diminution of vision for 1 year on and off. And she had multiple of these attacks. She was both a 10 years ago and currently on many AG, more than 660 even with pinhole. Apparently she could reach 660 binocularly. IOP was 28 and 30. On clinical presentation, when I saw the Schirmer values were 5 and 6, not very low. As we can see in the picture also, the inflammation is the mainstay thing which we can see as a clinical picture. Both eye puncta were open and staining was positive, TB was instantaneous. Mild thickening of the lids may be due to the medicamentosa of multiple AGMs and other drugs. And inflammation was severe, as I told, and cornea, especially the left eye cornea, had the scarring and the vascularization. Also, when we went ahead to see no fornical shortening or obvious keratinization, rest anterior segment was within normal limit, and fundus was hazy except for the cupping. There was no other abnormality detected. She had no systemic illness. So many dilemmas and many things had to be tackled together. It was a glaucoma management, chronic presentation, the inflammation, many drug cocktails she had been using, about a vision potential, and dry eye treatment. And what about the diagnosis? So I had to work on multiple factors as per the this case was concerned. So for IOP management, we had shifted immediately on all preservative-free drops. Oral acetazolamide was given for temporary IOP control. And a few months later, we planned both eye trabeculectomy. IOP was marginally controlled, but finally SLT was performed for better IOP control, and IOP is now well within in control. On second zone, when we for diagnosis, no history of joint pain, mouth pain. Sjogren's panels was almost negative except for the raised CRP. Biopsy was performed. OCP was positive for this patient. Then I referred her to rheumatologist and oral treatment was started. To start with, he started with methotrexate and oral steroids and tapering dose. Currently, patient is on mycophenolate, mofetil and tapering doses. And of course, the topical treatment had to be managed. So this was a big hurdle. Since recurrent episodes, preservative-free lubricants was my first choice. I stopped all other lubricants. Tried preservative-free cyclosporine, worked for literally few days, maybe 2 to 3 weeks, but later dryness persisted and so the inflammation. Then some magical drug came to my rescue. Blood is thicker than water and her own blood saved her. It was autologous serum eye drops, which I used for her. And she's currently maintaining 8 months on this autologous serum eye drops and no severe dryness or inflammation episode later on. The last part remained was vision. The vision, she's currently using sclerals. Right eye reasonably 618 and left eye reasonably 636. And with her plus 2.50 additional correction, she's reading till N8. And she's very happy. She's one patient with amazing follow-up and she had that urge to see well. And this was my take on this case of the OCP with recurrent inflammation and dryness. One dilemma I still have in my mind, and she's currently maintained on mycophenolate mofetil, 500 milligram, one in the morning and one in the night, with oral methotrexate 12.5 OD, and all blood parameters well within control. One dilemma, I could have done punctal cautery or punctal plugs, but since eyes were quite moist, not as moist as normal eyes, but moderately, so I didn't go ahead with her. So I would definitely want experts and all panelists' opinion on this. Thank you so much.
Thank you, Dr. Nikhil. That was an excellent case.
Thank you, sir.
May I invite the expert panel to comment on this? Dr. Shruti and Dr. Ketki, please. Dr. Shruti? Yeah. Please go ahead. Meanwhile, Dr. Nikhil, I feel is that being this is a case of OCP, the dose of immunosuppression you have given may not be very adequate. You know, the methotrexate 12.5 with MMP 500 BD, I feel it's slightly, not, you should be a little bit aggressive for as far as OCP is concerned.
So that's a current maintenance dose. Initially, she would started with oral tapering dose and mycophenolate mofetil, two tablets in the morning and 2 in the night, along with methotrexate. Current maintenance dose since last 6 months is this one.
Right.
Yeah, thank you.
And you should consider punctal cautery.
Yeah.
Yes, that's what. Punctal cautery. Yes, yes. Punctal cautery, very well, nicely managed case, Dr. Nikhil. Definitely, I should say. Punctal cautery, and though cyclosporine has shown a limited result, I feel you should continue it for the like 0.09% cyclosporine.
Yes,
topical drop should be continued for the long-term therapy.
Sure, ma'am. Thank you.
And for fundus examination follow-up for the methotrexate toxicity along with the.
Yes, ma'am.
Any comment by chairpersons?
Are you continuing the autologous serum drops with the scleral lens?
Yes,
I
ma'am.
had
But
2 questions. Yeah.
yes, ma'am. So yes, I am continuing 3 times daily. But when she takes a not over the scleral lens, of course, before and in between and later, like she's taking 2 naps of 4 hours of scleral lens used, and she started sclerals 1.5 months ago, ma'am.
Also, would the scleral lens affect? She underwent trabeculectomy as well, right?
Yes, ma'am.
So does placing the contact lens, scleral lens, affect the filtration in any way?
Ma'am, actually, research does say 2 opinions. 2 mm rays of IOP is always there with scleral lenses, few of the studies say. The second case, since I managed this and her IOP currently is 13, 14 with whatever, and her urge to see little more better with even that glaucomatous cup, I told her that 14 to 16 something else. And then IOP was very well controlled on post SLT for 4 to 5 months when I observed it was 12 to 14 wearing. So scleral lens with that double-edged sword risk, I started her on.
Nikhil, very well managed case, you know.
Thank you, ma'am.
I just want to highlight the cases of pseudo OCPs. Now, your patient did have an OCP, but with most of the AGMs, we see pseudo OCP-like features. And the way you have managed glaucoma, so getting oral medications, going to SLT, because I think it's an underestimated procedure. But in these patients who have an ocular surface disease, I think we need to resort to SLT so that we could reduce the medications as much as possible. Because we know that trabeculectomy in the immediate period is not going to work, and we need to control the patients with glaucoma. And my take on punctal cautery and other things, yeah, if it's a patient with OCP and you're seeing a dryness, definitely. But otherwise, the cases that I have managed of pseudo OCPs, I have not really taken those patients for punctal cautery. Really, you need it because they have good tears. What was
Yes,
problem was
ma'am.
the inflammation, not the tears. Yeah.
I was sitting on bark that it wasn't very severe dry eye, so punctal cautery could have been the suggestion, but then that's why I stopped for doing it.
Yeah.
Very good point to rule out pseudo OCP. I would just like to add, even gliptins or history of diabetes and what
Yeah.
anti-diabetics patient is on needs to be checked because gliptins are known to present like pseudo OCP.
Yes, ma'am.
Thank you, Dr. Nikhil and
Thank
all
you,
the
sir.
panelists. Shall we move on to the next case? Dilemma in the use of BCL management, healing or harming by Dr. Viral Rathod. Dr. Rathod, you are there? Dr. Rathod, could you please share your screen? Dr. Viram Rathod. I think we are not able to reach him. We'll move on to the next case by Dr. Harshvardhan Ghurpade about neurotrophic cornea. Dr. Harshvardhan, could you please share your screen? Dr. Harshvardhan, Dr. Rathod, anyone is there? Yeah. Thank you, Dr. Harshvardhan.
Can you hear me?
Yeah, please go ahead.
Yeah. So this is a case of herpes simplex keratitis, which turned out to be more of a neurotrophic
Can you
case.
just make it in screen share mode, please? Full screen mode. Thank you.
It's not full screen.
Go ahead now.
Is it full screen now? Okay. So this case was more of a neurotrophic rather than a turned out to be neurotrophic later on, and therefore we had to manage it differently. No financial interest, thanks to Dr. Morekar, who started all at our center very years back. And a 70-year-old female with recurrent HSV infections. Last episode was about 6 months ago. She came back with another episode with scarring and central infiltrate and ulceration. Diagnosed as recurrence of HSV, started on acivir, ointment and drops, tablets, along with antibiotic drops. Went on for almost more than a month of treatment that did not subside, and the ulcer progressed and became geographic. And then she was referred to us because it was not healing. We saw large ulcer with rolled over edges, corneal edema, central opacity, thinning. Scrapings were negative for bacteria and fungus. Corneal sensations were tested and they were found to be around 0 on esthesiometry. As it progressed further, it went into a large corneal melt and a flat anterior chamber, and ultimately the vision dropped to PL from 618, which was before the episode. So we diagnosed it as neurotrophic keratopathy grade 3, sorry, not 4, 3. And due to not only viral, but as well as diabetes probably. And element of neurotrophism was there, and therefore it complicated a recurrent HSV infection. So the method that we applied was, we thought about initially tarsorrhaphy and Tentinon's patch graft and other things, but we thought that if there is neurotrophism, it's not going to work anyways. And there was a melt and we had to do something about it. So tectonic graft was planned along with the sural nerve transplant. We needed a longer nerve because it had to cover all the 4 quadrants. All 4 quadrants were having neurotrophism. So we also took this ipsilateral side because in HSV, usually the ipsilateral forehead is spared as compared to HZV, where the ipsilateral forehead is also involved. So we have to take the opposite side. Because it was perforated, we had to do give tectonic support. So we decided a combined procedure, a therapeutic PK with sural nerve transplant. And the sural nerve was being harvested. At that same time, a therapeutic PK was being performed. And when the nerve was harvested after the PK, we did the nerve grafting. And this is just a small video where we remove this sural nerve from the middle cutaneous branch of the nerve of the foot, and this is the surgery where the nerve is now just being pushed below the eyelid through the conjunctiva. End to side anastomosis is being performed with the supratrochlear nerve of the ipsilateral side, and the remaining nerve is now brought below and made into small fascicles, which are then placed under the conjunctiva in all 4 or 5 quadrants wherever is possible. Now we make small scleral tunnels go up to the limbus to place it, and then after that we used to suture them also. Some people use glue also now. Both are okay. And then after that, once that is done, we just close the wound. So this is a very nice procedure because it's not very expensive. It's a definitive treatment, and we saw the ulcer started healing well. The PK was there. The nerve started growing. Some evidence of it on confocal, on OCT, and then the epithelial defect, which was large, then slowly healed over a period of 2 months. The sensations also started improving after 2 months, and by 3 to 6 months, we had almost 50 stoichiometry score, which is quite good. And there was no further thinning and perforation after 1 year. And we obviously kept her on Asivir because it's a herpes, it can recur anytime. But then the neurotrophism was treated well. And these are the scores over a period of 6 months. So main thing about sural nerve transplant is the stem cell recovery. The stem cells of limbal stem cell need nerves to grow. And if you don't have nerves, they will not grow and then lead to a large defect and melts. So this is one important paper which we saw where it says that for stem cell progenitor cells on the ocular surface, innervation is most important. And there's another factor called as VEGF-B, which is important for neurotization or neoneuralization. So VEGF-A is important for neovascularization. So when the VEGF-B goes down, the vascularization increases. But when the VEGF-B goes back higher, then the VEGF-A goes down. And therefore, you see the vascularization of the cornea also reduces over time after neurotization. And the cornea clears on its own many times. And some say nerves also regenerate spontaneously, but this paper shows that even after many months of HSV infection, the nerves do not recover as much, and the sensations definitely not. So neurotization is a good management for such cases, apart from the regular treatments. And
Harsh, can you please wind up?
Yeah, we're just finishing. I'm finishing. So it's a definitive treatment as is seen, and we have nerve growth factors also available, but they are quite expensive, and various studies have compared well with our cases. And this was one of our cases presented in 2015. And in conclusion, good recovery, good corneal healing, neuroneuralization with VEGF-B plays a role, inhibits vascularization, good evidence on various things like confocal, immunological, genetic, endoscopic, and robotic neurotization is something that we have started now, and it has better results because of less inflammation. Thank you so much.
Thank you, Harsh, for excellent case and excellent procedure. Expert panelists, please, your comments. Dr. Kunjal and Dr. Prerna.
Good morning. Dr. Harshvardhan, that was a very well documented and excellently managed case. And I know you've had previous experience also. I personally have had experience in only one case with Dr. Sunil Murekar for an unusual indication of neurotrophic keratitis following acanthamoeba keratitis, which is actually not yet reported. I just wanted to highlight a couple of things that, as you said, the sural nerve was used, and this is like an indirect neurotization. There are many groups internationally who are following the direct neurotization with the supraorbital or the supratrochlear nerve. Now, we don't have that many cases, worldwide to be able to know which direct or indirect is better. But I guess Dr. Sunil Murekar follows the indirect neurotization with the sural nerve most of the times. And it does give good results, of course. Just to emphasize that this should be taken up only, in the last stage, stage 3, stage 4, where you have tried everything and nothing really works. Patient should be on a good antiviral cover for a long time. And the case has to be in a very good setup where you have a good backup of a GA, along with a good anesthetist and, probably an ICU backup also. And your case was unusual because you had a perforation. So most of the cases in literature where the keratoplasty is performed at least a year after, having a good result and good renovation. But your case was different, and there are a couple of cases reported where simultaneously a PK and neurotization has been done. Though that's not a very common scenario, but that was an excellently managed case.
In fact, this first case which was done here was actually the same, the supratropical nerve itself was used. We did not use the sural nerve in this case. But the advantage of sural nerve is that it is a sensory nerve and it gives you a lot of options to cover many quadrants in the cornea and becomes very comfortable actually.
And you can get a very long segment,
Yes,
so you can cover everything well.
Yeah. Thank you.
Though you need a plasty surgeon. My case
No,
is
I mean, we have started doing it on our own. It's not that difficult.
Yeah,
You can
that's
have a general surgeon also.
That's
or you can do it yourself.
Dr. Wag has some comment to make. Ma'am, please.
Yeah, I was wondering whether it would work where the trigeminal nerve or the trigeminal ganglion itself is affected in conditions like HZO, or you have post neuro procedures, CP angle tumors, or sometimes radiofrequency ablation of the trigeminal for trigeminal neuralgia.
We use the contralateral side in such cases because usually it's only unilateral, most of these cases. And the contralateral nerve is easily used. It's not that difficult. You just go under the skin on the forehead and come on the other side. It's easily done, especially endoscopically. It's all the more easy and comfortable.
So you would just take a longer segment of the sheet.
Yeah.
I just have one comment. Harshvardhan, did you use insulin drops in these patients?
No. We did not
So
use
I think that would have been a little till the time your nerves actually
grow back.
Yeah, grow back. Insulin gives you a good backup to get the good epithelialization, faster epithelialization.
Yeah, so
And
insulin is a epithelial growth factor, not a nerve growth factor. So it does not recover the sensations. It only recovers the epithelium for that time, and then once you stop it, yes.
So that is what we want, because when you've done a grafting, you want the epithelium to be covered as fast as possible.
Correct. But then if the nerves are not there, the graft is going to fail after some time anyways. And
yeah. And what is the long-term success? Because I've had an experience with one child who had a neurotrophic cornea from early childhood, and the child was managed in Cooper Hospital later with neurotization. But I saw the patient having recurrence later on with the cornea going bad again. So I've been,
So the end-to-side anastomosis of the nerve has to be very elaborate. You have to dissect the sheath well, and it has to be connected well. And things most of the times it is done in a hurry, you end up scarring, and then it can fail.
Harsh, can we wind up quickly,
Yeah,
please?
I'm sure. I'm ready. I'm done.
We have one more case left for this session.
Okay, sure. Thank you.
Thank you. Yeah, Dr. Viram, could you please share your screen? She would be presenting about healing or harming BCL dilemma. Yeah. Dr. Viram.
Yes, sir.
Yeah.
So am I audible?
Yeah, you're audible, but your screen is not seen.
While you share your screen, you can start talking.
Yeah, Dr. Parul, as you pinpointed, recently I have managed similar case with Tenon patch graft and insulin. So those who don't have access to neurotization can also consider this option.
But the problem would be for visual rehabilitation later on. No, you cannot graft insensitive one.
Yeah. Yes. Dr. Viram, are you able to share your screen?
Yes, sir. Is it visible?
No, it is not.
Meanwhile, she's setting up. I do have one query. Is anyone amongst the group has experience with nerve growth factors, availability and cost?
No.
It's just
cost is around 10 lakhs.
Yeah, she has already. Yeah, so 10 lakhs, so no further comments. Yes, Dr. Viram, go ahead, please.
Full screen, please.
Good morning, everyone. Thank you for the opportunity. Myself, Dr. Viram Rajput from Cooper Hospital, and today I'm going to present on the. Sorry, not able to share it.
We can see the slides. Just continue. You can continue. We can see the slides.
Are you able to move your slides?
No, sir, not really.
Can you just summarize the case quickly verbally?
Yeah,
I mean,
now
just
it's
oral presentation.
Is it visible now?
No, now your screen is not visible.
Okay, you've stopped sharing, and once you've started, just click on the screen to move the slides. Just start again, reshare again, please.
Amrita ma'am is there. Amrita ma'am, you have her presentation.
I'm there. You may not be in a
Ma'am,
full
if you
screen.
have her presentation, you can just quickly summarize. So, and we can discuss on that.
Is it?
Just a second,
Yeah.
Dr. Rajput.
Yeah, don't go full screen then.
Let's
Go
go
for
to
full
the
screen
next slide. Go to the
Just a
next
sec,
slide.
just a sec, doctor.
Is it now?
Just go full screen, please. Slide
Yes.
share once.
Yes. So now it's visible?
Yes.
Yeah.
Yes.
Sorry
If you
for
can
the
make it.
inconvenience. Yes. Today's topic is healing or harming bandage contact lens induced worsening of corneal epithelial defect with infective sequelae, a case report. A 35-year-old female came with chief complaints of sudden diminution of vision with pain and redness in left eye since 3 days and watering photophobia since 1 day. She was apparently all right 3 days back, and she came with the complaint of diminution of vision and pain associated with watering and redness in her left eye. She had visited a local private clinic where a bandage contact lens was inserted after detecting a corneal epithelial defect. She was prescribed on topical moxifloxacin 0.5% and carboxymethylcellulose 0.5%. The patient reported progressive worsening of the symptoms, including intense foreign body sensation, increased pain, and photophobia since 1 day, and patient visited to our emergency for the same. Had no history of any contact lens use before. Patient is a pre-diabetic on dietary modification. No history of any ocular surgery in the past, and there was alleged history of trauma to her left eye by fingernail 2 months back. Personal history was not significant. General examination was within normal limit. The other eye, right eye, was within normal. Anterior segment was within normal limit, except for she had anterior blepharitis. The affected eye, left eye, visual acuity was 618, not improving with pinhole. Orbit and adnexa was within normal limit. There was late edema, anterior blepharitis, diffuse corneal congestion with diffuse conjunctival congestion with circumcorneal congestion, chemosis. BCL was in situ. On removal, there was the cornea was hazy. There was epithelial defect in the lower quadrant of size 4 by 5 mm, which was fluorescent stain positive with surrounding infiltrate and edema, and few defaults noted in the same region. Rest of the corneal thickness was within normal limit, and there was no vascularization and corneal sensations were intact. Anterior chamber shows +1 cells. Her posterior segment examination of both eyes were within normal limit. On investigating further, corneal scraping and bandage contact lens were sent for gram stain, KOH, and culture sensitivity. The gram stain turned out to be the gram-positive bacilli, and culture sensitivity reports suggestive of Pseudomonas. Our routine hematological parameters were within normal limit, except for our HbA1c was in the pre-diabetic range. The patient was started on intensive topical treatment with topical fortified amikacin 2.5% eye drops 1 hourly, topical ciprofloxacin 0.3% eye drops 1 hourly, topical carboxymethylcellulose 0.5% eye drops 1 hourly, and topical eye ointment atropine 1% 3 times a day. And simultaneously, she was treated for anterior blepharitis in her right eye. Patient symptoms gradually improved over a week. She is still under the treatment. Serial fluorescent staining showed progressive reduction in the epithelial defect size with the evidence of superficial corneal scarring. The dilemma in this case was the use of BCL appropriate at the initial visit. Did the benefits of the using BCL outweigh the risk, especially in the settings with no follow-up infrastructure and microbiological backup? Bandage contact lens can act as a double-edged sword, and there's a fine balance between therapeutic benefit and the potential iatrogenic harm. The pros are it promotes epithelial healing, provides pain relief, protection of regenerating epithelium, and no require of eye patching. But cons and concern are it acts as a nidus for the microbial colonization. It increases the risk with poor patient education and lack of follow-up. Epithelial defects following the trauma, especially due to vegetative and contaminated objects, to be ruled out first, and local and systemic factors for microbial infections are to be ruled out. The another question is the material type of the BCL. It can significantly impact the outcome. As per the literature, the high quality BCL have high decay, which decreases the risk of hypoxia and helps in the healing. The sterility is also ISO graded, and hence no such standards are mentioned in the low quality BCL. The infection risk increases here. Also, there are the literatures where the guidelines are provided for the safety profile for the use of the bandage contact lenses. But apart from using high quality bandage contact lens, cases of Pseudomonas keratitis has been reported. Hence, the risk factors are use of BCL in the presence of undiagnosed infections can be double-edged sword, compromised ocular surface, lid abnormalities, ROPLAS positive, systemic conditions like diabetes, prediabetes, immunocompromised, drug addiction, malnutrition, lack of follow-up or inadequate instruction to the patient, inadequate ocular hygiene, and improper drug compliance.
Dr. Viram,
Yes.
can we skip the didactic part and let panelists discuss those parts?
Yes, sir.
Okay? Yeah.
Yes.
Just wind up. Yeah.
Yes. On concluding, the case highlights the dual nature of the bandage contact lens, potentially healing or harmful depending on the clinical context and the management of the protocol. It underscores the necessity of BCL use should be individualized, not in routine and trauma infective cases. Always rule out predisposing factors causing microbial infection. Ensure strict aseptic techniques and patient follow-up post-BCL placement. Educate patient about signs of worsening and need for urgent re-evaluation. BCL should be used in caution with the patients with systemic comorbidities like diabetes and immunocompromised individuals. These are my references. Thank you.
Thank you so much, expert panelists, Dr. Amrita, Dr. Saurabh Mundada. Your comments, please. Also, Chairperson Dr. Wagh. Yeah.
Good morning, everyone, and thanks, Dr. Viram, for highlighting this common issue. Just 2 points I want to talk about. As Dr. Agarwal sir pointed in the very first case, that our threshold for BCL use must change now, and we should evaluate the patients before putting it for every second patient that comes to our clinic. Also, depending on moxifloxacin, like antibiotics, which have very high resistance because very rampant use by GPs is common. So patient with risk factors like, in your case, nephritis or patients with a ROPLAS or something like that, your BCL should be used with extreme caution and only when needed. Thank you.
I'm Dr. Saurabh. Basically, what you have pointed out is already there in slide, and we have noted in our practice, like the first aim of a general ophthalmologist is to give pain relief. So they don't think right and left, they just give BCL because the idea is to get a pain relief to the patient. Many times it backfires. And as you have mentioned, I just want to mention 2-3 points. Like in my setup, we don't give a BCL in the first visit. We don't give BCL if the patient is not ready to follow up within 2 to 3 days. If they say we are from far distance and we cannot come for a week, then it's better not to give. So if follow-up is not there in 2 to 3 days, we should not, we should avoid. Second thing is regarding Pseudomonas. As you have microbiological culture, so no doubt about it. What we have observed in Pseudomonas is basically we have 2 types of Pseudomonas. I'm just broad lining it, not going into deeper it. One which will respond excellently to treatment, particularly the contact lens induced Pseudomonas. And the seconds are the notorious one, basically the OT acquired Pseudomonas. They don't respond to anything, even if you go for a higher ups fortified. So in your case, directly jumping to fortified is not very well justified. You can simply start with tobramycin or normal amikacin nitrate rather than fortifying it, the ready-made available MTEC or something. So that will also help. They generally respond well to this type of Pseudomonas. So these are the 2 things I wanted to say.
Thank you. Dr. Wagh, any comment? Dr. Parul?
No, just that patients who are who get a bandage contact lens must be monitored, and I think, like Doctor said, we should see them at least at 24 hours. And also the way the BCL is placed, I mean, I've seen it in many clinics. They'll just wash their hands, take the lens and put it by hand. In our clinic, we always use sterile forceps to either place or remove a bandage contact lens. And instructions to a patient who has a bandage contact lens are the same, like to avoid water splashing and wear protective glasses. So I think these things can help to avoid an infection. And of course, we should avoid unnecessary use.
I think Sangeeta pointed a very good point, that use of forceps to put the lens and remove the lens. Same thing I think I follow. And I'm not very, I'm not pro bandage contact lenses in these cases, So I would avoid using BCLs most of the times.
A quick comment from my side. In this case, probably the only thing I would have differed on is probably I wouldn't have considered adding lubricant in the management. And if at all one is considering, then see to it the interval is good enough. Otherwise, it might dilute the concentration of antibiotics used.
Right.
Thank you.
Thank you, everyone. With this, we'll conclude the session. Thank you all the panelists, chairpersons, and especially scientific committee of MOS, Dr. Piyush, for this opportunity to these youngsters to present the cases. And it was an excellent session. Thank you, everyone, again, and we'll conclude the session.
Thank you, sir.
Thanks for
Thank
calling
you.
me.
Thank you, dear
Mr.
Dr. Swapnil Bhalekar and Dr. Mahesh Sonpetkar, especially to include the session within the stipulated 60 minutes allotted to the session. So thank you, everyone. It was a really marvelous session, I believe, of international standing. So with this, I'd like to welcome the moderators of the next session, which is going to be Dilemmas in Cataract. Dr. Amar Bhaskare will just be joining ASAP. Dr. Swapnil Kothari and our chairpersons, Dr. Sandeep Nagvekar and Dr. Satish Patil.
Thank you, and welcome to this session on dilemmas in cataract surgery. We will start with the session right away. I'll make a note to all the panelists that they have to stick strictly to time. It is going to be a 6-minute presentation followed by a 2-minute discussion. So without much further ado, let us start with the first cataract dilemma, case 1. I believe the speaker is going to be Dr. Vijaya Agarwala. Can she start her presentation, please? Dr. Vijaya Agarwala is here. I think she's not logged on. So can we take the next case? That is Dr. Ridhima Bhagli. Is she here?
Yes, yes.
Okay, ma'am. So can you start with your presentation? I believe you're going to speak on an interesting case of microspherophakia with a subluxated cataract. So
Can
please
you
go ahead.
screen, sir?
No, the screen is seen, but the
Start my
content is
video.
not visible.
Please start your video.
Yeah. So this is a case of microspherophakia with a subluxated lens. She's a 48-year-old female who came to me with a subluxated lens, and I had operated on her mother like 10 years back and done an SFIOL. But in her case, I wanted to save the bag. And my plan is to, I've started the Rexis, but as I start, I realize that it's difficult to proceed with no zonules. So I'm using capsular hooks to provide some kind of counter traction to assist. But as I proceed, I progressively add more and more hooks to aid with the Rexis. Another thing here is that the Rexis needs to be centered on the lens and not on the pupil. And now I'm, as you can see, completing the Rexis with the forceps. Once the Rexis is complete, all 4 hooks in place, I'm tightening the hooks and doing a regular hydro dissection and a hydro delineation. If the patient is young, we can just do an IA, I suppose, but in this case, I did a phacoemulsification. So my plan here is to fix the bag on both 2 ends with capsular tension segments, suture the segments to the sclera. And I have a plan B and C as well. But my first plan was I wanted to attempt a flange technique with the capsular tension segment. I had never done it before, but I had seen videos, read about it. And after my aspiration of the cortex, I decided to attempt the flange. So I have taken a 30 gauge needle and a 6-O-proline, and I'm seeing that it threads easily. And with the needle 2 mm from the limbus, I have introduced it and retrieved the 6-O-proline through the main wound. I want to do a flange on both sides. My plan was that I will thread the 6-O-proline through the eyelid of the CTS. And ideally, you should use a low temperature cautery so that this is controlled and precise. But I am using a ballpoint because that's what I had, and melting the suture to create a button. But as you can see here, like the more heat I apply, sometimes it, yeah, I'm checking that it's not going through the eyelid. More heat I apply, it starts melting and bending a little bit. But this was the best I had. I introduced the segment into the bag. The segment needs to be such that both arms are placed inside the bag, whereas the loop of the segment will wrap around the Rexis. But as you see, if I pull the suture, the flange has come out.
I've not edited out this part just to show that sometimes things don't go as planned when you're attempting in a complicated case. Now I'm getting the CTS out and I'm going to resort to my plan B, which is suturing the segment that I would have done conventionally. You can either do this through a Hoffman's pocket or make scleral flaps. I'm using double arm 9-O-Prolene suture, and I'm using a 26 gauge needle to retrieve both arms of the 9-O-Prolene from under the flap. This is the railroading technique, and I'm doing it for both the arms. This is the other arm of the straight needle of the 9-O-Prolene being retrieved from below the scleral flap. This is the Gupta segment. This is the Canabrava Gupta segment, which has a slightly larger loop, and I quite prefer it to the Ahmed segment because I feel like it's easier to ensure that the loop is over the rhexis. You need to ensure that it's properly in place before pulling and tightening and tying the knot under the scleral flap. I'm removing the hooks from that side and replicating the exact same technique with a new double arm 9-O-Prolene for the other side. I had just one Gupta segment available. I'm using the Ahmed segment on the other side, which you can see here in the video. Again, both arms have to go inside the bag and ensure that the loop is wrapping the rhexis, tying it, and then ending with a CTR so that the tension is equally distributed. And I've used a 3-piece IOL in this case so that if things don't work out, I can still do a scleral fixation of that IOL and then a closure of the case. So I think I'm done with my video. Any comments?
Thank you, Ridhima. That was an excellent presentation and so well executed this entire surgery. But I'm sure our expert panel will have something to say about it. So do we have Dr. Amok Joshi online, please? Dr. Amok Joshi? Nikhil, are you on? Nikhil, can you comment a few things about Ridhima's case and offer your expert comments there?
I think she handled it really, really well. This is a very difficult case to perform, and she handled it like a pro. There are so many things that could go very wrong over here. I like the tip that she said about using a not very hot cautery for that one particular step, because people tend to burn the sclera and it becomes very messy. So I had presented a similar case actually, where we had done a complete ICC and put an iris claw, because I'm an iris claw fan.
I've seen
So
that.
yeah.
It was very nicely done.
This was a different take, and yeah, I learned quite a bit from this.
Okay,
Congratulations. Did well.
One thing I'd like to ask you, Ridhima, was there, I didn't see any kind of a vitreous management over there. So,
no vitreous loss.
There was a considerable subluxation. Yes. So at that particular point, you mean the vitreous phase was intact?
It was intact throughout.
Did you?
At the end of
Yeah.
surgery,
Did you use?
I had put tricot to ensure, but there was no vitreous throughout the procedure, and that is why I wanted to actually save the bag. When sometimes it does get challenging, and our ego comes in the way when we want to save the bag, when it would just be easier to remove the entire lens to a sutured SFIL, but there was no vitreous here, sir.
Absolutely. Very, very well done. And this patient had significant cataract that prompted you to?
No, there wasn't.
So what was the indication for surgery? Because she managed 47 years of her life.
No, she had a gross subluxation in one eye and a slight subluxation in the other, but her visual quality was compromised. So because of the microspherophakia, she had a myopia about -9, -10. This was not myopic, but her best vision was about 6/18 because the lens had fallen down. So she had waited for a year and she had come all the way from Kerala fully prepared to get surgery done.
There was no glaucoma?
There was no glaucoma. And her other eye is still waiting. Like when this fully recovers, we'll plan the other when it's absolutely necessary. Currently, she's using a contact lens in the other eye.
At the end of the surgery, it looked fully recovered.
Yeah, it was fine.
Okay, thank you. Thank you so much, Ridhima, for that excellent talk. So do we have Dr. Nitin Deshpande online?
One small comment.
Yeah.
Yes, sir. Yeah. Since you failed that, since there was a failure to create the bulb, you could have just, created a knot, and that knot could have been used instead of a bulb. So instead of doing this, you could have just created a knot, and that knot would take care that it doesn't slip.
I have done a loop on the segment and done flanges on the sclera at 2 points is what I thought that would have been a better.
Instead of the flange, you just create a knot, and that knot takes care of the flange. And why didn't you put a CTR before putting the segments?
Because in my head, I feel like if I put the CTR before, then retrieving those 2 straight prolines without puncturing the bag becomes more challenging. I feel like when I'm retrieving the 2 arms of the proline, there's space for me beside the bag versus when I put the CTR. Like it's easier to do it with the CTR later for me.
Thank you. Really nicely
All right, I think in the interest of time, let us move. Nitin, are you ready with your case?
Yes, sir. Just.
Yeah. So can we start? I don't know what the case is about. It just says a cataract dilemma. So can you briefly introduce and start, please?
Yeah. So I'm presenting a case of traumatic cataract with a nasal. Well, I'm finding it a little difficult to do.
Share your screen, please.
Yeah. That's what I'm trying to do, sir. Yeah. 1 second. Hello.
No, we are still seeing you. You stopped sharing actually. You have to start sharing again.
Yeah, I'll do that again.
Can all the panelists rename themselves so that we can know who's speaking?
Is it visible now?
Yes, now it is. Yes, yes.
So I'm presenting a person in 30s who has had a trauma a decade or so back, and we could clinically see a nasal dialysis of around 3 o'clock. So that is how the case is. He has developed cortical cataract. That's why we are operating him.
Can we start?
Yes, I'm trying to press the button. It's somehow not running. Just a minute. So there is a nasal, kindly excuse me for the initial slight decentration. You have to use a good viscoelastic, so probably sodium hyaluronate, and make sure that the vitreous there is a tamponade, and I'm using a Haldipur forceps to complete the rhexis. A good rhexis is critical because if you want to place a segment, I'm trying to remove, and you can see there is a dialysis which is more visible now. Luckily, there is no vitreous disturbance, so I'm just removing the fluffy part so that it doesn't fall into the vitreous. So I'm just removing the ones that is floating, and with a good viscoelastic, I push the bag back. Now I'll be using the capsular hooks to stabilize the bag nasally. Without removing the little bit of nucleus, it's difficult to place them. So now I'm placing them nasally, and since it was only 3 o'clock, I'm able to stabilize the bag quite well with 2 capsular hooks. Till this point, there was no much vitreous disturbance, so I was okay to go ahead, and I could not see vitreous strands at this point. I have finished my phaco, and capsule could hold very well with the 2 capsular hooks. And since it was not a very hard cataract, it was not very difficult to remove. The cortex was removed gently. You can see that I'm able to remove even last bit of cortex without much hassle, and the capsule is holding quite well. I've chosen a 3-piece sensor, and I'm purposely placing the one haptic in the zone of dialysis so as to provide the extra support in that zone. You can see I've placed it there, so it's giving extra support in that zone. And I'll be using the MH segment to stabilize that part. I'm removing the capsule hooks. I have just done a small conjunctival cut and just doing a little bit of cautery. I could have done a Hoffman pocket, but being a glaucoma surgeon, I was comfortable doing a flap also, and it was not difficult to do. So this, I'm doing a nasal flap. Since it was nasal, I had to dissect horizontally. I had taken a corneal traction suture so that I had a counter traction to open up the flap. Yeah. So this is the MH segment. I have used 90 Prolene straight needle. So one needle is passed through the eyelid. And once the needle is fed, I'll be passing the segment. Here, many times, if you have not used before, you'd get stuck in the section. So you have to press it and push it. And once in, you have to make sure that the whole thing is in the bag and only the eyelet is popping out of the bag below the iris and above the capsule. So I have successfully fed the segment into the capsular bag. Now, so I have positioned it. And now here it's very important that you pass the needle very carefully, because if you go through the tissue later on when you want to pull the suture out, it will be stuck at that. So when you're passing the needle through the section, you have to be really careful not to catch any tissue there. So now I could easily pass. You can even bend the needle and pass it, but I could easily pass a straight one. Only thing, when you're pulling it through, you can see there was a little tug on the lens, so you have to be a little careful there because already everything is compromised there. Now I'll be just tying the suture there. I have taken 4 throws and then multiple throws, because this material you have to take multiple throws to make sure that the knot is stable. And just enough pull so as to center the lens well. So I have I have a segment there as well as the haptic of the lens to stabilize that zone, and rest of the zonules were pretty good. So only 3 o'clock zonules need to be taken care of. You can use glue to close this, but I have used Vicryl because I had glaucoma cases and I had the Vicryl suture is good enough to close the wound. Little bit vitrectomy just to remove a tag or so from there, but overall vitreous was pretty okay. Just have to hydrate it, and the lens looks pretty well centered. And
so in the interest of time, can we wrap it at this stage?
Yes, sir. Yes, sir. Closing.
Yeah. So Nitin, thank you for that excellent presentation and that excellent video. The video quality was really good. As we saw towards the end. Can I have Ronak Solanki, please? Can Ronak Solanki provide some kind of a comment on this case?
Yes.
Is he
Good
around?
morning, everyone.
Yeah.
Wonderful surgery, sir. Just a couple of points I would like to add. Like, some people want to use a Trifan blue. So the idea of using a cohesive viscoelastic in the start of the surgery just prevents the dye also from going into the vitreous and preventing that red glow to be altered. And when you use those 2 capsular segment, I've also done it once where you put the CTS segment and you can hold it with the capsular hook, so that sometimes if the pupil is going down or you're not sure where your anterior capsular margin is there, you can always then temporarily remove and again put your sutures and do it. It's just, instead of putting 2 capsular hooks to stabilize the bag, 1 segment, and through the eyelet you can put 1 capsular hook to just titrate the pressure sometimes during your phacoemulsion, so that that flutter of the equatorial region of the bag also is prevented sometimes.
Nitin, could you think of going the other way around from the sclera into the anterior chamber?
Yeah, I mean, since it was nasal, it was a straight approach. So I took that. If it was either up or below, then my approach could have been different. But since it was very straight thing and it was exactly nasal, I could easily go through the main tunnel.
Has any of the panelists used Gore-Tex instead of Prolene? Because there is this issue about even Prolene degrading over a period of time. How young was your patient?
In 30s, sir.
In the 30s. Any of the panelists having used Gore-Tex?
We've used Gore-Tex in the institutional setting, but I think it's very expensive to get, and you don't get a single one. You get a whole box of Gore-Tex, and the cost becomes for a rare case in your private practice. Practically, it's sometimes not feasible.
Actually, sir, a similar case was presented last time at Moscon by Dr. Nitin Balakrishnan. He's not here now, and he had used Gore-Tex, and the same conversation had happened there as well.
Any comment from Amok Joshi? Dr. Amok Joshi? Okay. Subira, you were trying to say something?
Yeah. I think when we look at a case like this, a patient comes to you with a 3 or 3+ clock hours on dialysis. I find that prior to the nucleus management, the placement of a CTR allows for ease of nucleus management. Not only that, it also prevents any vitreous from coming in the way, because merely using hooks, and I've seen this mainly in intraophthalmic dialysis, where we can't exactly measure the extent of the zonular dialysis. The entire bag has the potential of getting sucked out. So whether I want to use one segment or two segments or any damn thing, I would tend to use a CTR prior to the nucleus management. That's one point. And yes, Nitin?
No, sorry. Please.
You're brilliant. We have no doubt about this. Just been my experience.
No, you are perfectly fine. And that thought came to me. Actually, I somehow missed putting a CTR during the procedure. But my other thought was, if you put a CTR, removing cortex becomes even more difficult. I know to pull a lot in that zone,
So that was to remove the cortex and to remove vitreous. So I think it adds that little safety. The second thing I would like to state is that when it's not easy, you are extremely talented, but moving a long needle connected to a ninoproline suture is very difficult to maneuver across the eye and out of the eye. Irrespective of the glaucoma, in my experience, it's been easier to railroad with a 26 number and bring it out.
That's right. Yeah.
Third, I wouldn't necessarily anymore bother with making a flap. Even just a groove, a shelved groove, allows for ease of implantation, of burring of the sutures. And finally, even in the first case and now, I would place an IOL before tightening the sutures, which allows me to ascertain a more optimal centration of the IOL and therefore an optimal tightening of the suture to get the optimal centration of the bag. Thank you. Brilliant.
Thank you, Suvira. You're really the mother of all teachers. Okay.
Wonderful comments.
So, yeah. Okay. So now let's move on to the next case. Is Dr. Rajiv Brahmani here? Rajiv?
Yeah. Yes.
Are you ready with your presentation? Kindly share your screen and let's start. Can you go ahead, please?
Yeah. Can you see the screen?
I can. So please go ahead.
Okay. So I'll be presenting a case of a young cataract patient with bilateral high hypermetropia. So this was a 38-year-old active male marketing professional with predominantly a field job. Complaints of he came with gradual painless loss of vision since a few months. The best corrected visual acuity was around 624 and 618. And he was using +7 sphere at +1 cylinder glasses since childhood. On examination, he had posterior subcapsular cataract in both eyes. So the biometry data showed that he had a -1 cylinder in the right eye and -2.5 cylinder in the left eye. The anterior chamber depth was a little over 2 mm and the lens thickness was around 5 mm. The axial length was a little over 20 mm in both eyes. So the Barrett toric calculator gave us an required IOL power of 37.5 diopters with a recommended cylindrical power of 1 diopter in the right eye and 3 diopters in the left eye. So as most of us are aware, regular power of IOLs are up to 35 diopters. So it was basically a challenge getting this sort of lens. So the challenges that we were expected to face in this case are the obvious challenges because of a short eye, shallow iris, complications like choroidal effusion. Plus he was in a pre-presbyopic age with an active lifestyle. The IOL power calculation also has low predictability. Plus there were concerns of probable pre-existing amblyopia, internal aberrations. Plus, getting a customized IOL in this case can be a really expensive thing for the patient also. So we just laid out what options the patient had in front of him. And fortunately for the patient, care group had 38 diopters multifocal hydrophobic lenses available in the stock, 2 of them for that matter. So we laid out that option to the patient also. The patient was very keen to get rid of glasses. He's been using glasses since his childhood. So finally we went ahead and decided to do a phacoemulsification and use the 38 diopter non-toric acrylic hydrophobic multifocal IOL in this patient. And for the astigmatism, we planned opposite clear corneal incision on the steep axis in both eyes. So this was the surgery.
In interest of time, could you?
So we mark the axis like you usually do on for a toric IOL on the slit lamp using a needle and stained it for better visualization.
Could you skip to parts where you have done something different in the surgery rather than the whole surgery, please, in the interest of time?
Yeah, sure.
So that we can have more discussion.
Okay. So the post-operative data, this is what the refractive correction was there post-operatively. So the results were very gratifying. In the right eye, he was nearly emmetropic. In the left eye, he ended up with a cylinder of minus 1.25 at 20 degrees. And these were the vision. The best corrected visual acuity for the patient in the right eye was 6.9. And in the left eye, the uncorrected visual acuity was around 612. So the patient was extremely happy, and he was N6 for near vision without any correction. So concluding with good data collection and formulating a proper plan, you can always get a good surgical outcome.
Thank you, Rajiv.
Panelists.
Yeah, Rajiv, for an excellent video and excellent planning that you did. Is Dr. Manke over here, please?
I'm here. Good morning.
Yeah. So can you offer your comments on this case and the way
Yes,
the selection of the
yeah,
IOL was made? Could we have done something
I also
different?
had a similar case. Thank you, Dr. Narvekar, and excellent case and excellent results. So that is really good because IOL power calculation can be really difficult. But we also, for others who may be listening, there we need to just a few points that especially in high hypermetropes, because of the risk of iris prolapse, because of the risk of post-operative glaucoma, because of the risk of aqueous misdirection syndrome and all of that, pre-operative, a very detailed pre-operative evaluation with, even ultrasound and UBM is very essential, and a long incision into the anterior chamber to prevent the iris prolapse maybe, and also considering you have given excellent options to the patient with all kinds of options. I hope also sometimes we have also considered piggyback IOL because if the patient cannot afford customized IOLs, and there is a requirement of it is always better to give mannitol preoperatively in such patients and use some viscoat or something like that. So I think with these, it would be a complete evaluation in a case. But thank you so much. It was, I think you got wonderful results.
Yeah, thank you, Dr. Manke. Is Dr. Akshay Bhandari here? Dr. Akshay Bhandari? Could we have thought of a multifocal toric IOL that's customized? I think, Suvira, you had that to say because it's available anyways. We could have waited a bit because it was a PSCC and the care group could have probably made some IOL for us in that manner.
That's what I would have thought because addressing toricity with OCCI is questionable about the result.
No, OCCI is a little dangerous to do also because you never know. One little pre-op case for high hypermetropes, but little tip is that don't forget the good old mannitol pre-op, to just shrink that vitreous a bit, make your rexes a little easier. And in some cases where the intraoperative pressure has been really high, I've not even hesitated to do a little dry pars plana vitrectomy so that the anterior chamber gets well formed after you fill it up with the viscoat or whatever you want to do. As far as in other countries where maybe these kind of customized IOLs are not available, a piggyback option could have also been considered. get into the highest toric IOL that you can have on any of these machines. And either you can piggyback or even laze on the cornea if you need be for achieving emetropia. But anyway, all in all, Rajiv, an excellent presentation and an excellent result. So can I ask if Dr. Vijay Agarwal is still around? Or has she joined the meeting because she was to present? Is she there? So in which case, can I ask Dr. Pankaj Lande to go ahead with his presentation? Pankaj, are you here?
Yes, sir, I'm available.
Yeah, so can you just highlight your case and go ahead, please?
Yeah, I'm sharing my video, sir. So after finishing off this mature cataract, is my screen visible, sir?
Yeah, it is.
Yes. So to save the time, I had this mature cataract with a lot of pseudo exfoliation, and the bag was also slightly loose. I did my Rexis, finished off my phaco. So we'll jump to the point which I want to highlight. I implanted the IOL. After implantation of IOL, I was performing my hydrodissection, and here you note it is showing a descemet detachment. On table, hydrodissection induced descemet detection, and it was a situation where I was not slightly confused that how to proceed with this particular scenario. This particular scenario can be managed with air bubbles, with gases like SF6, C3F8, and anterior stromal puncture. So in this case, to identify the extent of damage I have caused, I just finished up the rest of the hydrodissection, and air bubble is introduced into the anterior chamber, which will not have a good circular contour because of the DMD, and I can see the extent of DMD, and it is well visualized with air bubble. Now you can see the folds in the Descemet's membrane there, and the DMD extent can be very well visualized. And this way we can know that how much damage we have already caused to the Descemet's. So to manage this, we have to, like in this cases of DMEC and DSEC, we do anterior stromal puncture. What I did is I took a 15-degree lancet knife. So it was slightly extensive, and which can cause later on edema in the post-operative period. And this was quite visible here. Because these Descemet detachments are not uncommon, and many times they are very localized and missed by many of the newer surgeons. So I wanted to highlight this point. And air bubble introduction into the anterior chamber is a diagnostic sign to assess the DMD. Now, once we introduce the anterior stromal puncture with the 15-degree lancet knife, we can see the air bubble has taken a good contour, and the Descemet has got settled in. And that is a venting incision, and we will just make it release more fluid which is there in the interface, and that way the case is saved. This was a small point which I have to highlight. And in these such scenarios, after this, we can use the sutures to the main port, and if needed to the side port, to have a good anterior chamber. And I'm using a viscoelastic so that if there is any liquid still coming out, I can note that, or otherwise we can use a strip-on glue, or otherwise betadine for that matter. Thank you.
Thank you, Pankaj, for that excellent video and that excellent presentation. Do we have Dr. Shushruth over here? Dr. Shushruth was supposed to be an expert panelist for this case. Is he around? So in which case, can I lay the field open to you, Suvira, to see what your comments about Descemet's detachment intraoperatively and the various techniques that can be used. Since we have some time now, this was, I presume, the last case that was to be presented. We can take some more questions and we can have a lively panel discussion. So Suvira, first, the case under consideration, Descemet's detachment intraoperatively during cataract surgery. You're mute. Can you unmute yourself, please?
Being in a teaching institute, I come across quite a lot of it. And what makes the desmus membrane detachments extensive is missing it when it just happens.
Yes.
If the students or even us senior people miss it and continue to go in and out through that incision, if it has happened at the incision, which very often in phaco I've seen happens at the side port incision, or if it's a very junior surgeon is accidentally with IA pulled on the central desmus, which makes matters worse because inferior detachments are extremely difficult to settle. So one, you should suddenly see that altered reflex from the undersurface of the cornea, and you should stop. Hand over to the seniors if required, and if it's happening through the side ports, I believe that you should take a suture there. Then make another side port, and then if at all proceed if you have the means to do so. When it does occur, however, I think the sequence in which it needs to be managed is one, I believe all the sutures, and assuming you've got to the end of the case, all the incisions need to be sutured. Even side port incisions are known to leak air. And therefore, if you take the effort to suture the main and the side port incisions and bury them, which can be removed in a week, and then through a clear area of the cornea, which is involved, a transcorneal pneumatic desmetopexy, my first choice would be air, should be done. And after you've filled the anterior chamber with air, a very important step that cannot be missed is using a 23 gauge MVR and making venting incisions on the surface of the cornea, which are full thickness. And after that, whilst maintaining the needle in the anterior chamber connected to the air, you inject air and you watch fluid come out through those venting incisions. Because now you've created a path for it to come out and settle, so it works both ways. So suturing, pneumatic desmetopexy, and venting incisions.
Right. A little tip to juniors who might be watching today. One of the primary causes of DM detachment is using old knives, blunt knives. That's the primary cause. We keep on using them again and again. And my little tip, especially when you all are doing doing premium cataract surgery, is to use a new disposable knife every time. And now disposable knives made by Indian manufacturers are also very good. You just got to use them once, and they are not inexpensive. Okay, they are not expensive rather. They are quite inexpensive. So desmus detachment is a very common problem. For a large detachment, we have probably more problems, especially it's an inferior detachment. Nikhil, would you handle it on the table itself, or a large inferior detachment, or you'll wait for your corneal surgeon to come across and do something about it?
No, I think at least you should make an attempt initially in the first time only to repair it as much as you can, because it's always best. You are the primary operating surgeon, you know which way to push the bubble or the suture or whatever. You must give an attempt, and then of course we have the corneal backups. I've seen a lot of these when I was a professor at Somaya. We used to see these quite a bit. Even now at Pramukh Swami, we see these. There are certain cases which are with these dense arches, and कि desmet में कुछ तो होने वाला है, I've seen a case where side port kiya and it entirely has like a taco just opened up. At that point, we had sutured it. And we didn't even proceed with the surgery. We let it heal. And then 15-20 days later, we reviewed and did a secondary surgery. It's best not to start the phaco only in that case then.
Regarding the choice of bubble, do we always use air, or can we use a non-expansile mixture of air and SF6? Sometimes for these large inferior detachments and the positioning of the patient post-operatively. Suvira, any comment about that?
So I, as a primary measure, I would use air. I would consider the 14% isoexpansile C3F8 because we have that in our retina OT. In cases where I've got a massive detachment or if I've got an inferior detachment. And that, of course, lasts longer. It lasts for 4 to 6 weeks. But I think it works pretty well. But I use it for selective cases, not for all.
Right. So regarding the other cases, there was some question being asked about the placement of the IOL before the CTR or before the segment.
Yeah.
So somebody could have an
I
answer
want
to
to
that.
add on one thing.
Yeah, please go ahead.
So while managing DMD, see, if you have a DMD which is on a nasal side, to manage that particular DMD, you should make an incision 180-degree apart and then manage it so that you should not again enter in the same quadrant. That is the one point which I think juniors should note down.
Right. Ronak, can you unmute yourself?
Yeah. So regarding this DMD case, I also wanted to say that there is no harm in trying multiple attempts on first day, second day, third day. Sometimes if you are comfortable, corneal surgeons also do a slit lamp air fill. So because over time, these things do not require a total corneal intervention in the form of an endokeratoplasty and all that. So you can counsel the patient that you may just need repeated air fills, and it actually works sometimes well. And also, as ma'am said, suturing the ports, what happens in a complicated case, you tend to just keep hydrating the ports more and more and cause more damage. So once you've sutured it, even your hydration extent is minimized and causing more tear and damages.
Right. And also, the juniors should be instructed how to hydrate the ports. Very often they go so posteriorly, they're right away splitting between the descendants and the posterior stroma. So these things happen. And, you have to be very careful, even at a very senior level, that you place your syringe and your cannula exactly where it's meant to be. And let the roof hydrate and close the incision rather than allowing it to be towards the posterior side.
I think, Sandeep, even creating the incisions should be we need to be meticulous.
Absolutely, yeah.
Trouble while struggling with instrumentation increases the risk of creating DMDs as well.
Yeah. Rajiv, you had some comment, Rajiv? Rajiv had some comment. He was dying to speak.
No, I had some. Sorry.
Now go ahead, Rajiv. Yeah.
Yeah, it was about my case. So you said something about customized IOL. So we inquired about that also, but the customized IOL is only available in hydrophilic materials. So since he was a young patient, we would prefer to use a hydrophobic material. That's why we went ahead, and basically the decision was made because the availability of the IOL was there.
Now, the question here is that
Yes,
I mean, this is just a joke, but hydrophobic because it causes less PCO. Is that the
Yes,
only
sir.
reason? Yeah.
Yes, sir.
So he's a hypermetrope. There's not much
Yeah.
risk in the yak capsulotomy. Just a little aside.
Okay.
I don't. Okay. So anyway, I think.
Sir, I just have one comment about the hydration. Many guys don't do any hydration. What do you feel about that? They don't just hydrate only.
Absolutely risky. I wouldn't allow that. You have to hydrate your wounds. You may not hydrate if you have got two wounds well hydrated and the third one doesn't show any kind of a leak. But to leave a wound unhydrated is absolutely the last thing I would ever do on earth. Because the risk of endophthalmitis, just 10 minutes into surgery, if you were to just take your intraocular pressure, it's very often less than 10, by the time. So you will have ingress of organisms from the conjunctival sac, and you just can't take that risk. The risk of endophthalmitis is too high. And in fact, I would go ahead to say that even in those cases where you've lost vitreous, I think it's better to suture the wound.
Suture. Yes.
Nothing like suturing to close a wound, however small or large it be. Yeah.
True.
I would like to make a few comments about this DMD. One is, if you are keeping a full air fill, don't shy away from creating a PI. In a case where you have kept a full fill for any reason, a PI would help in relieving the relative pupillary block. Number one. Number two is, in case of DMD, it is much better to intervene earlier, because if you wait for a long period, if you wait for this thing to resolve on its own, sometimes what happens is there is a fibrosis that gets created in the interface, and then settling that DMD becomes very difficult. You have to literally create a descemetorrhexis where the fibrosis is not there, and then kind of settle the flap. And third thing is, while hydration, it's always much better to use a very small 27 gauge cannula in the early learning period, where the chances that your hydration is going posteriorly decrease significantly. And you need to monitor your pressures also. If you are feeling that you're giving too much amount of pressure while you're hydrating, then probably you don't need that much hydration. The thing is hydrated. One more thing is, if you want to avoid suture at any cost for the main port, then you can always create a pocket above your main port and hydrate that pocket, rather than keeping on hydrating the main incision to kind of close it. I forgot the name of that pocket, but you can create a pocket above I think it's warm pocket or something, You can create a
No
pocket.
matter, it's a pocket after all. All right, yeah. So I had one question for Dr. Ridhima. Is she there still?
Yes,
The girl who presented Spherophakia.
yes.
Can you tell me what was the biometry in that patient and what was the lens thickness in this patient?
I don't have it here offhand.
Because to diagnose microspherophakia, I've seen a few. Most of them present very early in life with glaucoma or a wandering lens and stuff like that. She reached the age of 47 and didn't have a problem at all. That was, that was unique, and that's
Her
why.
refraction was about -9. However, her biometry, her IOL power was not that myopic. It was about 18, 19 diopters.
Right, it could be, but how did you diagnose spherophakia? What was the
Actually, her mother
anteroposterior?
also had microspherophakia, and she also came with the same, like both eyes. So I did not. So she had a subluxated lens. There was no cataract, but she had a lens subluxation and a lenticular myopia. So her fundus and her actual length was not myopic, but her myopia was -9. So, and she had a family history. Her mother had the same condition.
Right. Okay. Fine. So, any other comments that people would like to make?
So I wanted to ask in, say, an anophthalmos, a high hypermetropia, I have very often chosen monofocal lenses, and patients are very happy with monofocal implants in very high hyperopias, like +11 or +12. So I wanted to ask if you would still consider a multifocal implant considering the patient is young, or even monofocal IOLs or a monovision slide is the first choice usually for the panelists here.
So, in my humble opinion, generally about +34 or +35, IOL power, I don't like to put in a multifocal IOL. I have done occasionally patients where the intraocular lens power has been 55, 56, and even when these companies have consented to make an IOL for me, I found out after the initial experience that the quality of vision in these patients is not very good. The more hyperopic the IOL power, the quality of vision, the glare issues are very, very bad. So I have now switched over to performing a piggyback monofocal IOL in these patients. So for example, if my patient's power is 50 diopters, I put a +40, sorry for using some trade names, I use a 40 diopter SA60-80 lens from a single piece lens available from Alcon. And then I put the 3-piece lens, which could be from any company, in the ciliary sulcus. And there are special formulas how to calculate the power, and they are easily available online. And it probably gives the best quality of vision. So I'm not a great fan of putting a multifocal after a 34 or 35 diopter. Yeah.
Great, sir. Thank you.
So, Dr. Sandeep, if we put in 2 lenses in an eye that's where again the question of you have the interface between both the lenses, why not consider getting, even if it's an Indian company, we know we have some that actually could make you a monofocal IOL for up to 40, 50, 60 diopters and just use one lens.
No,
because agree with you about
of the quality of the vision. The quality of the vision is the problem, Suvira. What happens the more you make the lens hyperopic, the curvature of the lens is the one which causes all the problems. All the spherical aberrations and everything increase. We don't have interface issues as long as the material of the 2 lenses is different. In fact, the ideal situation, they say, is to have a silicone lens, from either Star Surgical or Bausch & Lomb in the sulcus with a hydrophobic in the back. But I have seen that 2 hydrophobics also do well, and I have not had a single case of interface issues, with that. The quality of the vision is the issue, I think, Suvira. Yeah.
Sir, I wanted to ask about the use of IPCL in sulcus, if anybody is having experience about it.
No experience at all with IPCL. I don't use IPCL at all. Sorry for that. But anyone else?
Phakic for that matter, in pseudophakic cases.
It's easier to use.
It has been done.
It's easier to use the piggyback IOLs that Care Group also makes instead of using the IPCL. And cost-wise, it is much more effective.
Yes.
Hello. And easier to place instead of, it's actually very easy. Doesn't cause UGH syndrome or anything like that in spite of being in a sulcus and supracapsular region.
Rather, but I would like to go with the three-piece IOLs in the sulcus, which are very well stable and the centration is extremely good.
Yeah. But somebody has asked whether is it not risky to put two IOLs in extremely short eyes? No, I don't think so. Because if you see the lens thickness of the natural lens, it is always 4 millimeters or more. Okay. What is the thickness of the IOL that you're putting in the eye? It's not thick at all. So in the contrary, you don't have issues of glaucoma by having two IOLs in the same eye. Yeah. And one in the bag and one in the sulcus always. Never two in the same bag. Yeah.
Yeah. Sir, have you studied the eye trace or some aberrometry for these high hyperopic patients? In a patient in whom about a 50 IOL plus 50 IOL has been used, and vis-a-vis you have used two, probably 20 and 30 or something combination like that?
No, I have not used. I have not gone for that. In fact, I put the plus 55 or 56, I remember, customized IOL has been lost to me for follow-up. So I really don't know. Yeah.
So that may be a good point to check whether whatever we are assuming in terms of whether the 55 diopter IOL is giving a poor quality, whether it actually translates to on the bench also.
So the patient whom I had implanted this thick IOL said he was extremely happy not to wear glasses, but his problem was night driving, a lot of glare. He said everything was appearing as if there was a kind of a strobe light on that particular thing. And so that is the reason he was unhappy with the glare issues that were happening with such a thick IOL.
So let's ask Dr. Shirish's opinion on this as
Hello.
well. He's also here.
Hello.
Yes.
Nikhil?
So we should ask Dr. Shirish's opinion as well. He's also here. He has so much experience with these.
Sirish? Is Dr. Sirish there?
Yes. Hello.
Nikhil,
yes.
Regarding the question of using IPCL or Neurotrophic, I had two patients in whom I have used IPCL, but I find it better to have a PGR IOL which is made by clear tube. Earlier, I was making like circumflex that was very, physiologically very good, material was very, fine, but somehow then I stopped making the that circumflex IOL. But the better option is to have a IFC marketed and maker they're using PGR. That is very good options. And regarding the case of Ridhima's first case, I would like to advise her to go with the, rexis the forceps, because it's very difficult to control the rexis with the needle in the area of hemodialysis. Nice way she has used the capsular hooks to create artificial support to this. And regarding the case of descent detachment, I will like Pankaj to, advise always go 180 degree upward to air for entry of air bubble wherever the detachment is, and air bubble in the initial cases will take care of this, and tight air bubble is the key to success for 7 minutes, the key to success for the early reattachment of this. And inferior, as already discussed, the inferior detachments are very notorious to handle, but irrespective of the grade of the detachment detachment, you should use the SF6 for minor detachments, because SF6 is a easily absorbable gas, and in large cases we need to have C3 effect, irrespective of fear of pupillary block, which can be handled very easily. So these are my takes on all cases.
SF6 alone is dangerous because it can lead to very high rise.
Non-expansile concentration.
Non-expansile, yes. Okay, so I think we've had a very, very nice morning. We have had good discussions between everybody. I would take this opportunity to thank all the speakers and all the panelists for making it so lively. So
only one question to Dr. Nitin, if I allowed to ask.
Sure, please go ahead. We have 1 minute. Go ahead.
Your eyelid was looking over the iris. That IMX segment.
No. It was a very dilated iris. That's why, but it was behind.
Okay. Yes. It is very good that you have handled that needle through and through to the AC, because it is very long and very difficult to handle this needle.
It was above the iris, it would go through the angle.
And particularly if the subluxation is on nasal side, these are very long needle, and there are high chances that these needle can perforate PC or AC. So it is better to have a second instrument like dialer or any, I mean, a non.
Window color.
Yeah, below the needle to guide it along the path of the needle to the AC.
We can keep on talking till the cows come home. If there's a final comment by Nitin, otherwise we'll wrap up.
Yeah, regarding the, I don't know if sir remembers, regarding a high hyperopic case that we did before COVID, and I had consulted sir also. So we did a highest available hyperopic lens and then did a multifocal Selcoflex over that. I have a 7-8 years follow-up now. Patient is doing quite well. And the problem is, why do a Selcoflex? Because you get a lot of variation in such high hyperop cases. So you really don't know whether you're hitting the right target with one lens. So it's already, you have to always give option of a Selcoflex to these patients.
So I prefer to put the toric first in the bag, and the highest toric that is available is around 34. And then after that, because I think the toric with corrected in the bag works much better than the Selcoflex toric, which is notorious to rotate.
Yeah.
So on that positive note, and it's noontime, sirs and ladies and gentlemen, so we call it a day and we hand it over to the next session. Thank you.
Thank you so much.
Thank you
Thank you
for
very
having
much.
us.
Very lively.
Thank you.
Thank you, Dr.
Very
Narvekar.
nice.
Thank you, Dr. Amar. Thank you, Swapnil, for this fantastic session. Great contributions, great learning, very interpreted and precise, crisp. So we move on to the next session, this 9th session of the conference. And may I invite the moderators, Dr. Swapnil Sawant and Dr. Rahul Bahekar, to please come center stage, invite the chairpersons and the panel, please.
Thank you, Piyush. Am I audible?
Yes, sir.
Are audible. Yeah. So it's time for retina, and our session says dilemmas in retina, and we have 5 interesting cases to be presented. Dr. Manoj Sasavde sir and Dr. Preetham sir, can you just on your videos if you have joined? And Dr. Vaibhav would be presenting the first case, which is SFIOL in difficult situations, which would be moderated by Dr. Tina Agarwal and Dr. Pradnya Deshmukh madam.
Dr. Vaibhav Tadi.
Yeah. Vaibhav, just stand by. We'll just wait for our chairpersons.
Sapnesh, can you hear me?
Yes, yes.
Yeah, hi. Yeah, I have
Welcome,
joined.
sir.
Yeah, thank you. Thank you so much.
Yes.
I think it's going to be a great retina session. First of all, and rather at the end of the session, let me in the beginning of the session commend the MOS leadership and Dr. Piyush, as well as our retina stars, Sapnesh and everyone for organizing this session and this wonderful midterm conference. With that, let's start. Maybe some words from Manoj sir, Manoj Sasade sir, if he's here, and then we'll start the session immediately.
Already you are introduced, and I will start the session in time, and at the conclusion we will speak something. Okay.
Hi everyone.
Hi everybody.
Very colorful.
Hello.
Hello. Welcome, sir. Welcome to all delegates and speakers. So, Swapnesh, will you please call first speaker?
Yes. Yeah. So I request Dr. Vaibhav to start his case on SFIOL in difficult situation. Please share your screen, Vaibhav.
Is Vaibhav is there or?
Do we have the next speaker, Dr. Sagar?
Yes, I'm there.
Yeah, Sagar. So
You can
Sagar
start.
is my colleague from Shankar Netralaya, and he would be presenting a case of IOFB. Dr. Manish Vapai sir from Nashik would be the expert panelist for the case.
Yes.
Is my screen visible?
Yes, sir.
Yes.
Make it full screen.
Yes, yes, yes. Basically, these are just a minute. Yeah. Good afternoon to all. First of all, I'll thank MOS for giving me this opportunity. I'm Dr. Sagar Bhuibara, practicing VR surgeon at Akola. He is a 31-year-old male patient presented to my clinic with almost 15 days of mild redness and watering with pain. And this was aggravated in the last 2 days. Initially, it was of a very milder variety. He has already consulted elsewhere and under treatment with topical antibiotic cycloplegic for intraocular inflammation. The best corrected visual acuity was 6.9, 6.18 in the affected eye. On careful history taking, it was elicited that he underwent an road traffic accident under the influence of alcohol 18 days, almost 2 to 3 days prior to the onset of symptoms, which did not relate to his eye problem since there were no other associated injuries, and he felt that it was very trivial to me. So, with this, I was not, I didn't had that clinical photographs. My screen is still visible.
Yes, yes.
Yes, sir.
Yes. So I don't have the slit lamp photographs. So this is then intraop which where there's a small area of pigmentation, just almost 4 to 5 millimeters behind the limbus, which is not very clear.
Sagar,
Yes,
Your
sir.
first slide.
your screen is not moving.
Dr.
No,
Sagar,
no,
can you just
I
first make it full screen?
I have not started the video yet.
No,
No,
we are still on the
You are
first slide,
on
case
first
1.
slide.
Can you just make it full screen once, please?
Just a minute.
Slideshow, and then click on the screen and then move the slides.
Just a minute.
Just make it in a slideshow mode. Also, I think there is a serious issue in your bandwidth. Your video is also freezing.
So is it okay now?
No, it's still in the normal mode. Yeah, now it is better. Yes, you can continue, doctor, please.
Yeah. Is the video working right now?
Yes,
It's paused actually as of now. If you can just play it.
Okay, so I don't have this slit lamp photograph. So there was a small area of pigmentation 4 to 5 millimeters behind the limbus. On clinical examination, he had a large area of clumped exudates vitreous in the periphery, temporal periphery. So, and I also got an B scan done, which again, sorry to say, but I don't have the B scan images with me. Showed a large area, large hyperechoic structure embedded partially in the sclera on the affected side. So I suspected to be a missed intraocular foreign body presented with low-grade inflammation. Plan which I decided was to do wound exploration, peritomy, see whether I could retrieve the foreign body from that area itself. So I started with the case by doing the peritomy, trying to expose at as much as part possible. This is the area which was the site of entry. Now, since it was an old foreign body of 14 to 15 days, there is certain amount of granulation, trying to dissect it and see whether I can see the distal part of the foreign body still outside the globe. But I was not able to see any. So just to be double sure, I also tagged the muscle in that quadrant just to make sure that there was not any foreign body beneath the muscle on that affected side. So, but there was not any. So later it was decided that I'll suture the suspected foreign body side to reinforce it and proceed on with vitrectomy, trying to remove it. So this is, I am inducing the PVD, trying to clear as much as vitreous possible. Going in the periphery, I'm indenting the globe from outside, and this is the large clump of exudates which was there in the periphery. So I'm trying to remove as much as exudates and vitreous from above the foreign body. Finally, I was able to see a part of it, the tip, and with active suction, I tried to pull it inside the eye. Fortunately, I was able to hold it in the mid-vitreous cavity using active suction. Brought it in the anterior-vitreous cavity, and under direct visualization with the handshake technique, used a forceps to align it with my wound and remove it outside directly. But oops, here I missed the foreign body in the wound. The mistake which I did was probably I should have exposed the sclerotomy in a much better way and even enlarged it possible. So I continued doing that. I exposed the conjunctiva, but fortunately for me, the tip was still in the wound. So I removed it with the help of forceps. So it was a large thorn which was partially embedded in the sclera. Considering the size, the patient was lucky to say that the lens was not damaged. I completed the vitrectomy, the peripheral exudates and the vitreous removal. I also did cryo in that quadrant to have missed any micro breaks during the maneuvering. At the end, I injected intravitreal antibiotics, and since it was a vegetative foreign body, I also gave a shot of antifungal, closed the wounds. Yeah, intravitreal antibiotics, close the wounds, and peritomy. So, considering the size of the foreign body, I would say that the patient was very lucky to have missed any lens injuries and eventually gained good vision.
So I request Dr. Manish sir for his comments. Sagar, have you finished the presentation or
No.
is there anything more?
Yeah. So learning from my case would be a careful history taking is utmost important, though we have very modern and advanced investigative modalities, but it cannot replace careful history taking. B scan, it forms, though CT scan is the gold standard way to go ahead, but B scan is very important and decisive, especially for vegetative and non-metallic foreign bodies. And whenever planning for a transscleral retrieval, always make an adequate size sclerotomy to avoid missing the IOFB, especially in phakics. And most important, preserve your clinical data so that you won't be in a clinic situation where you're presenting a case and you don't have the B scan image. Sorry. So these are some of the instruments what we use for removing these foreign bodies. For magnetic foreign bodies, we have intraocular magnets of various gauges. For larger magnetic foreign bodies, it is better to use the handshake technique to bring it in the anterior vitreous cavity and then remove it with a forceps. The max grip and the claw forceps are also
Sir,
used.
please wrap up. Your time is up, actually.
Yes. So this is it. We can discuss.
I think that it was very well managed surgery. As you said, when you are removing the foreign body, your size of the sclerotomy has to be adequate so that the whole foreign body comes out without causing any collateral damage. Because if it's possibility that either you will lose the foreign body and foreign body will drop onto retinal surface, or you can cause some trauma in the pars plana region. Another technique that I like is that you create an additional sclerotomy between the two active ports. Because when we open one of the active ports, most of the times we are using 23 or 25 gauge nowadays with trocars. But when we open the active port, then for doing rest of the vitrectomy, that port might keep leaking, or you might have to suture it and then go through the sclera. Instead of that, if you make an additional port between the two active ports, in that case, you can have adequately large sclerotomy and remove the foreign body through that and then suture it. Then, it's like a closed globe and you're back to your old this thing. So that's the only additional thing I think you can do. And since it's a vegetative foreign body, very rightly you have to be very careful of fungal endophthalmitis, and you have given antifungal already. Patient is lucky that he did not eventually get it, because once these patients go in fungal endophthalmitis, it can be very bad. I had some problem with my initial part of the video. Did you have to suture was there a scleral tear? Did you suture the scleral tear?
Yes, though it was in sealed scleral tear, there was granulation tissue above that site of entry, so it was already sealed.
Okay.
But I dissected it, so I thought that I have iatrogenically induced some sort of ectasia at that point. I have thinned that sclera by dissecting it. So just to reinforce it, I took one suture, but or else it was in closed globe even otherwise.
Okay, because in such in these cases, if the foreign body is partially out and then partially inside, then it can be, very difficult decision whether you are going to remove it ab externally or internally. So depend, because you try to pull the outer part inside, it can become difficult. But even if you want to remove it ab externally, or you want to remove it externally because there is some amount of foreign body piece out sitting outside, it's a good idea to do a complete vitrectomy and then put antibiotic. Just don't pull out the foreign body. You're going to cause traction, and it's going to lead to further complications later on. So it's a good idea to do a complete pars plana vitrectomy. Make sure that the foreign body is relieved of all the vitreous adhesions, and then pull it out if you want to do it externally. If you want to remove it externally.
Sapnesh, can I make a quick comment?
Yes, sure.
So I think most of the points were already covered by Dr. Sagar and elaborated by Dr. Manish. I personally think that even though you have B-scan, but you should still do radio imaging, considering the fact that in the court of law, it can come up that the possibility of you missing up another foreign body inside. So if you have it with you, it's always to be on the safer side. That's the first comment. The second one was, of course, you mentioned that the size of the sclerotomy was comparatively smaller. This has happened to all of us. Sometimes judging the size of the sclerotomy can be a problem. So just exposing the conjunctiva well right at the beginning, so that in case if you need to expand it, you need to increase the sclerotomy size while holding the foreign body in one hand. You can expand, you can increase the size of the sclerotomy with your other hand, and then grip it and take it out.
Good. Good case, Sagar. Everything is covered. Just I wanted to make a point that after you have given the prophylactic antibiotic and antifungal, I think it should be given once you close the sclerotomies. Should not be put to the cannulas. Otherwise, adequate concentration will not remain in the vitreous cavity. It will dribble out. That's all. Otherwise, the excellent case. Thank you.
Thank you.
Great. Nice case, Sagar. I think we'll proceed now because we have 4 more presentations.
Yes.
So I invite the next speaker. There is a slight change in the order. Dr. Trupti couldn't present because of an emergency situation at home. We have Dr. Harshit Vaidya to present a case of closed funnel RD, which would be for which the expert panelist is Dr. Payush Bansal and Dr. Ashish Vaidya, sir. I think both of them have joined. So Harshit, I would like you to share your screen and please start the presentation. Dr. Harshit, are you there? Do we have Dr. Parag Bhagat? Dr. Ganesh Bame?
Yes, sir, available.
Yeah. So Dr. Ganesh Bame would be presenting a case of endophthalmitis, complex scenario. And Dr. Karobi madam and Dr. Gadre sir would be the panelists for the same.
Sir, my screen is visible now, no?
Doctor, you need to select the presentation, please.
Yeah. So I'm going to present a case of 70-year-old female. She was having uncontrolled hypertension and diabetes. She was actually referred by a diabetologist for a second opinion as her sugar was uncontrolled due to the IV steroid. Her vision in right eye was hand movement, left eye was 6/9, cornea was clear, antechamber was quiet in both eyes. There was RAPD in right eye, and lens was having nuclear sclerosis grade 1, and IOP was 15 in right eye and 19 in left eye. Fundus examination of right eye show few vitreous cells which were scanty, and retina show subretinal placoid multifocal choroiditis lesion, and disc was slightly hyperemic, and choroiditis was there. So this was a case. So you can see there was presence of choroiditis which was more confined to the posterior pole, and it was limited to inferior pole also. And in the second picture, you can see there were some deposit in the vitreous cavity at the mid vitreous cavity. Left eye was totally normal. So I just asked for the negative history. There was no history of fever, no history of recent weight loss, no history of similar complaint in the past, and there was no history of any low-grade fever or symptoms suggestive of any pulmonary pathology. There was also no history of any connective tissue disorder or surgical intervention in the past, no history of recent IV transfusion, antibiotic, and catheterization. There was no history of immunomodulator drug or immunosuppressive treatment taken in the past. So this was a OCT picture of right eye, and you can see a dome-shaped elevated lesion, and it was multifocal. So the dome was irregular, and at different location, you can see the choroiditis, and there was adjoining area where you can see the outer retina was showing some hypoechoic area, and there was fibrinous deposit in subretinal space. So this was a right eye OCT. Left eye OCT was normal. So there was no signs of choroiditis in the left eye except a slight depression of the foveal contour, which was age-related. Her fundus fluorescent angiogram was done, and it was showing hypofluorescence at the site of choroiditis in early phases, and slight leakage in mid phase also was noted. And in late phase, you can see leakage, which was correlating with the area of choroiditis. So what I'm dealing with, the choroiditis, which is worsening with steroid, whether it is tuberculoma or whether it is secondaries or whether it is an endogenous endophthalmitis. So it was a big dilemma. So blood investigation was done. CBC, urine, HIV, SBSAG, VDRL was negative. ESR was slightly raised. HbA1c was raised. Estimated average glucose was raised. Creatinine was normal. Lipid profile LFT was normal. Her blood culture was done, which was negative for acid-fast bacilli, bacteria, fungal, and urine culture was also negative. Radiological investigation was done. Chest X-ray was normal. USG abdomen was normal. USG pelvis was also normal. So what is the cause? It was a big dilemma. So again, tried to dig out the history and look for any clinical sign. The one thing which was clicking me to the diagnosis other than choroiditis was small colonies which were confined in the mid-vitreous cavity and which were uh, uh, in line, and it was very minute. It was looking as if it is some fungal infection. Then I again asked the patient, have you done anything in last 1.5 months? So then slowly the patient said, हा मी 1 महिन्यापूर्वी कान साफ केला होता डॉक्टरांकडे जाऊन. Then I noticed that there was a history of otitis externa 1 month back, and the eardrop which was used was containing besimethasone and clotrimazole. So what should we do? Should I go for surgical or medical management? Main presentation was choroiditis with some optic nerve involvement. Vitreous cells were very scanty. Sugar was uncontrolled. Fitness was not available. So I planned that I will go for some medical management. But in hand, the culture of blood was negative for bacteria and fungus also. So I planned for IV antifungal agent, and I started with fluconazole with the help of intensivist, and her LFT and RFT was monitored, and intravenous fluconazole was given for almost 15 days. She was followed up on the 3rd day, 7th day, and on 15th day, and there was progressive improvement in her visual acuity. And one more thing, that good glycemic control was achieved with the IPD basis. So after 15 days, patient was shifted to the oral for fluconazole 150 milligram for almost 1 month, and LFT1 RFT was monitored. And this was a picture that within 2 months there was complete regression of choroiditis. The choroiditis was cleared from posterior pole, and even the fungal colonies which were seen at the mid vitreous cavity were completely regressed. This is a OCT picture. You can notice there is total regression of keratitis and regaining of the retinochoroidal complex, and foveal contour was also regained. So the patient improved from hand movement to 6-9. So take home message, it's not the tomato ketchup which is always different. Sometimes keratitis can also present with a different scenario. Thank you.
Have you done quantiferon gold test in this patient?
No, sir, no.
Mantoux test? Because I have missed in between.
Mantoux test was negative, sir.
Okay.
Was negative.
Okay. I feel rather than it's an endophthalmitis case, it's basically a choroiditis case with a spillover vitritis, we can say, rather than saying it's a congenital endophthalmitis.
Yes.
And because there is.
Can I ask a question?
Yes.
So, Dr. Ganesh, you just gave a systemic antifungal, no steroids in any form.
No.
Just managed.
Even not a single topical eye drops I have given, ma'am.
Okay.
Yeah, not because patient was actually patient had already taken IV steroid for 1 or 2 days, and patient was rather worsening with the steroid, and then patient was referred for a second opinion by a diabetologist whether the steroid has to be continued. Can we have another way to treat this patient rather than steroid?
Okay, because did you also think of mucor? Because she had an ear infection. I mean, we have seen mucor patients, frankly, 1 or 2 presented like this.
Ma'am, her ENT, actually I talked
I
with
know
the
the presentations is different. They will present with proptosis and ptosis and
yes.
loss of vision and
Yes, sir.
uncontrolled diabetes, because post-COVID, that's one of the things. Pre-COVID, we were really not thinking of mucor, but post-COVID, we have a surge of post-diabetic patients who with mucor who are coming up even now. So that I just.
Yeah, on presentation, actually, her extraocular movement were normal. She was not having any pain, no proptosis. And even I took the ENT opinion also once she gave the history of some ear infection in the past. So the ENT surgeon has also given a green signal that there is no sign which is suggestive of mucormycosis.
Ganesh,
Yes,
I'd like to say that first things first, you have presented a very nice, interesting case. You have done your workup very well. You have revisited the patient when you couldn't find an answer to your queries. And that is something which is very important, which we have to learn to do with our patients. Now, certain feelers which were there in your case is that you found there was multifocal kind of this, which was definitely inflammatory in nature as evidenced by the fluorescein angiography. And the thing is that there was a worsening of steroids. The patient was a high diabetic. The chances of a fungal infection is definitely much more higher than a tuberculoma. Yes, quantiferon gold, etc. And this should have been done because that is something which is prevalent in our country, and you have to rule out tuberculosis as a major cause. But my thinking would be more towards a fungal. And then when you revisited and got a fungal infection in the ear, it kind of clinches your diagnosis as to what you were sort of thinking. And the thing is that line of treatment you have done in consultation with your physician, which was good. And you have got a very good result also at the end with improvement, not only in the visibility, but also in the fact that the OCT features also almost came back to normal. Those few dots which you showed in the center, like in the in the equatorial region, which you said, these sometimes are classic of candida infections which can occur. And if you see spots like that, which are small, fluffy, tiny, discrete ones, that is another thing which draws you towards a fungal infection. And that is what you have to investigate. But overall, I feel that you've done a fantastic job and you have worked up the case well. You've thought about it and you have done your homework nicely and treated the patient very well.
Thank you.
I have just a question, Dr. Ganesh.
Yes, sir.
Yeah, since you were working on the working diagnosis of fungal infection, you never thought of taking up maybe an aqueous tap or a vitreous biopsy to confirm?
Sir, actually, I planned for the aqueous tap, but when she was presented to me on the first day, her sugar was already 400 plus. So the fitness was the main issue. And second thing, the patient was she was almost on the wheelchair. So she was physically debilitated, and I thought the aqueous was totally quiet. And even on anti-vitreous examination with the 90D, there was no cells seen except that colonies which were present inferiorly. So I thought, and for other cases, when I used to send the aqueous for the culture, most of the time, even if it is full-blown end of the aqueous sample doesn't give a very definitive diagnosis of any microscopy. So that's why I not planned
No,
for.
it is you've done a good job with the case because the case responded very well to systemic therapy. Maybe I'm only saying what I would have done little differently is probably taken a vitreous biopsy in this case and maybe sent it for microbiology.
Yes, sir.
Yeah, very well presented, Ganesh.
At this
But
juncture, Preetham, I want to say one thing. Ganesh, do you have your own OT or do you work in someone's OT?
No, my own OT, ma'am. My own OT.
It is easy because people who have their own OTs, they have the discretion of doing this as a small, simple procedure vis-a-vis somebody who has to sort of go through the hospital rules and the patient lands up paying a whole lot of money for that tiny procedure. So if you think on your clinical basis you can manage it, I think there's nothing better.
Yes.
Can I make a point?
Yes. Yes.
Yeah. Did you do CT scan orbits and PNS for this? Because one of the differentials in diabetics with presenting like this can be mucor. So we have to look at the this thing. And we have to look at the sinuses also.
Yes, sir. Sir, actually, that whole gamut of investigation, the patient and the relative were, after doing so much of investigation, they were slightly
No,
not.
no, no. What I'm saying is that what you have worked up the case very well and the patient responded because it was a choroidal infection of fungal infection. But mucor has to be kept in mind in a uncontrolled diabetes with this kind of presentation, and that needs to be ruled out as well.
Yes, sir. Yes, sir. That was in my mind, but patient.
only one point, Ganesh, is that it was a submacular lesion, basically a choroiditis.
Yes,
It
sir.
resolved with, whenever it is an infective choroiditis, it resolves with the scarring and residual damage. There is no evidence that it was a choroiditis, and the vision also is improved to 6/9. That is very interesting and surprising. Was it a really infective etiology or something like a posterior scleritis?
Sir,
Leakage-like syndrome, particularly in such cases where the choroiditis resolves without any evidence. That should be thought.
the thing which I found in this case, actually, once I started the antifungal, on third day only the patient's vision improved from hand movement to 1 meter, and then patient was feeling slight betterment in vision. Third thing that I look for external examination, I rule out scleritis, I rule out external ocular movement, painful orbital movement, and everything. And the thing, every 4 or 5 days, I was revisiting the patient. So I was trying to see whether my guess or my line of treatment is not missing out anything.
Yeah.
So just medically and without doing much more investigation, I tried to manage this case.
Good, good.
Okay, nice. So thank you, Dr. Ganesh, Dr. Karobi ma'am, and Dr. Girish. Sapnesh, shall we move ahead?
Yeah. Yeah, so I would like to invite Dr. Harshit Vaidya to present his case on closed funnel RD. And Dr. Piyush and Dr. Ashish Vaidya sir would be the panelists for this case.
Thank you, sir. Am I audible?
Yes,
Yes.
yes.
Is my screen seen so far?
Yeah.
So thank you, Sapnesh sir. Thank you, Piyush sir. And thank you, Moss, for giving this opportunity. So basically, I'll be discussing a case of closed funnel RD. So we have these ultrasounds that all of us, our retina colleagues and our anterior segment colleagues would have seen at some point in time, and these are obviously clearly some challenging cases. So my case doesn't really have much of a dilemma, so to say, but it was one case that was slightly difficult, which I thought I'd share here and take opinion from our seniors here. And so I'll just get directly onto the video. It's just one case and a few discussion points with the senior. So this was basically. This was, sorry. So it was a 62-year-old male who had a total cataract and on-table PC dehiscence. So we had this anterior and posterior PVR with a closed funnel RD. So we started doing the vitrectomy, relieving the posterior PVRs to begin with, because that's the first thing you would want to do to ensure that your posterior retina is free of the PVR membranes. And we extended the PVD to the extent as much as possible. It was done deliberately and meticulously to the extent possible. Now, here we obviously the main thing was to ensure that the infusion cannula was in place. So that's something that I had to see a double check initially as well. We trimmed the vitreous, slowly and steadily, ensuring that we can see the posterior pole. At this point in time, I injected the PFCL, and this time you can see the Schlerin admixed with the BSS as well. I could see that the posterior retina was fairly okay, so I went ahead and filled the PFCL to the extent possible, and then went ahead and started removal of the anterior PVR. Used all the tools available, the cutter, the forceps, as well as the scissors. At this point in time, I could see that the temporal retina had a slightly large tear underneath the forceps that you see. And the anterior retina was stiff, not giving way at this point in time. And we know that I did not put a belt buckle at this point, initially as well. So it was I was trying to ensure if I could remove as much as anterior vitreous and PVR, but it was slightly difficult, and the break led me to believe that I should go ahead with a 360 relaxing retinectomy. And that's what I did, ensuring that I could go as anterior as possible, relieving the anterior PVR, but ensuring that the edges are trimmed as well, because the thick scars, if they are left, they can lift off very easily, even with the laser marks. At this point, it is also important that we relieve the anterior flap of the retina to ensure that there are no cyclitic membranes that form, causing a hypotony subsequently. Went ahead, did a 360 laser barrage, putting tight burns, about 4 to 5 rows each. And at this point in time, it's a question as to where your next step would be. The dilemma is: are you planning to go ahead doing a direct PFCL oil exchange, or we go ahead with a air exchange first, then remove the LPFC, and then silicone oil insertion. In my hands, the fluid air exchange, subsequently doing the oil exchange, helps better than direct LPFC oil exchange. Again, this is open to debate, and I would want our seniors to opine on this. At this point in time, obviously, we take the flute needle, ensure all the edges, do not have any residual fluid, because any slippage of fluid makes the case significantly more challenging. So this takes significant time. I ensure that can be taken care of. At this point in time, remove the PFCL, and ensuring that at this point in time, after this also, I went ahead and double checked at the anterior edges if there was any sort of fluid. So here we see and removing the any residual fluid there as well. The retina was fairly good at this point in time, and I went ahead and did a silicone oil insertion. There was a LPFC bubble at the posterior pole, which was subsequently at the end removed. I don't have the post-op images, unfortunately, but the patient I had seen last 4 months, like at the 4-month follow-up, and the retina was stable with a fair enough 6 counting finger, 1 to 2 meter vision. So some considerations and points to discuss with our panelists and seniors would be that we have these anteriorly nano funnels. It's important to ensure that the placement of the cannulas is we can see the infusion cannula before starting it off, because the chances, just like a bullous RD, the subretinal placement just complicates the things further. In these cases, I would want to know sir's opinions as to, in young phakics, considering sacrificing the lens, because that's something, to ensure the anterior PVR removal, we would, how many would sacrifice the lens, and what would be their take? Adding a belt buckle, in my case, probably I got away with it thinking that primary retinectomy is what I opted for. But I think adding a belt buckle in these cases, which are significantly more complex, and you're not planning a retinectomy, would be helping in supporting the vitreous base and also base dissection and visualization. I think PFCL is a must in these kind of cases to ensure that the posterior retina is settled for us to manage the anterior retina subsequently. So the point here, I think, the membranes in these kind of closed funnel RDs are significantly mature, so they are relatively easier to peel as opposed to the oil-filled eyes with the current RDs where PVR can be immature and difficult to remove. But I think using dye, is an option which needs to be considered, I suppose. And ILM peeling is something which I would want to know from our seniors where and when they would do it. Bimanual surgeries, probably in extensive PVR cases where you have 360-degree GRTs with subretinal gliosis as well as pre-retinal membranes. I think these would be something which our seniors would have experience and can guide us. Again, the question of the SRGs which are away from the macula, are we removing them all aggressively, or are we leaving them alone when there is no traction at tenting up the retina? And like we discussed, the direct LPFC and silicone oil exchange is something which can be considered. So thank you so much, and I'd like comments from our sir consultants and everybody, our seniors. Thank you, sir.
Yeah, good afternoon, everybody. Can you hear me?
Yes.
Yeah. So excellent case, Harshit. Fantastic result and very well managed. A couple of things is that when you're doing this retinectomy, sometimes there is so much of contracture that the retina doesn't settle even then. So you may need to do a couple of radial cuts in that thing so that, the retina has a better way to settle. Rather than, because what can also happen is that there can be circumferential contracture later on and the retina may get pulled off. Other than that, I think it was a very, very well managed, excellent case and fantastic result. Another thing is, did you put a IOL in this patient, or what was the
sir,
patient had a mature cataract? So
yes, sir. No, sir. Actually, there was a PC dehiscence also, so we left it aphakic only, sir.
So how would you prevent the silicone oil from coming in the anterior chamber in these patients?
A PI would actually help, at least post-op. PI actually, in terms of the glaucoma, that would help. But sometimes you can just put, if you have a PI, you can put a cannula under the PI and then inject saline through that, ensuring if the oil comes in the AC. If the oil does come in the AC.
Yeah, so sometimes what I do is in this pseudophakic patients or something, we put viscoelastic in the anterior chamber and leave the viscoelastic in the eye, so that it sort of maintains the anterior chamber and prevents the oil from coming up.
And I think so. The option in viscoelastic is going ahead with sodium hyaluronate is probably better than HPMC, where the IOP rise also is relatively lesser, I suppose.
Yes, definitely.
Yes.
Other than that, as I said, excellently managed case, absolutely very well done. Piyush, any comments from you?
Beautifully managed, Harshit, very nicely documented. And when you asked us those particular questions, if we would do it any differently, at least I wouldn't do it any differently. I would still not go ahead and put the belt buckle over here, since you had a phakic or a phakic or pseudophakic or a phakic section over here. With MIBS, you can pretty much go very close all over and make sure that the anterior traction is removed. Like Sir said, that those relaxing cuts in the peripheral retina, of course, help in complete resolution of the traction. Apart from this, I don't think I have anything more to add in this particular case. Yes, one more point. You said that whether doing a direct silicone oil PFCL exchange or putting in air first. Of course, if you're putting air in it, it gives you an additional, surety that you have a settled retina. So if you can manage to do that, there's nothing better than that. We have Dr. Tina Agarwal also. If you have any points.
Harshit, I want to make a small comment. You managed this extremely well. And the only thing is that you asked about the belt buckle. But since it is a decision that you made on the tape inside, when you were inside the eye, that you wanted to do a 360 degrees retinectomy instead because the membranes were not getting done, there's no point doing a belt buckle in advance because that's wasted, I mean, with 360 degrees retinectomy, you've wasted time doing that. So I think once you decide what you have, what you require, that is when you do the procedure. And the peripheral subretinal glycotic bands don't need to be removed in case there is no traction. If the traction is there, yes, then remove it.
Correct. Thank you.
Also, Harshit, I think it's a very good thing that you removed the edge of the anterior retina which was there, so that that doesn't cause any, later on doesn't cause any cyclitic membranes and hypotonia. That's another very important thing which we need to do.
Can I make a point?
Yeah, go ahead.
Yeah. Regarding the silicone oil LPFC exchange, or whether you have to exchange with air, I think whatever you are comfortable doing, you can do, because the basic idea is that the fluid should not go into subretinal space. So whether you are exchanging the LPFC with air or oil, you have to make sure that the fluid film which is there between the two interfaces is removed. So there is no fluid which is left behind. So it really doesn't matter whether you're replacing with oil or air, as long as you make sure that there is no fluid between the whatever you are replacing this thing with. That is one point. And second point I wanted to make was, in such extensive cases, you have also left behind LPFC as a short-term tamponade for 8 to 10 days when the retina is having a lot of intrinsic contracture, so that it kind of stabilizes the retina, and then after a few days you can 8 to 10 days you can go back in again, just do simple air exchange and then replace it with oil, or if you are very comfortable, then gas also. But so these are the two bits that I thought.
Thank you. Nice points, Manish. Here, I also would like to make one point that, with air, you can get success. You put in air and then replace with oil. But, besides not allowing subretinal fluid, the other problem with air can be slippage of the margin of the retinotomy. Now, this slippage can occur without you realizing. You could see your retina is fine, it's dry, but there could be still slippage. So one sign of noting slippage is that you should look at the edge of the retinotomy, and if there is slippage, then you will start seeing your laser burns on the choroid. That will tell you that your posterior edge of the retinotomy has slipped towards the disc. So make sure that you see this and only then go ahead with putting oil, because if the retina edge has slipped beyond the margin where it's supposed to be and then you put oil, then you could have a recurrence on your hand.
Very good point.
Very good point.
So what about ILM peeling, sir? I'm sorry, ma'am, please go.
Dr. Harshit, how do you prevent macular slippage? Like, do you let the nasal part remain attached before performing 360-degree laser or something like that? Before removing PFCL air exchange, how do you manage it?
No, so basically, I think in my case, I just used the flute all around. Because there was 360, the retina was free. So I was ensuring that, I mean, before doing anything, before my step, before putting any oil or before removing the LPFC, the entire edge of the LPFC and the air needs to be ensured that there is no fluid between the gap. That's the only thing, and that is 360 where I used my flute. And then when I was sure, obviously what Preetham sir said is absolutely right about the slippage that can happen after that. The retina can recede a little bit, and then you'll see that there are some burns which have gone on the choroid. So that means, that's something you need to take care of. But other than that, I think just ensuring that the flute is there 360, ensuring that sometimes, like, I'm overzealous and I've even had a choroidal bleed, because I've touched it and there was a bit of a bleed as well. So yeah, that has happened. But yeah, that's what I have done.
And another point is regarding the cannula placement. When such a puckered up retina, you can also try and do the surgery with an AC maintenance.
AC maintenance, yes. So that's the questions that I had, because there were a couple of them wherein it's a phakic. In aphakic, we've done that. You can put an AC maintainer and do it. In a phakic patient, you either sacrificing the lens. That's one thing I wanted to know, when and how you would decide that. And second is the question of ILMP. So I wanted to know these two things in younger patients with trauma and something. So what is the how do you do that then? Like, are you sacrificing the lens or you still save the lens?
No, you can very much.
Before anyone answers, Harshit, put on your camera. We like to see your face.
Ma'am, actually, I've been trying. I'm just not able to do that. Like, the video is on, but it's somehow black. So I'm not able to do couple of times.
You can place AC maintainer and do in fakie case also.
Yeah.
The fluid, I have done cases and you can
Manish,
their eye doesn't collapse that easily. Yeah.
let's conclude because we have 2 more cases to go and only 12 minutes. So, let's move on. Swapnesh.
Yes. So the next speaker is Dr. Parag, and he would be presenting a case of complicated ERM, and Dr. Deepthi Kulkarni and Dr. Hemang Kopikar sir would be the panelists for the same. Parag, please share your case. And then at the end, we would have some SFIOL scenarios for Dr. Pradnya Deshmukh madam and Dr. Tina Agarwal. The speaker is unable to join because of internet issues. So we'll have a quick 5-minute discussion on various secondary IOLs. Thank you.
Yes, Parag, your screen is visible. You can move to the screen mode. Your voice is shaking.
But perhaps what you can do is you can switch off your video. You can switch off your video because you're not able to hear you. So you can switch off your video and that will ensure that we can hear you and we can see.
Now you are audible. Proceed.
Sir, am I audible?
Yes.
Dr. Parag, please start. Dr. Parag, please continue. So I believe there is some serious network issues.
Am I audible?
Hello, can you see me now, Samyak? Okay.
Parag, what you can try, are you there? Maybe he's rejoining.
So I think by that time, we can give some SFIOL scenarios, secondary IOL scenarios to our panelists, Dr. Tina and Dr. Pradnya. So Dr. Preetham and Dr. Manoj sir had decided that we would just share some difficult secondary IOL scenarios. Scenario 1 would be a Marfan's case. Scenario 2 would be a post-trauma vitreous hemorrhage with dislocated phakic lens and underlying RD. And scenario 3 would be a typical case of a PCIL dislocation. So what would be your do's and don'ts in all 3 of them? Quickly, if you could just enlighten us, Dr. Pradnya madam.
Yeah, so in that case with an RD vitreous hemorrhage post-traumatic dislocated phakic lens, I would not think of a secondary IOL, frankly speaking. I would like to do the VR surgery, remove the lens, put oil, and the secondary IOL can be done at the second sitting. So it is not the first line of management. In a dislocated phakic lens with vitreous hemorrhage with RD, IOL is not the priority. And if you, the second scenario I think was an post-cataract surgery IOL dislocation, correct? So my anterior segment surgeon, whenever they always panic, they want me to do everything at the same sitting. But I always want to post it as a secondary because I don't know the patient. So to take home message is first see the patient undilated. I always try to look at the iris because iris claw is one of the options that many people are opting for. It's easier done and it's not even time consuming. So I like to look at the iris myself, whether the patient has PXF. I like to look at the peripheral retina because sometimes in these complicated patients, you might have a peripheral retinal tear or a dialysis. I like to treat that before I go in and, do something this. In a posterior dislocated IL, pseudophakic, I keep both the options open. First of all will be the vitrectomy with full vitrectomy with removing of the dislocated IL, of course. And whether I put it in An SFIL or an iris claw will depend upon the iris status. I have done both. Frankly speaking, iris claw is a lot easier. It is less time consuming, and it sometimes in SFIL I have noticed that I have this mild vitreous hemorrhage. Maybe it is in my hands. It clears up, but that is not the scenario that I see in a iris claw. And the third thing I think you said was an Marfan's. So that will depend upon the age of the patient. So a pars penile lensectomy and an SFIL. However, I had a discussion with a pediatric ophthalmologist. What his suggestion was that a secondary IL should not be done in a very young age group because the SFIL tends to dislocate. Now the other panelist might have a better, I should say, more inputs about that. But they had recommended leaving this patient aphakic for some time because the IL calculation also becomes easier. You know, the child grows up and then it can be always done at a later stage. But I think an SFIL will work better in a patient of Marfan's.
Dr. Tina, your inputs, quick inputs.
Yes, yes. I feel in first scenario, like if there is a retina surgery, like in RD cases, so better to perform in a stepwise procedure. Like first perform RD surgery with silicone oil or gas, whatever you prefer, and then next sitting, when you remove oil or later, then you can have proper IL calculation because with RD IL power calculation will be difficult. So we can do a stepwise approach in RD cases. In case of Marfan's, because they have mostly systemic issues, Marfan patient. So we have to take interprofessional team approach, like even cardiac examination, even the prior corneal diameter we have to measure because they have the horizontal diameter of cornea usually large in cases of Marfan's. So we have to check whether we have to perform the sclerotomy site 3 and 6 or 3 and 9 or 6 or 12. So all that we have to look. Even periphery posterior segment evaluation on all are very important. And in the third scenario with cataract, IL dislocation, or we can do in same sitting. Like already the patient had undergone one surgery and doing multiple surgery will be difficult to explain to the patient. So since IL dislocation, lens dislocation is a simple procedure, so we can perform in the same sitting. That's what I feel. And IL power and all are already priorly measured. So that won't be a problem. Yes, that is my take on it.
Great. So Sasavdi sir,
one
your
point,
closing
Swapnesh.
comments. Yeah. Sir, please.
Yeah. So see, in the Marfan's, very often the patient is a very high myope. So you have to be sure of the IL calculation, and sometimes with just giving a +1 or a +2 lens for distance, the patient can remain aphakic. Rather than complicating the matter, especially in the Marfan syndrome or in any high myopia, it may be sometimes simpler to leave the patient aphakic than put a lens.
Only thing in a close group injury, I think I would rather try a sterile IL power calculation and also take the IL power calculation of the other eye, so that once the RD is done, BB is inserted, oil is inserted, IL power calculation might be difficult. So that's my input about it. I think Dr. Parag is unable to join as such. Dr. Parag, are you there?
So Sapnesh, we can take some few questions for Dr. Kopikar sir and Dr. Dipti on ERM.
Yeah, Dr. Dipti has suggested a discussion on difficult RDs and use of low molecular weight heparin and methotrexate. Dr. Dipti, if you can unmute and just put your thoughts, and we will have an expert panel and a lot of seniors to debate on that. And him, Kopikar sir,
That was the reason why I
please
said
join in the debate.
Yes. After the previous case that we discussed, there are a lot of papers and publications about use of methotrexate in the irrigating fluid or as an adjuvant just after surgery, even in the presence of silicone oil. I have personally not used in the irrigating fluid, but for the past 3 years, I'm using methotrexate 0.05 ml at the end of surgery. And it's giving quite good results, except in the case of very fresh RDs, like of 2 or 3 days duration. All the other complicated RDs, re-RDs, PVR, I've been using this and somehow it's giving good results. I would like to know what our seniors are doing about this and if they have any other thoughts.
That's Dipti, a very good point you raised. I have also started this year only methotrexate set since last 1 year and 1.5 years. I am finding it very useful. Apart from the methotrexate, one more point was there, the glue, using the glue also. It is also helping a lot. That's all the retina surgeons who are doing the surgeries in difficult scenarios. They can use this both the things and see, analyze yourself. What was your previous experience and what is the current experience? Because we don't have any R&Ds and to say whether it was right. Every case varies. But depending.
But what is your criteria for case selection? Which cases you'll use it?
There is no harm in using in any case.
Okay.
We don't know whether it was started already the case of activated PVR or intrinsic PVR, or whether it is going to cause the epiretinal membranes or fibrosis later on because of the excessive lasers or cry or handling. In those cases also you can give, and as such make a rule that every case you can give. There is no side effects if it is given in a proper dose.
Sir, there were a few papers that in cases of re-RDs or in advanced PVR, even after oil, we can use monthly or 2 monthly injections of methotrexate till we do SOR to prevent fibrosis and redetachment.
Ideally, it should be given every weekly and all those, depending upon the list, but how much PVR it was to start with and what PVR changes you are expecting. But we are not following that one. Only on table I am giving it right now.
So if I can just quickly add, recently when I was at the Egyptian Ophthalmological Society, a couple of retina surgeons over there had shared their experiences. I think Professor Hamza also did the same. And they were using it for PVR of grade C. So they were not using it indiscriminately for all cases of PVR. Again, there is no questioning whether it is the actual surgery that is preventing the redetachment or whether it is methotrexate. So I don't think we have adequate data on this as of yet. But all of them were the opinion that they keep trying something new and seeing whether it is going to help us in the long run.
Manoj,
I think just to add
for you, would you use this in pediatric detachments and what would your dosage be?
Ma'am, I gave it only in 2 pediatric cases till now. Both of them had a history of trauma and they came to me quite late. But in both the cases, I gave 0.02 ml.
Okay. Half the dose.
Half the dose.
What about
any words from Dr. Kopikar, sir? Would you like any comments, sir?
I'll only make one comment because I'm having a lot of young diabetics in the last almost 1 year, 29 years old, 35, 44, type 1 diabetics who are coming with very florid retinopathy or with diabetic papillopathy and various other issues. So at least 2 of these were taking supplements from Ayurvedic and other fields of medicine without supervision, and they developed these problems. And I don't know, the severity of florid retinopathy in young diabetics and type 1 diabetics has increased in my observation. This is just what I was saying. Have other people also found the same? And if so, always inquire about whether they are doing all these YouTube alternative therapies, etc., and caution them about it. That's all.
Okay. Thank you, sir.
Thank you.
Yeah. So I think with this we've come to the end of the session. I had given the opening remarks, so I think I would ask Dr. Manoj Sasavade, sir, to give the closing remarks.
Thank you everyone who has participated in presenting as well as the discussions, and it was a good discussion on the difficult topics, and there was a thorough discussion, and 1:1 discussion has been happened, and it will be useful for those who have presented and who have attended this 1 hour retina meet. I am thankful to each and everyone, and let us enjoy the Sunday. Thank you very much.
Thank you.
Thank you very much, sir.
Thank you very much.
Dr. Swapnesh, Dr. Rahul.
Yes.
We move on to the next session, which is session 10, where we'll be discussing dilemmas in uvea. And the session, I would like to hand it over to our moderators, Dr. Mayur Morekar and Dr. Samyak Mulkutkar. So to introduce the chairpersons and then take the session forward.
Yeah, thank you, Piyush. Am I audible?
Yes.
Yeah, okay. Thank you. Thanks a lot, Piyush. And thank you, MOS, for giving us this platform. And I would like to now call upon the chairpersons of this session. Our chairpersons include our own Dr. Santosh Agarwal, sir. We all know him. He is the past president of our society. And of course, we have with us Dr. Parthopratim Mazumdar. We all know him. He is from Shankar Netralaya, Chennai. Hi, Partho. Thanks for being here. My co-moderator for the session is Dr. Samyak Mulkutkar. Good afternoon, Samyak. Thanks for all your help always. And we have an expert panel which includes Dr. Paritosh Kamdar, Dr. Salil Mehta, Dr. Anand Subramaniam, and Dr. Vatsal Parekh. There's a little change in the order. Samyak is going in 4. Samyak wanted to be probably Shubman Gill, so he said that he'll go in number 4. And we'll have number 1, that's our own Dr. Swapnesh Sawant. And he's presenting a perplexing pediatric disc edema. Over to you, Swapnesh. Thank you everyone for being here.
Thank you, sir. I would just try to log in from another computer. Okay, is the screen visible?
Yes, Swapnesh.
So this is a case of a pediatric disc edema, and I would like to thank Dr. Mayur Morekar sir for guiding me in managing this case. So case presented to me was a 11-year-old male with blurred vision in the right eye, and visual acuity was 612. Left eye was absolutely normal. Color vision in both eyes, Amsler's grid, and intraocular pressure were normal. This is how the fundus picture looked like for the right eye. There was a bit of vitreous haze. The anterior segment was per se absolutely normal. There was a bit of disc edema, tortuosity of vessels, cystoid macular edema, and tortuosity of arteries as well as veins. Periphery looked okay. There were no exudates. There were no other positive signs in the periphery. This was how the OCT looked like with a 484 micron central foveal thickness. And a typical workup to start with was done, and oral steroids were given in tapering doses to this child. And he started improving. So this was in month of October that he presented. By November, he started improving. And he kept on improving. The OCT also became okay. Vision came up to 6/9 partial, and near vision also improved. And we were all happy. But after 1 month, in Jan 2024, there was a relapse. And again, with disc elevation, hyperemia, dilatation, there was a abnormal tuft of vessels near the disc and along the arteries near the arcade. There were vitreous cells, and now there was a bit of trace vitreous hemorrhage that was seen. So this was how the vessel caliber was, and there was a tuft of vessels, looked like knots, the arteries, and you could see a bleed around that abnormal tuft of vessels near the disc. So I had referred this case to Morekar sir to see what was happening, young boy, and an extensive workup as shown was done. I would not repeat what I've printed. So, but nothing came out. We did a MRI brain and orbit plus MR venography. The optic neuritis sequel was seen in the form of peripheral fat straddling, but the venography was normal. For the want of any compression behind the disc, the color Doppler was also done for the carotids as well as the vertebral arteries. That was normal. To rule out any other granulomatous disease or any other pathology, CT scan of abdomen and pelvis and chest was done, which showed some sub-centimeter non-necrotic mesenteric lymph nodes, but nothing was conclusive as such. So these were our differentials to start with. And his twin brother also was examined, and there was a mild disc hyperemia in right more than left eye with venular dilatation. Sir had planned to do a octa. However, the oral steroids were already started. He started improving. All the findings started becoming stable, but the bleed from the aneurysmal dilatation continued. And octa was overall normal except the pre-retinal proliferation, There was no capillary non-perfusion area. The foveal avascular zone also was okay. So we were thinking that are we looking at a stage 1 of IRWAN without the typical features of hard exudates and not all features of neuroretinitis? This was how the Octa pictures looked like with superficial neovascularization. He improved. The disc edema became lesser. Oral steroids were restarted. Intermittently, some tests were done which came okay. We referred him to a rheumatologist, and azathioprine 50 milligram once a day was started. Vitreous hemorrhage was waxing and waning. We planned to decrease the steroids and step up the azoran to permissible doses. He had reached to 612 N8 at the March end, but in mid-April, the vision dropped. Vitreous hemorrhage increased, and there were episodes of fresh heme intermittently. Vision by May, it had dropped to PLPR. It was accurate, and a USG B scan was done. A serial B scans were done, which showed PVD, which was getting induced, but the amount of subhyaloid bleed as well as the vitreous bleed was slowly increasing. So a surgery had to be planned. So this is a short 1-minute video. In these cases, we have to ensure that the cannula is inside the vitreous cavity before even we start the vitrectomy. As you can see, it was a very dense hemorrhage in the vitreous as well as in the subhyaloid space. So even if the B scan is done elsewhere, the surgeon has to repeat it that he knows is there any peripheral RD that you are facing and where is exactly the subhyaloid space or the vitreous detachment there. After clearing all that, as you know, in the periphery, that could be ischemic areas. And so a proper pan-retinal photocoagulation was done because these areas, if left untreated, may lead to a lot of neovascularization and rebleeds. And a FG and a C3F8 gas was done and the case was closed. He improved to 618 N8. There was on the right side a early PSC, but the vitreous cavity was clear. He is on follow-up. Predfort eye drops and Timolet are on. Azoran is on. And in the last follow-up, February 2025, 612 N6, he's doing quite well. Dr. Morekar sir is watching him, and probably if the cataract becomes more significant, we are going to plan a cataract surgery for him. So I rest my case and open for discussion.
Yeah, so because I myself was involved in the management of this case, I would put the question to the chairpersons, Dr. Partho and Dr. Santosh. IRWAN was one of the things that I thought of, and Takayasu was something else that I thought of. In fact, that's why I had requested for a PET CT. And this is the second case where I'm seeing a young patient with a tuft of vessels close to the disc. The patient previous to this had even developed a neuroretinitis. We controlled that with azathioprine and adalimumab. That patient didn't require surgery. This one did. So, Partho, your comments on this?
Very interesting and challenging case, Shapnesh and Mayur. I think I always feel that the children here, the disc edema was little confusing. And probably it was a case of retinal vasculitis, and the vascular inflammation has actually caused the entire picture clouded. And if you see this in children or the pre-pubertal group, here the vasculitis or the vascular inflammation is quite different from the adult, and it's always very aggressive in nature. So I remember we did a study, and finally we concluded that this is some growth hormone role of growth hormone in this young children or the prepubertal age group may actually, which is a precursor for the increased VEGF expression, causes this kind of picture. So I think you rightly managed this case with a lot of immunosuppression, and we have a couple of patients where the single immunosuppressant was actually not sufficient to control the inflammation. So we have actually sent that for publication where we had to use the mycophenolate, methotrexate, and oral steroid to control the inflammation. And another point in this children is often you need to do a fundus fluorescent angiography to see the subclinical retinal vascular inflammation. In naked eye, you may not see that. And otherwise, other than that, if you look for the differential diagnosis with retinal vasculitis with optic disc involvement, I think you have excluded everything, including all other differentials. So I think it is really challenging, and I think so far you have treated it very well.
Thank you, Partho. Any comments from Dr. Santosh?
Yeah, it's very tough and challenging case. The basic pathology is vasculitis, all we know. It is very aggressive. Only one or two things I want to ask Dr. Swapnesh, whether the laser was needed. And second thing to Dr. Morekar, whether we should go for aggressive and immunosuppression in such cases and steroids. Because somewhere we're lacking, so we have to opt for surgery at last because there was no CNP. So,
Yeah.
is there any need of laser in such cases?
So CNP, as I told you, was for the opta of the central area, because some cases of IRWAN can have foveal avascular zone to be increased, and there could be those non-perfusion areas in the posterior pole. However, as we had in our mind kept a provisional diagnosis of IRWAN, it is very well written in literature that peripheral non-perfusion areas are always there. So correct me if I'm wrong, Dr. Mayur Morekar sir. So that is the reason for the peripheral laser. If you saw the post-op photos, it was not like a diabetic PRP where it is very close to the arcade. Somewhere like a Eales disease where near the equator or just behind, just posterior to the equator, I have stopped. Preventing re-RD also in a case of vitrectomy, as well as not allowing the neovascular process to proceed.
So as far as the immunosuppression part is concerned, in the other patient, we have combined azathioprine and adalimumab both. Yes, this requires an aggressive sort of an immunosuppression. I think we can move on to the next case, come back to this case at the end of the discussion. I think, is Dr. Hitesh here?
Yes, hello.
Yeah, so we go on to Hitesh. His talk is on to be TB or not to be TB. And the Dr. Salil Mehta is the discussant. So over to you, Hitesh.
Sir, is my slide visible, sir?
Yes, yes.
So, thank you, sir, for giving me this opportunity. So, I'll just present one interesting case. So, 32 years old female presented to us on 1st February 2025 with blurred vision from the right eye since a week. She gave history of on and off blurred vision from right eye since OD since November 2022, diagnosed to have serpiginous keratitis and was already on oral steroid 75 mg per day and on ATT since 25th December, so roughly around more than 1 month of ATT. So So on examination, her vision was 6.6 and 6 in both the eye. IOP was normal. And right eye, we can see active keratitis patches superiorly and just temporal to the macula. And there were multiple healed patches of keratitis. This was the superior patch, the temporal patch. This is just temporal to the macula. The left eye was quiet but had multiple healed patches of keratitis. So provisional diagnosis may be right eye recurrent keratitis, left eye healed keratitis, presumed ocular TB, paradoxical worsening, drug resistance. So these are my questions to the panelists and the experts. But coming back to the history, in December 2022, when it all started, she complained of blurred vision from the right eye. So there were active patches in the right eye. And she had taken multiple opinions, maybe around 4-5 opinions in 1 or 2 months, and extensively investigated. All were negative, inclusive of MON2, HRCT, quantiferon gold. Even MRI brain was normal. So she was given 3 days of IV methylprednisolone 1 gram, followed by full dose of oral steroids. So lesions were healing nicely and recovery was well. But there was first recurrence in February 2023 when the oral steroid came down to 10 mg. So this is the recurrence at the inferior, near the inferior arcade. And then again, she was, the oral steroids were hiked up. Then she was referred to Shankar Nethralaya, Chennai, and where she was started on mycophenolate mofetil along with oral steroids. So she had 4 visits at Shankar Nethralaya and she was on MMF and tapering doses of oral steroids. For maybe a year, she was okay.
But again, there was a recurrence in April 2024 when the oral steroids and the MMF dose was gradually reduced. So you can see active borders inferiorly, even superiorly. So again, she was extensively worked up. Even rheumatologist had seen all tests were negative. So increased dose of MMF to 2 tablets BD and full dose of oral steroids. From April to December 2024, 2 more recurrences after lowering down of oral steroids. So hiked up oral steroids again. These were recurrences. So new opinion, so new findings. She sought one more opinion, and again CT scan was repeated. This time CT chest showed some ill-defined nodules which were not present earlier, but they were very small so that biopsy could not be done. This is the CT report. MON2 again was negative. Quantiferon gold was again negative. So chest physician opinion was sought, which was done earlier also, but now the second time chest physician opinion was done. And she was started on 9 months of ATT since December 2024. And the chest physician had stopped mycophenolate mofetil and oral steroids were started from 80 mg per day. So 25th January, again she had a recurrence, roughly around a month of starting ATT. These were the new active lesions. And then this was when we had seen her. So multiple lesions. And this was the picture at presentation. So again, the same slide and provisional diagnosis is this. So my question to the panelists, and how do we treat it and what do we do? So I'll just share my treatment, like what I did. So continued ATT and hiked up oral steroids. And it was still progressing and there were lesions were very close to fovea. So I had given IVMP for 6 days continuously. And again, I had not started MMF and planned to hold MMF till the completion of ATT. So this is the chart shared by the patient herself. She was very particular about what all my instructions were and whether I could see new lesions or not, or the lesions were healing or not. So date wise, this is what she shared with us. So February 2025, the lesions were there. There were some hemorrhages also around that choroiditis patches, even superiorly and temporally. So March 2025, when there were the lesions were very close to fovea, I had given her IVMP for 6 continuous days. So those hemorrhages resolved, but the lesions were still progressing and it was very close to the fovea. So this is the active lesions. Then post IVMP, the lesions started healing gradually after 6 days of IVMP. And at end of March, it almost healed, but there were 2 new active patches. As you can see, superiorly 1 patch over here and just temporarily 1 more new active patch over here. But the posterior pole overall was okay. This is the new active patch and this is the new active patch. In April 2025, almost all her patches, there were no new patches, but all the old patches were healing. Posterior pole was okay. At the end of May, all patches healed nicely. She's still on oral steroids and ATT. At last follow-up, which was yesterday, so all patches healed nicely. She's on 30 mg of oral steroids and ATT without any immunosuppressants. So other eye was same. There was no recurrence in the other eye. So few more doubts to the panelists and experts. What if there is recurrence now? At lower dose of oral steroids, should I increase the oral steroids, hike up the oral steroids, or consider immunosuppressive therapy, or should I wait for the completion of ATT? What if recurrence is there after completion of ATT? Would we start immunosuppressants at that point? How do we rule out drug-resistant TB? If at all, immunosuppressants have to be started, which one to consider and how long? Thank you to my teachers.
Thank you, Hitesh. And comments from Salil, sir?
So, Hitesh, this is an extraordinarily interesting case, and it's something that we face, everybody faces repeatedly. When you see a serpiginous-like pattern, question is it autoimmune serpiginous choroiditis, or is it what is now termed as multifocal serpiginoid choroidopathy, which is due to Mycobacterium TB? After seeing all the extensive investigations and thorough workup that people have done, including you, I simply in my opinion, I am unable to reach a diagnosis even of probable TB. Forget about presumed. I can't even label this as probable. I don't think she needs a second round of ATT. I don't even think I would have given her a first round of ATT. I think this patient is best managed only on immunosuppression, either methotrexate or mycophenolate mofetil, whatever you and the patient are comfortable with. Because I grant you, the first round of investigations for TB, including HRCT, MANTU, TB Gold, can be negative. And as time goes by, when you repeat it second, third time, you do get findings. But here, second time also, they are completely inconclusive. That X-ray which you showed is not conclusive of anything at all. Even a small viral infection, peribronchial infection, which is roaming in the air, can cause this. So I am a little reluctant to start ATT again. Now, what's done is done, but I would actually actively consider stopping the AKT and switching her off to some immunosuppression, either like whatever you choose, mycophenolate mofetil or methotrexate, and step up the immunosuppression until she is stable, and then gradually taper off the steroids, keep her on an immunosuppression for about 2 years, and take it from there. The other question you've raised, very interesting, is drug resistance. Drug resistance is only and only a microbiological diagnosis. There is no question of diagnosing drug resistance on clinical criteria. You don't know. Because even if the patient doesn't get well, it doesn't mean that the patient has got drug resistance. It should simply could mean that the patient is not taking the medicine, or the dose is not enough. When you have microbiological samples from any patient, whether you take from the sputum, you take from EBUS, you take from lymph node biopsy, wherever, then when you send it to a good lab for drug sensitivity and testing, and the report comes back with the first line, second line, third line, that is the only way to confirm drug sensitivity or drug resistance. We can't even talk about drug resistance. And the third point you made about paradoxical worsening. Paradoxical worsening occurs within the first 1 or 2 months. After a complete course of AKT, you can't have paradoxical worsening. You can have reinfection, I agree, if the patient is exposed to somebody in the neighborhood, somebody in the house. And so this is what, unfortunately, we teach all our juniors and we teach all our MBBS students. Any contact of TB, any contact of TB in the house, nothing is going to happen. Most of them travel in these horribly overcrowded railways. They work in theaters, restaurants, 100 people go in and out every day. TB is everywhere. It is all around us. So that cannot be escaped. For every patient who comes to your OPD, you must write TB contact positive. That is the norm. So I think I would only keep this patient on IMT and nothing else, and monitoring. So in the right eye, I think she might even be a good candidate for Ozurdex. I don't know what other people feel.
Extremely elaborate answer. I think I don't think there will be anything to add to this. Would the chairpersons want to add anything?
Yes, yes. Why PCR of vitreous sample or any retinal biopsy in such cases is warranted?
Sir, PCR was also done at Shankar Nethralaya. It was negative, sir.
Negative. Okay. And what about any retinal biopsy in such cases is indicated to have a precise diagnosis?
A few people have done chorioretinal biopsies, but then the risk is always of unfortunate iatrogenic retinal detachment. And then what will you do? Unless you are really stuck in a bad situation where both eyes are losing vision and the patient is about to become, significantly impaired, I don't know how many of us would jump into doing retinal and choroidal biopsies. Unless you are very confident and you do it somewhere far in the periphery, do extensive barrage after that, and on top of that, you put oil for 6 months to make sure nothing happens. I don't know. How many of us would actually think even of retinal choroidal biopsies as even a first or second or even third line? What would you, Mayur? Agree? Disagree?
No, I think I would tend to agree with you. I would be very skeptical.
Partho, any opinion about whether to stop
I
DT
think
or
that,
whether to
as
continue.
usual, I think it's a very challenging case also, and we can keep on discussing this ocular TB. But a quick few points. I feel that means whatever insight we have on the role of ATT in reducing the recurrence of ocular TB probably emerges after the completion of the entire course of ATT, not immediately after 2-3 months of starting ATT. So I think this is very well now proven. And if you see that evidence of drug-resistant ocular TB, I feel it is very, very limited evidence we have, and we should not pay attention to that. And if you see that the role of immunosuppressive in managing such recurrences, in ocular TB is increasingly on the rise. So there was a time we used to feel that if you start immunosuppressive in ocular TB, it can actually lead to a disaster and all. I agree there are certain clinical phenotypes where you have to be very, very careful, like subretinal abscess and all. But these are the cases like retinal vasculitis, choroiditis and all. These are the cases probably represents that hypersensitivity mediated ocular TB. So I think we have to be little balanced while using the immunosuppressive. I think one of the best option I felt is that mycophenolate mofetil is a good drug. The reason is that because ATT can also cause deranged LFT. And if you see that other immunosuppressive like methotrexate and azathioprine, these are also known to have a lot of hepatic issues. So mycophenolate mofetil with steroid, in this cases actually can help to prevent recurrences. Biopsy, I won't suggest in these cases.
I agree. So there's a lot of work coming out now, which categorically is showing that methotrexate, folitrax, whatever you use, is causing a lot of liver fibrosis as with increased usage. So a lot of people are now telling patients who have been on methotrexate for 5, 10, 15 years to get not only LFT, but also go get a liver fibroscan, a liver scan done to see whether you can continue the methotrexate or not.
Thank you, Dr. Salil. We are 30
Sir, can I ask one question?
Sure.
So when do I start immunosuppressants, or if at all there is recurrence, or should I wait for ATT?
No. I think you should start straight away. Give steroid plus immunosuppression for about 4 to 6 weeks, and then gradually start tapering the steroid, because by the time the immunosuppression will kick in.
So, and this patient, sir, particularly complained that she had for years irregular menses and all those systemic issues. So post starting of ATT, all those issues came back to normal. Like, is there any?
I can't think of I can't visualize anything like that. Sorry.
So
I can't visualize. Maybe her gynac may have some opinion on that, but I can't visualize anything. Sorry.
Okay.
I think, sorry to come in. I think in interest of time, we need to move on.
Thank you.
Sure.
This is a never-ending discussion, but excellent case, Hitesh. I think we can talk for hours and hours. So with the permission of everyone else, can we move on to the next case?
Sure.
Yeah. So now let me call upon Dr. Sarvesh Tiwari for the next dilemma in uveitis.
Yeah.
And we have our expert.
Hi, everybody. I think there's some issue with my uploading. Can you see my video? Can you see me on the screen?
Sarvesh, you seem to be missing.
Can you share your video, Sarvesh?
No. I've actually I can't see my video, but my audio, and I can hear you all comfortably. Am I audible clearly?
Yes, we can hear you very well, but we can't see anything.
Yeah, even I can't see myself. Okay. Can I share my slide, and just let me know if I'm no?
Yes, you can share your slide.
Yes, Sarvesh, we can see your slides.
Yeah. So I think
okay, go ahead.
I'll go ahead then, because there's some issue with my video.
Don't worry.
So, okay. So thank you, Moscon, for giving me this opportunity. So without wasting time, I'll start with my case. So this is an interesting case in which, there's this 30-year-old male who came to our OPD with the complaints of defective vision since one day. He didn't give any systemic history which was relevant. There were no history of any prodromal system, no travel history. He did have pets at home. On presentation, his best corrected visual acuity in the right eye was 618, while it was 6.6 in the left eye. The anterior segment was unremarkable with no positive findings. And on fundus evaluation, this is what we found. The left eye fundus was absolutely normal, while in the right eye, we could see these multiple whitish placoid lesions, which were like seemed to be multifocal sort of. There was a subretinal fluid, which was involving the macula. As you can see, there was a subtle disc edema, and the anterior vitreous face showed around grade 2 cells. So he had some degree of mild vitritis also. Looking at these findings, we took an autofluorescence image. As you can see, the areas corresponding to the choroiditis appear hyperfluorescent. The right image is the infrared image of the same patient. So after this, we decided to do an FFA for this patient. As you can see in the early images, there is areas of hypofluorescence. And as the time progresses, you can see the areas of hyperfluorescence corresponding to the lesions and the area of pooling in the subretinal space. Also, if you watch carefully, we see a hot disc. So in the late stages, even the disc was showing a lot of activity and leakage. This is the OCT for the patient through the lesion. You can clearly see a neurosensory detachment adjacent to the area of the choroiditis. Another interesting thing we noticed, there was an area of hyperreflectivity extending from the plexiform layer to the retinal pigment epithelium. And also, if you carefully see, the retrohyaloid cells were also visible on the OCT, suggesting the vitritis which I quoted before. This is the optic nerve head OCT. You can see there is subtle disc edema there. So with all these findings at differential diagnosis, the clinical differential diagnosis at this point I had was first atypical toxo, VKH, or atypical APMPP. We did a complete uveitic workup for posterior uveitis, and most of the investigations like MAN2, IGRA, VDRL, TPHA, X-ray, everything came out to be negative. Only thing which was positive was a antitoxa and plasma antibody, which were elevated, both IgG as IgM. So with this, keeping these things in mind, we arrived on a diagnosis of atypical toxo retinochoroiditis, and we started the conventional 6-week treatment with Cetran DS along with oral steroids. What you're seeing is the fundus photo at 6 weeks. You can see a complete resolution of the lesion with no SRF anything, and the visual acuity had improved to 6/6 at this point. But what was perplexing is that even as you see the complete resolution, there is no scar anywhere evident. This made me rethink my diagnosis, whether what I was treating was really a toxo or was it something else. You can even see the OCT. This is at the OCT after 6 weeks, complete resolution of the fluid and the choroiditis without scarring. So these two other conditions which came to my mind, one was mutes, one was APMPP. Mutes obviously is it's unilateral and more common in females. Though APMP was in my mind, but there were some things which were not matching with it. So let me just highlight those cases. Now in my case, the points which were in favor of toxo were, first, the patient was immunocompetent. There was mild vitritis present. There was a serous macular detachment noted. Though we know that macular detachment is an unconventional finding, but it has been reported in literature. FFA showed an early intense hypofluorescence. There was a history of animal contact, and the patient had high antitoxo titers. Now, what was unusual was there were no typical retinitis lesions, no obscuration of blood vessels. The lesions were multifocal. They all healed without scarring, and there was disc edema. Now, there have been case reports suggesting atypical toxo can present with serous macular detachment, disc edema, as well as vasculitis. So that is what made me think initially that the case I'm dealing with is toxo. This is the literature of suggesting toxo can present with neurosensory detachment. Now, also there have been case reports like of atypical APMPP. These cases, though we all know that APMPP is usually bilateral, but in atypical cases, it can be unilateral with serious neurosensory detachment, vasculitis, and papillitis. 3 of these findings were present in my case. And the usual part is that the patient responded wonderfully to oral steroids. So all these findings made me think that what I cured, though my patient was cured and happy, but what exactly was I dealing with? Was it toxo or was it an atypical APMPP? So the points which were against it, APMP in my case was unilateral. There were no prodromal symptoms like flu-like fever, anything like that. And there was a mild vitritis, which is unusual in APMPP. So with all these, I rest my case with some unanswered questions like what was the correct diagnosis of this case? And could this case could have been approached in a different way than the way I did? So the questions are open to the panelists. I rest my case here.
Thank you, Sarvesh. All well that ends well, actually. And is Dr. Anand there? I don't seem to get a response from Dr. Anand. Partho,
He's here.
Yeah,
Toxo,
sir is
IgG,
here. Yeah.
IgM done.
Can you hear me?
Yes, sir.
Yeah, Dr. Anand. Yes, we can hear you.
Hi. Yeah. Hi. No. So Sarvesh has documented the case very well. And my first question to everyone is, would you have done a toxo titer in this case in the first place? So looking at the clinical features, it looked more like amphigenous to me. So in such cases, I may not have even done a toxo titer in the first place. So to get a diagnosis of atypical toxo after that will be very difficult. But I think Sarvesh has done a very good job. So I think I will ask these questions to the expert panel and get some more clarity in this case. Any comments, Partho?
Partho, I'll leave the comment to you. I know how much you like Toxo IgG.
No. See, I believe that there are atypical form of toxo exist, which we don't know how to explain. But I hear this is classically example of like, if you don't know that how to cook a fish, no, better don't try to catch it. So I think this is there is Dr. Anand rightly pointed out that why the toxo titer was advised in a case of serous retinal detachment where you don't have a single solitary focus or not that much vitritis, or I think that was the most important thing. And second thing is that toxo titer actually cannot rule in or rule out any diagnosis. The toxo is basically a diagnosis clinical suspicion. And the healing pattern wise also, Dr. Sarvesh has rightly pointed out that it does not look like that. My question is that, was there any history of pain in this patient?
No, sir, there was no history of pain.
No pain or nothing, no? So I was suggesting, it is, if you look at the APMPP also, if you see the lesions are usually placoid and multiple. And this looks like if you go by the FFA picture, there is pinhead leak and showing the placoid pulling of the dye.
Correct.
So there are so many conditions. Usually the stromal choroidal inflammation causes that. So the most common, etiology-wise, if you see that these are the Vogt-Kwanagi Harada, posterior scleritis, sympathetic ophthalmia, this all comes under this picture. So I'll suggest that it can be idiopathic, any inflammation. Watch the patient carefully. Maybe you have started the treatment early, the steroid early. Look at whether the other eye is getting involved after a period of time or not. And look carefully. Always, sometimes we always believe that the posterior scleritis means there has to be pain. But if you look at our series, 13% of the patient of posterior scleritis presented without pain also. So it's not always that the pain rules in a diagnosis of posterior scleritis also. Look for the subtle changes, follow up this patient for some more time. I don't think it is toxo.
So, Partho, you want to say picture abhi baki hai?
One thing,
like that.
Yeah. So sorry. One thing which I would just point out that this case is actually 3 months old. So initially I had a doubt that am I looking at some sort of a leakage like thing? So we kept the patient under follow up, but it's been 3 months and the patient is absolutely fine in the other eye. So that's why it is perplexing in this.
Patient is on steroid now?
No, sir. No longer. No steroids. No immunosuppressives.
Okay. The patient is just okay. Then just watch it. Let's see.
Okay, sir. Okay.
So if Dr. Santosh is fine, can we move on to the next presentation? I think Dr. Samyak is waiting.
Thank you, sir. Thank you.
Yeah, thank you. Samyak?
Yes.
Yeah. Please.
Sharing my screen.
If Samyak comes in Sarvesh's case, I would keep my radar on for syphilis.
Okay, sir. Sure. Point taken, sir.
Yes, absolutely. And I would for a lymphoma.
Okay, sir.
Is my
We're
screen
having that
visible?
next. Yes, absolutely. Samyak, please.
Yes, thank you. So I'm going to speak about masquerades without directly going on to the case. So this happened in August 2022. We had a 42-year-old male who presented with bilateral, gradually painless, progressive diminution of vision for about a year. There was no history of any redness, any discharge. Now, looking back at his reports, he had an ultrasound done in November 2021, about 8-9 months ago, which suggested vitreous cells of vitritis in both the eyes. Based on that, he was diagnosed as bilateral pan-uveitis at another center, and oral steroids were started. And he happened to improve on these oral steroids. But when these oral steroids were tapered, he worsened. So he was, given 2-3 courses of oral steroids on and off. If you look at the right eye, the fundus photo of the right eye, vision was about 660. So you could just see faint, idea of the fundus. There were cells and flare, some keratic precipitates as well, and a posterior subcapsular cataract. But there was no, as such, vitritis, no snowballs, no choroiditis, or no vasculitis. Similar picture existed in the left eye, but the vision was less in this left eye. So counting fingers, 1 meters. Going back to the past, yes, 20 years ago, he did have type pulmonary tuberculosis and he was treated completely. But in 2015, about 12-13 years after treating TB, he had a recurrence of tuberculosis. And this time he had spinal tuberculosis, tuberculous osteomyelitis. And the one which was recurred was a multi-drug resistant. So he was given linezolid, there was rifampicin resistance. So coming back to 2022, when his X-ray chest was done, of course, it showed some fibrocalcific shadows and old changes of healed tuberculosis. So did it look like TB uveitis? I mean, probably yes, that this is probably could have been a recurrence. Now, digging back into his history, in 2008, now he was 28-year-old at that time and he had neurological symptoms for which MRI brain was done. Neurosurgery was done and a stereotactic biopsy was taken of the interest lesions, and it showed a CNS lymphoma, a primary diffuse large cell CNS lymphoma. And he was put on high dose methotrexate and everything. Radiotherapy was given, and in the subsequent year, he was completely treated. No remission, no recurrence. Now, with this data, we spoke to the oncologist in detail that, don't you think this is a primary recurrence of the primary disease and the fundus picture looks something different? But the opinion was like, no, this is unlikely because we've treated him completely. So we said, okay, at least let's run the diagnostics, imaging tests again. So CT brain was done at that point of time and showed there is persistent gliosis, which is one of the indications of the treated lesion. So there was no recurrence on the CT brain. The MRI of the spine was done, which again suggested that this is old changes of post-treatment of the tuberculosis lesions. And of course, the X-ray chest showed old healed TB. Now, interestingly, when the CT of the brain was done, and it included the CT of the screening CT, when the PNS was done, there was a soft tissue lesion located in the nasal cavity. Now, was this TB or what was it? So, coming back to the timeline, pulmonary TB in 2002 treated well, CNS lymphoma in 8 and 9 treated well, recurrence of pulmonary tuberculosis in 15 and 16. He underwent all checkups, protocols, follow-up. He has a good follow-up. And when he presents to the eye in 2021-22, he has vitritis and everything. Oncology says he's completely treated. Neurology says he has no recurrence. So looking at the fundus photo again, you can see that these are not vitreous, these are not snowballs or anything, but they look like loose sheets of cells of vitreous. And that's what was not fitting into the picture. The clinical pictures actually did not correlate with the diagnosis of pan-uveitis. So we insisted, let's do a biopsy, let's biopsy the vitreous and also biopsy the nasal mass. Kind of was a bit of, it required quite a bit of convincing to the oncologist as well as to the patient. So this nasal mass which was sent, the immediate report came that this is not lymphoma, but these are not granulomas as well. But it eventually turned out to be a sinonasal teratocarcinoma, which is a very, very rare tumor from the nasal mass. Now, we didn't know what was happening. So we did a 25 gauge vitrectomy, which revealed diffuse large B-cell lymphoma in the fluid cytology. Now, when this report came in, immediately a day or a couple of days later, the CSF was done. And the CSF then revealed occasional atypical lymphoid cells. So the CNS did not show anything in the evaluation other than that the CSF showed very, very few occasional diffuse cells. The CSF was also subjected to TB evaluation, but which was not detected. Eventually, he was treated with injection rituximab, high dose methotrexate. He couldn't tolerate methotrexate and he went into septicemia, had neurological deterioration, so on and so forth. So let me just sum it up that masquerades, you never know unless you see something that doesn't fit into the picture. It can well be a very great challenge.
Thanks.
Thank you so much.
Thanks, Samyak. We have about 2 minutes before we go to the next case. So quickly, Dr. Paritosh, would like to invite Dr. Paritosh.
Fantastic case, Samyak, and fantastic management. So whenever there is recurrence of relatively quiet vitritis or a relatively quiet, without so much of a red eye, recurrent uveitis, you give steroids, it gets suppressed, and you taper it, it again recurs. If it happens 2-3 times, then in fact, the second time it happens itself, once antenna must go up with regards to lymphoma, vitreoretinal lymphoma. The MYD88 mutation in the aqueous, though the sensitivity is little low, but it's very highly specific. So that is one thing I would suggest in cases of recurrent so-called uveitis and relatively quiet eyes with vitreous cells. The important thing to understand here, just from basic sciences, I'll take a couple of minutes extra, please, Mayur, is that this gentleman had TB twice, and then eventually had he had in between a primary CNS lymphoma, then a different tumor. So basically, these are people with impaired lymphocytes. In this case, there's impairment of both the B and the T group of cells, just to look at the immune function kind of a thing. I think the management was excellent. We just have to keep a lookout. Just a word or two about the collection of the biopsy, that the steroids need to be systemic steroids need to be stopped for about a week or so, because corticosteroids can be lymphocytic. Also, they can reduce the amount of cells leaking out of the blood vessels. So your density of cells may reduce. Cells, if they are necrotic, then obviously diagnosis by the histopathologist may go down. So just doing a cytology is not sufficient. One should, have a multi-pronged examination of the vitreous biopsy, cytology, of course, but also do staining and do the MYD88, which is highly specific. Though it's positive, I believe, in about 70 to 80% cases only. So far as the treatment is concerned, I think in bilateral cases, we go ahead with either systemic chemotherapy with a multi-pronged attack or external beam radiation would be the treatment of choice in a bilateral situation. If somebody is not tolerant as over here, then rituximab would be the agent of choice. In the future, there are going to be antibody, meaning currently rituximab, for example, is an anti-CD20 antibody. In the future, we'll have something anti-MYD88 also, and more than that, we are likely to have agents which will cause necrosis of these lymphoma cells, kind of inducing apoptosis in them. So we hope to have more remissions in them. In fact, this patient, despite B and T cell abnormalities, he survived quite well, according to me. The survival rates are relatively poorer, but here it's an example of good survival itself. So thank you very much, and I
thank you, sir.
And the MOS scientific committee and the MOS.
We have about 8 minutes left, and I think to do justice to the next speaker, we should move on.
Yes, thank you.
Drushti, you have your full 8 minutes. Dr. Vatsal Parekh, sir, and Dr. Santosh Agarwal, sir.
Screen.
Sir, is my visible?
Drushti, we can see that you are sharing the screen. Can't see your presentation.
Doctor, you can stop and reshare. I think it is stuck. Just stop and reshare, please.
Hi, everyone. Okay. Okay, sir.
I also trying to stop, but it is not going off. Yeah, it's gone now. Just retry again, please.
Yeah. Yeah. Is it visible now, sir?
You need to reshare, doctor. It's not there.
Mayur, any thoughts? Okay.
Are you on, doctor? Are you on Mac?
No, I'm on a lab.
But
no, I'm
I
not on
believe
Mac.
there is a network issue or something else. Yeah,
we just
it
saw
just
it.
came.
Just
Last try, just same. Can you just repeat the same process?
Yeah. Now,
just allow it another 10 seconds or so.
Drushti, there might be a problem with your internet bandwidth. So perhaps what you can try to do is switch off the video that you have.
Yeah,
Drushti, we are here. You're good to go. 36 slides.
yes. Right, sir.
Drushti, you'll have to be a little quick. We have to hand over.
Yes, sir. Yes, sir. So I'm going to present a case of a unilateral array, a case of VKH syndrome in a young girl. So this 15-year-old girl came to us months back with the complaints of diminution of vision, redness, and pain in the left eye since 15 days. She was locally treated in Rajasthan with topical and oral steroids 20 milligram per day for the last 3 days. So at presentation, she had a visual acuity of counting finger close to face and near vision less than N36 in the left eye, with the anterior segment being normal and the fundus showed disc edema, macular edema, and an inferior bullous retinal detachment. So this was at presentation where you can see the disc edema, the inferior detachment. The RP was also uneven. It was as though there is something pushing in the choroid. There was some fibrin as well over here. So we did an FFA, and here we can see that there was leakage and disc edema, leakage and staining in which confirmed. The ICGA also showed some the mid phase and leak in the late phases. She didn't have any other systemic illness or previous episodes. We started her on IVMP for 3 days, 1 gram per day, and she was advised to do blood workup and other investigations. Now, just after 1 dose, her vision improved to 618. The macular edema was also lesser, but she started developing fibrin. Her investigations were essentially normal. So this was how the disc looked. On the 2 days follow-up, the macular edema was much lesser. The RP was also settled. This is a comparison of the 2 days where disc looked much better. But the edema was still there. The inferior detachment was still there. The macular edema was settling down. This is a comparative. We also have to rule out, sign and steroiditis. So along with oral steroids, she was maintaining, she was doing well, but the detachment was not settling. So we added methotrexate. But the native RD was quite refractory, and in June she visited Shankar Netralaya, where they started biologics, so adalimumab subcutaneous injections once a week, along with mycophenolate mofetil. So that, along with the methotrexate and omnipotil, detachment settled down. She maintained visual acuity about 612, 6.9 in that eye for the next 2 months, and she was under regular follow-up. But on 16th of August, 3 months after the initial presentation, we noted a disc hemorrhage on examination, and we did an angiography which confirmed that there was a CNVM membrane. So this was on 16th of August, which after 2 weeks, there was this entire hemorrhage and CNVM seen over here, which also was seen on the OCT. We did an FFA, where the CNVM was demonstrated, and the diagnosis was confirmed. So we gave her 2 injections of Eylea 1 month apart, and you can see on fundus imaging that she responded quite well to it. And after that, these are the comparative OCTs, August and October. So, but in September, she developed pneumonia. So we had to stop all her immunosuppressants, and we kept her only on a minimal dose of 5 milligram oral steroids. From September to March, she maintained with that. Her vision was also 6.9 and 6, and she was under regular follow-ups. But in March, again on OCT, and we saw that there was reappearance of subclinical disease. The fluid appeared again. So we hiked up the oral steroids to 30 milligram and added mycophenolate mofetil 2 grams. With that, she was doing much better. These are the comparative photographs in March and April. But so you can see over here, the edema was quite okay. So this was at presentation, and this was after pulse steroid and biologics. This was resurgence in March this year, and then this was in May after she was put on mycophenolate and tapering steroids. These are the FFAs we did in March and April, where you can see that the disease was still active. And there was also appearance of disease in the right eye, which was previously normal. So this was, and then we did an ICGA in June this year, where you can see that in the late stage, there was hypersinescence in the right eye as well as in the left eye. So when we compared these ICGAs between which we did in September, the top ones are from September, the bottom ones are from June, that in the late stage, there was an active disease in both the eyes, the right and the left. So we shifted her, so we started her on mycophenolate 3 grams. Then we shifted her to 3 grams and oral steroids. And for now, she's doing well. She's maintaining her vision. So we plan to continue immunosuppression for the next 2 years. We stopped it due to the pneumonia, which led to clinical disease reactivation. So I open the case for discussion whether we should have treated her differently or whether we should have given her IVMP again for the subclinical disease which came up. I would like to thank Dr. Amod Gupta sir, Biswas sir, Dr. Vishali Gupta ma'am, and PMR sir, who have been jointly managing this, helping us manage this case. And I rest my case here and I open it to discussion.
Inviting Dr. Vatsal for his comments, and then Partho and Dr. Santosh for the quick roundup. We have
to begin with, can you hear me? To begin with, this appeared to be unilateral case, so Arthro thought it of osseous keratitis, and it responded well to biologics. After pneumonia, we stopped all this immunosuppression. In March, there was disease reactivation subclinically, those who maintain normal visual acuity. And as you saw in this patient, FFA and ICG in subclinical stage demonstrated the disease activity much before the clinical symptoms started. So I think that was helpful. Now the question is whether we should have given withheld prednisolone again, or the way we are continuing, we should continue for 2 years. So basically this shows importance of ultrawide field FFA ICG and picking up the disease early.
Partho, any quick comments from you?
Yeah, I think Batsal sir, as I told you earlier also, this is excellent. Like documentation, no one can beat you, and that's why you are so successful. Every time picking up at the just because the disease starts and you can pick it up. 2 points quickly. I always feel the prefix idea that which we ophthalmologists have. No, it's so dangerous. You won't believe me. These are the children. Actually, you can actually treat them better with both immunosuppression. And we have a pediatric rheumatologist, Dr. Ramanan from Bristol University. We have a series of cases where we have treated it with both mycophenolate and methotrexate. But when you go to publish it, all the standard journals, they are writing that both immunosuppressive, both are antimetabolite, you can't use them. Whereas there are all other subspecialty like rheumatology, even in dermatology, they are using these medicines. But it's impossible to, even the peers of the ophthalmologists who are treating uveitis and inflammation, no, they are not ready to accept. So that's the problem. I think this is a very classical example where the aggressive immunosuppressive can help. And the problem is we try to reduce the immunosuppression thinking that what will happen to the child. I understand the child had pneumonia and so we had to actually stop that. But I think if you keep them on higher immunosuppressive, aggressive immunosuppression, no, they do well. Thank you.
Thanks, Partho.
Thank you.
Santosh Agarwal for the final.
Yes, in such cases, what I think aggressive immunosuppression, as well as you have to taper it very slowly. You have to keep on for long time so that there will not be any recurrence. So you have to balance everything. You have to take help of rheumatologists and other things. You have to look for the systemic, any complications, everything. You have to be very cautious about all those things. And for a long time, you have to continue the treatment so that you will not have any recurrence. Very excellent case. Nice discussion today.
Thank you. Thank you very much, sir. Is Piyush here? Dr. Piyush?
Yes, sir.
Yes, please.
Thank you. Thank you very much, sir. With such extensive discussion and completing it in almost 54 minutes is something that is quite miraculous. So we'll quickly move on to the next session. Thank you very much, everybody.
Thank you.
Is
Thank you.
Dr.
Thank you,
Sumit
Piyush.
and Dr. Aditi there?
Thank you, Piyush and Mayur. Excellent.
Thank you, everyone.
Piyush, I'm there.
Excellent presentation and discussion.
Yes.
Thank you.
Aditi, maybe you could invite the moderators of the next session and then take over.
Yes. Dr. Namrata is also there. I think she
Yes, I am here. A very good afternoon, everyone, and welcome to our dilemmas and oculoplasty session today at the midterm Moscon 2025. And at the outset, I would like to welcome the chairpersons of the session, Dr. Darade sir, the chairman of the scientific committee, Dr. Piyush Bansal, and also Sumit Lane, who is the secretary. And without further ado, I would like to start our session. We'll be starting with 6 interesting cases lined up for today. And the first speaker we have is Dr. Milind Tsangole. Dr. Milind?
Hello, ma'am.
Yeah.
Can you manage to hear me?
Your presentation. Yes.
Okay,
The expert panel
Good
on
afternoon.
Dr. Milind's case is Dr. Soham Pal and Dr. Mangesh Dobekar. So, Milind, over to you.
Good afternoon, everybody. Thank you for the opportunity. So it's a very interesting case where the animal lover adopt an orphan puppy and local Indian stray who bite her later when grown up. The bite was deep
Dr. Milind, can you
enough
start your
and
camera,
powerful.
please?
It will the mask. Is my slides visible?
Yeah, can you just start your camera, please?
So it will hamper the presentation. Hello?
Yeah, please continue. Please continue.
Yeah. So this was the pre-op picture showing the right eye where the upper lid and lower lid canaliculus tear was there with avulsion. And this is the left eye, which is worst eye, where the upper lid and lower canalicular tear was there, along with the medial orbital content was pop out. So the patient was thoroughly examined and the history was taken. It was found that she has received local treatment and rabies prophylaxis in the form of immunoglobulin, and also she received the antibiotic, IV antibiotic. and patient come after around 8 to 10 hours. So how to proceed? There are a national guideline for the rabies prophylaxis, which tells you that this type of wound is nothing but the category 3, where there is a multiple transdermal bite and the scratches. So it has a management in the form of wound management, rabies immunoglobulin, and rabies vaccine. Wound management is wash the wound, apply the antiseptic, and uh, inject the immunoglobulin around the wound, and remaining amount into the thigh. Rabies vaccine prophylaxis as a post-exposure prophylaxis for category 3 has to be advised, and keep the dog under observation. Ours was a home dog which was vaccinated. Though it states that vaccination does not means the dog is not having rabies until and unless we check for the antibodies titer, which we generally don't do. And by the history, it was a provocative bite. So with this taken into this mind, there comes the conflict whether we should suture it or not. If you don't suture it, then you open this atlas and you will find out n number of diseases which this female will encounter in the future life, including ectropion, entropion, watering, and of course squint, because there was a avulsion of middle rectus also. So we go towards the deciding towards the suturing, as the patient has already received immunoglobulin, and the greater part where we have to take care of tear pathway and the muscle movements. So decide the suturing, decide to place implant, and decide to explore the MR. So this is the video showing that upper lid. This is the canalicular repair going on. We decide to do a right eye first because it was a less damaged eye. After securing the lower canaliculus, upper canaliculus was also secured. I generally use single stent in one canaliculus. I don't do bicanalicular stenting because in such case I think it is better to do less damage. You can make out that even though the extensive laceration, we can make out the distal end because the case is fresh one. Then subsequent surgeries was carried out. Now, once we move to the left eye, you can make out that there is an entire medial orbital content was pop out, including fat. Here we are trying to isolate the medial rectus, which found to be ovals, but it's a partially ovals. And to by patient's luck, we can make out that there is a hematoma which is buried deep into the orbit. And this told you that this hematoma is connecting to this hematoma, where the muscle probably has get detached. So the 60 vicryl suture was used to suture the split muscle, and suturing was carried out. Once it is done, the upper canaliculus repair with avulsion was repaired. So this is the matrix suture placed from the lid to bury all the orbital content into the orbit. Look, while tightening, the content are getting buried out. And the canal mini monoco stent was also placed. 1, 2, 3, and yep, the content get buried. So no additional suturing was done in this region apart from margin suture, and the subsequent laceration was repaired, including conjunctival laceration. So after this, this is her post-op 2 weeks after the suture removal. You can make out there is a slight punctal eversion present in the right eye, but ocular movements are barely good and no diplopia in primary gaze, though there is a extreme diplopia in right gaze. And this is her post-op 4 month, where left eye has a ptosis, but the patient was not having any functional problem. Thank you. So dog bite is very traumatic experience to the patient. It is very disfiguring and can lead to functional problem. Guideline is there. Just don't rush. Take a good history and follow the guideline. Hello.
I would like to invite Dr. Soham Pal and Dr. Mangesh Dobekar to give in their expert comments on the case.
So excellently managed case, Dr. Milin. I congratulate you for the nice management. So one thing was not mentioned was how much immunoglobulin should be given at the wound site and how much immunoglobulin should be given at the remote site.
So
Yeah.
in eye, sir, can I answer?
Yes, sir. Yes.
Please. The lead has a very small structure. So whatever amount you can infiltrate, you have to infiltrate around the wound. Remaining you can inject into the thigh. The dose is depending upon the body weight. And depending upon the which immunoglobulin you have used.
Yes. And yeah, so first thing is irrigation. So did you perform the irrigation over the wound site or that was actually
Luckily,
not
patient
mentioned?
was a physician's wife. It was well irrigated for almost for a 2 liter saline in the both eye. And they aware about the immunization. So the injection of immunoglobulin also does. So the only part it is not infiltrate around the eye. So we infiltrate around the eye.
Okay. Yeah. Thank you. Nicely managed. Yes.
Thank you. Thank you, sir.
Thank you, Milen, for putting up this case. This was really a need of an hour. What happens most of the times, whenever we get such a dog bite in the periocular area, actually we get most refer cases, and most of these cases are unsutured. And then they will land up in the superficial infection and again a deeper spread of the infection, and then everything is messed up. So it's very important message to give through this case that whenever you get a dog bite case, you just have to think about giving the post-exposure prophylaxis as per the guidelines, and then you can take it as a normal case what you do in otherwise non-dog bite cases. This is a very important point. And as Soham has rightly pointed out, wound toileting is a very important point in this case. Though the bite of the dog is the deeper one. Okay, whatever happens is just because of the result of the avulsion. Okay, means even the orbital soft tissue contents from the medial side of the orbit may come out, and they may cause there is actually a dog bite, but most of the times it's not a dog bite there. It is just a result of the avulsion injury what we see in the medial part. Whenever there is a prolapse of the orbital contents, I think imaging is warranted. Did you do that?
Sir, actually, we plan to do MRI, CT, but the patient was very agitated, and they were almost, it's a night time. So CT was advised post-operatively. Luckily, she is not having any orbital fracture.
Okay, good. And this idea of putting 2 mini monoca is also a good one because it is sort of minimally invasive. The only thing is that mini monoca doesn't offer any counter traction. So it's very important to attach the medial part of the sort of the caruncle properly to the deeper part of the MCT, because that will give you a medial stabilization, and most of the times this doesn't happen, then it will land up into the sort of medial laxity, which might be seen in the medial part of the upper lid and most prominently in the lower lid. Good case,
Yes.
nicely managed. Congratulations.
Thank you, sir.
Thank you so much for the expert comments and good presentation, Dr. Milind Changole. So
Thank you.
we'll move on to the next case, which is to be presented by Dr. Abhijit Kothari. He'll present on delayed eyelid retraction post-ptosis correction. Let us stick to the time. Just please maintain the time so that we have enough of time for discussion and all the case presentations. And we will invite Dr. Namrata Adulkar and Dr. Shubha Zawar Madam as expert panelists for this case. Dr. Abhijit, over to you.
Good afternoon, everyone. Myself, Dr. Abhijit Kothari, and I will be presenting on delayed eyelid retraction post-ptosis correction under the guidance of Dr. Sonal Yadav, ma'am. So the case was a 27-year-old female patient, professor by occupation. She is presented to our OPD in 2019 with a complaint of left eye drooping since approximately 9 months. So we go through her negatives such as any aggravating, there were no aggravating relieving factor, no history of any trauma or ocular allergy. Then no history of any contact lens wear, no history of any drug uptake or previous ocular surgery, or no improvement in ptosis when waking up. Significant medical illness history was not there. So on examination, her she's average built and well nourished, and the systemic examination was within normal limit. So ocular examination, the vision, she's a myopic with a right eye refractive correction of -2 diopter with the visual acuity of 6/6, and the left eye refractive correction is -1.5 diopter with visual acuity 6/6. On examination, patient is orthoptic with full extraocular movements in all the cases with mild facial asymmetry due to left eye ptosis. So the slit lamp examination was within normal limit with left eye ptosis was there. So that we did a ptosis measurement. So in left eye, there was a 2 millimeter of ptosis with a decreased palpebral feature in down gaze with a good LPS and good bells with a margin to crease distance of left eye is 10. Came to the diagnosis of left eye mild acquired ptosis and aponeurotic ptosis. So patient was asked to do the follow-up after 3 months. She did a follow-up and she was very much interested to get it operated for the cosmetic correction. So we again measured the ptosis amount and they were exactly same as that of previous visit. So we decided to go ahead with the surgery of the left eye LPS reinsertion via anterior approach. So after the surgery, she did a follow-up as advised on 7 days, 3 weeks, and at the end of the 2 months, we can see the both eyes are looking same, and PFH is also good, nearly similar. So then in between she was doing proper follow-up every 3 yearly. In October 2021, she again visited to our OPD with a complaint of left eye, which was operated, is looking bigger than the right eye. We evaluated her medical history and she had got COVID in 2020, for which she was given a steroid, high dose of steroid as a treatment. And in 2021, she was diagnosed with thymoma, for which she got operated. Thymectomy was done. So the brief history, in first visit in 2019, she has a left eye ptosis. Then we operated her. The 2-month follow-up in October 2019, she has a good correction. And when she again visited us in October 2022, there was a retraction in the operated eye, upper lid retraction. This was the picture in various cases. So the ptosis evaluation was done, and there was a 2 millimeter of retraction in the left eye with good LPS, good bells, and rest thing you can see. So we were in the dilemma that what could be the reason for the retraction in the operated eye. So we thought that it could be because of a thyroid eye diseases. So we asked her for the thyroid function test and anti-thyroid antibodies with USG thyroid. Anti-thyroid antibodies was negative, thyroid function within normal limit, and USG was also normal limit. Since she has a history of a thymoma excision, we also went ahead with the serum marker for the myasthenia gravis to rule out whether we had missed previously subclinical myasthenia. But the serum markers were also negative. Then we asked for to observe and follow her at a 3-month interval. So at the end, 8 months after that, she came. We again evaluate her, and the retraction was pretty much same as the previous visit. And she was very much keen to get operated for the cosmetic correction. So we decided to operate her with the left eye mullarectomy with LPS reinsertion was done. So at the end of, you can see there is a good amount of similarity is achieved. So there was a dilemma that why the eyelid retraction post-ptosis repair occurred. So we mainly arrived at 3 main reasons. One is the overcorrection, or second is the scarring, and third is the inflammation. Overcorrection was ruled out because it would have come after we could have observed it in 2 weeks after the operation, first surgery. But at the end of the 2 months, she was absolutely all right. Inflammation reason was there. To rule out it, thyroid eye disease, we did a basic investigation, and those were the negative. So the COVID history was there. So to correlate, means actually patient has a history of a thymoma. So to we went to the various article, and we found that 50 to 60% of the thymoma are solitary with no relation, means no myasthenia gravis. But in few cases, after the thymectomy of the solitary thymoma, the myasthenia gravis can occur. So we asked her for the serum markers, and that were negative. So post-COVID inflammatory response, the systemic inflammatory response contribute to or exacerbate the existing inflammatory tendencies. This could be the one reason. Then the high dose of a systemic steroid were administered for COVID treatment. So catabolic effect and coupled with the impact on collagen and elastin metabolism could have subtle affected the already operated eyelid tissue. And compromised scar healing may be the reason because of the high dose of the steroid.
Dr. Abhijit, kindly wrap up.
Yes. So the conclusion is left eyelid retraction in the early or immediate post-operative period is well-known phenomenon. But however, in this case, there occurred a delayed eyelid retraction. Both local and the systemic factors can be the reason for the post-op retraction. In our case, inflammatory response is a sequelae of a COVID-19 infection and an effect of a high dose of steroid administered on the eyelid. Administered could be the reason for the this retraction. And meticulous evaluation and observatory period to rule out the eyelid height fluctuation followed by the titrating eyelid surgery helped our patient to achieve the optimal cosmetic outcome. Thank you.
Nice presentation, Dr. Abhijit. I invite Dr. Namrata and Dr. Shubha Madam for their expert comments.
Well, that was a good presentation, Dr. Abhijit. So what was your final diagnosis then?
So the retraction could be because of the COVID or the high doses which were given had hampered the healing procedure after the primary surgery, and could have caused the retraction, misfashion retraction. We thought of that.
Okay, so for how long was the follow-up later on after the second surgery?
She's doing regular follow-up till now, about at every 3 months or 2.5 month interval, and she is well maintained on that currently.
She's okay now. What about the other eye? The other eye was normal?
Yes, other eye was normal and thoroughly evaluated. She doesn't have any complaint of vision or any ptosis or kind of thing in other eye.
Okay, fine. Any comments you want to make, Dr. Sonal?
Hi, ma'am. Thank you. So we just wanted to share this because it did, it took me by surprise that she came up with a retraction of almost 2 years post surgery. However, the COVID inflammation, we are still finding out the sequelae of COVID-19 inflammations that the pandemic kind of brought us. So this might be one of those things because that fell in almost was within 6 months of her surgery. So probably that might have had some effect. The thymoma surgery also was something which kind of was a consideration point. However, even pre her first surgery, we had given her an ample time of observation where there was no fluctuation. And in fact, I did have her surgical video where the LPS was in fact hissed during intraoperatively. So there was no other etiology that we had missed while primarily kind of diagnosing her for aponeurotic ptosis. Very interesting. So possible scar modulation in the immediate post or not immediate but kind of late healing stage might have been the reason for the retraction. So more fibrosis along the scar line and the LPS muscle. That was ultimately my conclusion. But till date, she's doing very. So she's a professor in engineering college and is a very avid aware regarding her cosmesis. So she's doing well till now with no other systemic issues which have come up. So yeah, so I would chalk this down to post-inflammatory retraction.
Aponeurotic ptosis, then you have to look for her other eye too. Follow up with that, and then only I think you can confirm with the diagnosis, right?
Definitely, yes, ma'am.
Thank you.
Yeah, nice case, Sonal, and nicely presented, Abhijit. I would like to make a few comments. Yes, it is indeed very intriguing how she has thrown up such extensive retraction 2 years later. However, in young patients, what I like to do is ask them, to get back with their old pictures, and reviewing those really gives us a clue. Any young patient with an aponeurotic ptosis of for say 9 months, I would really try and look at all angles before jumping in for surgery. That would be one. Having said that, they're prodding a little bit more into the history of thymoma surgery. Would give some actual insights, because in thymoma, when we are seeing myasthenia, it's mainly a paraneoplastic syndrome, and once the thymoma is out surgically, the antibodies are going to be negative. So post-operatively doing an anti-MuSK or an anti-acetylcholine receptor antibodies is really not going to help us to confirm the diagnosis.
No, so we actually did a little literature search of that. So there is evidence that the patients who do not have myasthenia before thymoma may turn up with myasthenia after thymomectomy. That was the reason we wanted to check if that has something, to do with our case though. And euthyroid TED was something also which I had in mind even from the primary visit, because she always had a little bit of lower lid retractions. But she maintained euthyroid levels and no other signs of TED. And this was again only the operated eye retraction. There was no retraction in the other eye as well. Until date, she doesn't show any other signs of TED apart from the retraction. So that always, was one of the etiological factors considered, but cannot put exact finger on either of them.
Wonderful. Yeah, such is our specialty, I guess, keeps us on our toes all the time. Yeah, let's move on to the next speaker.
Thank you.
So the next speaker we have is Dr. Neha Srirao, and she'll be sharing her case on tricky situation, difficult decision. Dr. Neha, over to you. Can you share your screen, Neha? Please unmute yourself.
To all the speakers, I would like to say, please keep your presentations open on your screen first. Yeah, go ahead.
So, am I audible? Am I audible now?
Yes, Neha, you're audible.
Yeah. So this is one of the cases that I handled a year back of a 4-year girl who presented with sudden onset proptosis and redness of the right eye, and she had a history of preceding URTI before the proptosis, and there was no history of trauma and no other specific history. There was no fever or signs of any infection. On examination, her vision in both eyes was 6/12. The right eye had some proptosis And however, the optic nerve did not seem to be compressed. There was no RAPD. And there was mild congestion. The left eye was normal. So these are our clinical pictures. As you can see in the primary case, there's axial proptosis, and the ocular motility is limited in all directions. However, there's no signs of any inflammation or infection as per. So we went ahead with the MRI for this child. The right eye showed presence of a T1 hypointense mass. It was ill-defined, but not very dispersed out. It could pass off as a well-defined mass and was pushing the optic nerve laterally. In T2, the mass was heterogeneously hyperintense, and post-contrast showed some enhancement as well, heterogeneous enhancement as well. So since there were no signs of infection, and with these kind of imaging features, she was also admitted under pediatrics, and she was given a trial of antibiotics, IV antibiotics for 3 days, to which she did not respond. So I made a clinical diagnosis of lymphovenous malformation with hemorrhage, and she was given oral steroids in accordance with the pediatric consult in tapering doses. However, she came back 2 weeks later with her parents, absolutely no improvement in the proptosis, which one would expect if there is a hemorrhage and a lymphovenous malformation. So we had to rework the diagnosis, and that is the reason why we planned a orbitotomy. So there was, which would be used for a biopsy, and if intra-op, I thought I would see something like a LVM, then would also go ahead with a bleomycin injection. However, the incisional biopsy done via lid crease approach showed the presence of embryonal. I'm sorry. I think the presentation has.
We can actually see your presentation.
Yeah, okay. So the histopathology revealed the embryonal rhabdomyosarcoma with the IHC, as you can see. So she was consulted with the pediatric oncologist, completed 10 cycles of chemotherapy over a year. This is her when she came back in May this year. Her vision is 6/18. She has some ptosis, and the ocular exam otherwise is normal except for a dry eye. So in the repeat MRI revealed resolution of the lesion. So there was a dilemma in diagnosis from my end, and we know that orbital RMS can be misdiagnosed as multiple entities. It can masquerade as orbital cellulitis. On the scan, it was actually reported as a cavernous hemangioma by the radiologist. But since cavernous hemangioma is a very, very rare entity in children, almost never seen, I went ahead with the clinical diagnosis. Also, we know that sometimes the lymphovenous malformations do not show very typical features on the MRI, like flow voids or fluid levels, or the macrocysts, microcysts, and there are reports that they can pass off as a well-defined lesion. So keeping all this in mind, I went with the clinical diagnosis. But could this case have been handled any differently? So the take-home message would be that imaging and clinical picture both can mislead at times, but biopsy will clinch the diagnosis. And of course, as we say, orbit is a Pandora's box and keeps you humble in your practice. One must always have a high level of suspicion and low threshold for biopsy. So I opened this case to the panelists and for the expert discussion whether I could have done something differently in this case.
Okay. Thank you so much, Neha. So, firstly, I think I should congratulate you for your case selection, the choice of the case. Very well presented, and a thorough presentation, completely covered most of the points you could in 6 minutes. I think there was no other way to probably handle this case. You always have to think of the commoner differential diagnosis. You mentioned that it could mimic any of the orbital conditions. But this is a very important take home point for comprehensive ophthalmologists. We often feel that we are not going to deal with rhabdomyosarcoma. That's true. But here, the window to treat them effectively early on is so small that you should have it as a differential. And biopsy is the only way to confirm it. Having said all that, yeah, rhabdomyosarcoma is relatively well defined, is usually because it's a sarcoma and differentiates into striated muscle later. So it will be similar intensity, iso-intense to your extraocular muscles. And sometimes it can mimic sinusitis also. So we have to look at the epicenter of the disease, and this was very, very well managed. The only thing probably slightly differently I would have done is considering how in India we often lose patients to follow-ups, and being specialists in ocular oncology, we have to reiterate that, we maybe need to see the kid in 4 to 5 days if we are having this as a differential, so that the kids are not lost to follow up and we have the window to jump onto a biopsy faster. That's about it. Any comments from
Dr. Ramesh Murthy, sir, your comments, please.
Yeah. Yeah, thank you, Dr. Neha. That was a very important case in which you've highlighted a very important clinical presentation of sudden painless proptosis in a child. So in these cases, we have to think of malignancy like embryonal or alveolar rhabdomyosarcoma. Other differential diagnosis would be Ewing's and maybe acute myeloid leukemia. So the fact that it is painless is very important for us to reevaluate this child again and make sure that we go to the diagnosis, and biopsy would be very important. So if it was painful, maybe we would have thought of infection or inflammation. But now that it is painless, we have to be doubly sure that we're not dealing with a malignancy, which is like rhabdomyosarcoma or even retinoblastoma sometimes can present like this. So I think it was a very good case that you presented with a very important clinical message.
Yes.
Just to, I know it is like we are running short of time. Just a question to all. Like in all VLMs, if you really feel that it is VLM with hemorrhage, do you still go ahead with biopsy or just do bleomycin at a first shot? Or always go ahead with biopsy and then do it? Because I have had both the experiences. So I've again gone back to starting the biopsy, getting the biopsy first and then doing bleomycin like on table. So just maybe the panelists who are there for the case can comment.
So I think if it's fluid levels, you can see very classic, then there is no other diagnosis, and you can plan the bleomycin in the same take. And considering here, you couldn't see very classic fluid levels, though you could see some heterogeneity, which is little relatively rarer in rhabdomyosarcoma unless you have necrosis and bleeds, which are rarer compared to VLM. So you can definitely plan and keep the bleomycin ready. It doesn't make sense to go in twice. On table, if you make out that you can aspirate and there are macrocysts or there are aspirates, you can definitely go ahead with the bleomycin in the same sitting. Sorry to just add, I think another thing that slightly differently I would have probably done would not be starting the kid on IV antibiotics, because even for it to be a subperiosteal abscess with sinusitis, it was a relatively quieter eye which may have needed drainage. So just keep the kid under closer observation the first 48, 72 hours to look for the responses, the key over here.
Very difficult to convince the pediatricians when you're working in a multi-speciality that you don't need IV antibiotics. They will start it for a lid abscess also. They will start it for everything. So
Yeah.
it's better to just let them do their thing and keep them happy, and you are doing your thing.
My question was because I kind of had a case where there were large cysts and like I kind of assumed that it was VLM with acute bleed, but it turned out to be a cystic degeneration of schwannoma, where it was totally a different thing than what I expected.
Yeah.
Thank you so much for the case. Interesting case. We can actually go on with the discussion, but we have to move on to the next case to be presented by Dr. Preeti, a case of Kimura's disease in the orbit. And till she starts sharing her screen, I would like to invite the panelists for the case, Dr. Snehal Kokode and Dr. Sonal Yadav. Yes, Preeti, we can see your screen.
See screen,
Please make
okay.
it
And I'm
full screen.
audible also, right?
Yeah.
Okay. Thank you so much, MOS team. So I'll directly start with my presentation. My case was a 21-year-old female patient. She had a sudden onset, rapidly progressive, painful swelling of the left eye, which according to them was since 17 days. And there was a rapid progression of her symptom of watering and pain and swelling over the last 1 week. And there was no history of any trauma, fever, sinusitis, or any systemic illness. There were no known allergies or any previous episodes. So this was the clinical picture when she came, and it was post-COVID era in 2022, and 2-week history with a painful proptosis. So, and also, she was treated elsewhere as a case of orbital cellulitis, and already she was given IV antibiotics. There was no improvement despite the 7 days of treatment, and rather there was progression. So my first dilemma was, I'm looking at a painful proptosis patient who is not responding to antibiotic. So what it can be? So I went ahead, on inspection, there was a abaxial proptosis with the downward displacement of globe. There was upper lid edema with erythema, and there was a diffuse fullness which I could see in the superior orbit. Also, on inspection, there was lot of chemosis, congestion, exposure keratopathy, exposure conjunctiva was also dry, and cornea was almost gone. There was no PL, and also there was no pulsation or change, any change on Valsalva maneuver I could notice, and the extraocular movements were also lost. On palpation, I could feel firm to hard mass diffusely in the superior orbit, which was slightly irregular. There was mild tenderness, and retropulsion was strongly positive. There was no pulsation or bruit I could notice, and there was a bone. There was no bone deformity, and also there was no regional lymphadenopathy. So what first thing came to my mind, since the history was really short, whether it is an infective case and it was post-COVID era, whether it is a fungal etiology. Secondly, very fast progressing mass like rhabdomyosarcoma. Thirdly, I was also thinking, is it any inflammatory mass? But it was down on my list, and thyroid and vascular were also down on my list. So I did a basic blood investigation. Hemoglobin was low, leukocyte count was normal, and eosinophils were slightly raised. And peripheral smear, there were no abnormal cells. Thyroid profile was normal. Inflammatory markers were normal. RBS normal. KFT, LFT was also normal. So we went ahead with imaging. She had a CT scan in which bone was normal. We went with the MRI. I don't have many images, but this image, this is a T2 image. There was a hypointense lesion, as you can notice, with a relatively well-defined margins, and it was displacing the globe down. So our radiologist was of opinion that it looks like some tumor, mostly benign. So now imaging is suggestive of something relatively well-defined mass, and the picture is mimicking a very short history, like whether it is an infection or not. So I was thinking, should I again start a antibiotic or add steroid, or consider the biopsy? So, but I went ahead with the biopsy, saying I could feel the mass and see the mass on the imaging. So superiorly, I went over with the lid decrease incision, since there I could feel the mass, but all the tissue planes were obliterated. There was thickened tissue, and I could not actually see the mass. So I took multiple chunks and sent for histopathology. On histopathology, there was a non-Cagering granuloma, lymphoid hyperplasia, and tissue eosinophilia. So according to my pathologist, he told it looked like a Kimura's disease. So it was a really shocking thing to me, since I had not thought of this kind of disease. So what is this Kimura's disease? I started researching. So I found this kind of diagnostic criteria. Clinically painless things. It was against my this thing. Proptosis was there, but it was painful. Hematologically, slight increase in eosinophil count was there, but IgG was normal. Radiologically and histologically, it was pointing towards Kimuras, and still lymphadenopathy and renal involvement was not there. So we did IgE level. So to my surprise, it was raised, quite raised. So after researching, we started her on oral steroids, 1 milligram per kg body weight, and a tablet cetirizine twice a day. And also we started on a immunosuppressant, that is azathioprine, 50 milligram twice a day. So after 1 week post treatment, she started to respond. After 2 weeks of treatment, it was a good response in her. After 3 weeks, almost all the inflammation was considerably down. So when I interpreted, clinically, pain was very less typical and eosinophil count was not very high, but IgE imaging and histopathology was compatible with Kimura's diagnosis, and systemically it was a steroid responsive. So we continued the oral steroids for over 3 months with slow tapering, since it is known for recurrences, and we continued cetirizine and azathioprine for a year, but in between there was no recurrence, and meanwhile IgE levels also came down. So from this to this, after a month and after a year, since vision was not there, we could not regain vision, we put her on a prosthetic eye. This was the final outcome. So I'll rest my case. Thank you so much. So I'll open the case for the panelist, and I have my questions. How would you people have approached this case? Thank you so much.
Congratulations, Dr. Preeti. You presented it very beautifully and you also managed it very nicely. I would like to ask you, as the patient was no PL and you thought of anything else your management would have changed now? Because it was a tense orbit.
Yes, it was a tense orbit. Actually, I was thinking if she could have reached us earlier, and it looked like very much like a orbital cellulitis only. But in imaging, there was a defined mass. That's why biopsy was done.
Okay. It's a very atypical case because Kimura doesn't present usually with a painless this short time of proptosis.
Yes.
I think
And also histopathology, I took multiple chunks and I had sent to 2 pathologists. Actually, I had extra sample. So one told ki it is looking like only inflammatory disease, and other told that it is looking like a Kimura's. So it was lot of literature review I had done.
A very well documented and as well as managed case, Dr. Preeti, and I liked how you compare your case with the literature to show the compatible points and the points in favor of a diagnosis versus not, because we do, yes, orbit and ultimately is a Pandora's box, and we do deal with diseases which sometimes can have or most of the times can have a typical presentation than what the literature also suggests. We also have published a case of Kimura's in conjunctiva and had a similar dilemma regarding diagnosis. Histopathology is the key. As you rightly mentioned, you did take multiple chunks. Incision biopsy was a good call. I think you also did IV antibiotic course, but however, it was not responsive, right?
It was done elsewhere. When she came,
Elsewhere.
she was no PL. When she came to me.
Okay, all right. Yeah, so she did lose that time though. However, diagnostically speaking, yes, if responsive to IV antibiotics and cellulitis is falling behind in your differential diagnosis, incision biopsy is a right call. Multiple chunks or a core biopsy to reach the epicenter of the mass to get a good histopathologic clearance is valid. Also taking 2 opinions from the pathologist just to clear up some of these confusing diagnosis was a very good point. What has been the longest follow-up for this case, if I may ask?
Almost it is 2022, I think. So almost 3 to 4. I mean, 3 to 4 years. She has came last time. She does not have any.
She's been doing well, yes. So I think your combination of steroids plus immunosuppression has
I
worked
started
well.
at first go.
Okay. Yeah. So I think diagnostically, I would applaud you for the algorithm that you have used. And yes, just keep her under watch for any further recurrences, though, because inflammation, as we all know, can present in various ways, can recur in various ways as well. Any lacrimal gland involvement was seen at the primary go, because Kimura's can have association with salivary gland, so maybe a mimicking situation lacrimal gland might have happened. Rapidity of the growth is something which again not very literature proven, but you might write up this case and prove that in literature too.
Yes. And also,
I think in the interest of time, let's move on. We have 10 minutes left for our session to get over and 2 pending cases. So I would like to move on to the next case. We have Dr. Ayushi Agarwal from Kolhapur, and she's presenting a case of recurrent lacrimal abscess. Tame the flame. Over to you, Ayushi.
Thank you, Dr. Namrata. Hello, everyone. Firstly, I want to thank Dr. Namrata and Dr. Aditi for giving me this wonderful opportunity and to be a part of this program. Today, I'm going to present an interesting case of a 47-year-old lady who presented to me with complaints of recurrent medial canthal swelling associated with discharge and watering in the left eye for 6 months. She was a known case of uncontrolled diabetes mellitus. Her visual acuity in both eyes was 20/20. At Nexel evaluation of the left eye revealed a firm, fluctuant, tender, and erythematous lesion in the infromedial aspect of the left eyelid with slight extension above the medial canthal tendon. She also had a component of preseptal cellulitis. Her ocular movements were full and free. She also had a ptotic upper eyelid, which she revealed that is present since birth, for which she also underwent a ptosis surgery in the past. The rest of the ocular examination in both eyes was unremarkable. Considering the diagnosis of a left recurrent acute dacryocystitis with lacrimal abscess and preseptal cellulitis, we performed an abscess aspiration in the OPD and obtained a 1 ml purulent aspirate and also started her simultaneously on oral antibiotic therapy. The patient was planned for an early endoscopic DCR, but the surgery got delayed by 5 days due to uncontrolled blood sugar levels. So this is her on the day of surgery. Following aspiration, as you can see, there is a reduction in the size of the abscess and the swelling also appears less tense and tender. She underwent an uneventful endoscopic DCR under general anesthesia. Post-operatively, she was given the routine intranasal and topical steroids, nasal decongestants, and an oral antibiotic course. She was asked to review at 1 month. Now, at 1 month follow-up, her epiphora had completely resolved and lacrimal irrigation was freely patent. Now, by textbook definition, this was a successful outcome. However, what bothered me was a new onset, firm, ill-defined swelling in the medial canthal area, which did not show any signs of inflammation such as pain or erythema. And I'm saying new onset because on the first day after surgery, her swelling had completely subsided. We went on to perform an endoscopic evaluation of the ostium. Excuse me for the poor quality, as I did not have an inbuilt recording at that time. So as you can see, there is a giant superior edge granuloma over the ostium with surrounding inflammation, but a patent ostium. Now this granuloma was excised and simultaneously we injected an intralesional triamcinolone acetonide and also restarted the patient on intranasal and topical steroids. We also gave her a very short tapering course of low-dose oral corticosteroid therapy. 2 weeks later, as you can see, the medial canthal swelling has reduced. The granuloma had resolved with reduction in the surrounding inflammation. The patient was continued on intranasal steroids for 2 more weeks. Now, at final follow-up of 2 months, the medial canthal swelling has completely resolved with a successful outcome. Her endoscopic evaluation showed a positive and spontaneous functional endoscopic dye test, what we also call as the FEDT. The ICO dynamicity is good. There is no granuloma or any ICO thread such as Seineke, and the ostium is well healed with resolved inflammation. So through this case, I learned that ostium granulomas can lead to exuberant external inflammation even when there is anatomical and functional success and should be managed early on to prevent failure of DCR. Hence, a multi-pronged approach, including needle aspiration, early endoscopic DCR, and frequent endoscopic ostium evaluation should be opted for. With this, I would be glad to also know the opinion of the panelists as to how differently could this case have been managed and what is your take on this case. Thank you.
Wonderful case. I would like to... Yes, I would like to invite Dr. Wankhede to please give his expert comments on the case.
Yeah, please. Yeah. Thank you. Dr. Ayushi, great case, and I think you have managed it well. I think in the short of time, I'll ask only 2 questions. What is the cause you think of granuloma in this case, and how you can prevent it in future or any other case?
Well, usually the granuloma occurs when you have left the raw bone behind. So you should always make sure that when you are doing the endoscopic DCR, your raw bone is covered with a mucosa. As far as I remembered, I was actually feeling happy that it was a very good DCR that I performed, and I was very surprised to see such a large giant granuloma. But another possible thing could be because it was an acute acryocystitis. So there may be more chances of granuloma formation. But we should be careful while performing surgery that you do not leave raw bone behind.
Yeah, any role of mitomycin you feel, and also is there any role of silicone intubation?
Actually, I forgot to mention, but I had done an intubation and a mitomycin CO as well, along with the endoscopic DCR. Since I routinely do it, so I skipped to mention it.
Probably
But
a stent
it
can
was
be a
performed.
cause in this case also.
Okay.
Yeah, but it's okay. It's a great presentation, and congratulations. Any other question from other panelists?
Dr.
Hi,
Richa, can you
Ayushi.
make some comments?
Yeah. Hi, Ayushi. It's a very well managed case, and you highlighted very beautifully about the multimodal approach of such a simple and common pathology that we see. Uh, Aspiration of abscesses is not something that is very commonly done. But why did you go for aspiration and not incision drainage in this particular case?
Well, the reason was because she was there in the OPD, and needle aspiration, as the literature says, is now to be as effective as IND. Firstly, as we used to believe that IND gives you the benefit of dissecting the compartments that there are, but now MRI shows that there are no compartments in the abscess. So needle aspiration has shown to be as effective as an IND. So why not do an office OPD procedure rather than taking up the patient for a surgery?
Okay.
I think it avoids a
Why?
scar also.
Yes.
All right.
Yes.
I'm sorry to be a party pooper here, but we have to move on, and we are very short of time. So let's move on to our last case by Dr. Akriti Desai from Mumbai, and she'll be taking us through a difficult case of an eyelid carcinoma conundrum. Over to you, Akriti.
Hello, good afternoon, everyone. I'll just proceed with my case. One second, please. Yeah. So there was this 68-year-old gentleman with right upper eyelid lesion, which was placoid in nature, but his complaints were of blurriness of vision, redness, swelling, and discharge for the past 8 months. So his complaint was not of the eyelid lesion at all. He had an upper eyelid entropion, a thickened upper eyelid lesion, an epithelial defect, but I also checked for the lymph nodes. There were no preauricular, submandibular, or superior cervical lymph nodes. On eversion of the upper eyelid, there was distortion of the eyelid margin architecture. There was effacement of meibomian gland orifices. There was, as you can see, there's upper UTC scarring. There were dysplastic lashes, and there was cicatricial entropion. We can see the epithelial defect when he presented here on the cornea, which was taking up the stain. So the plan was to take up the patient for upper eyelid incision biopsy and electroepilation along with copious lubricants. But then he was lost to follow-up for like 3-4 months, and he underwent an incision biopsy elsewhere, wherein it was diagnosed as sebaceous gland carcinoma, and map biopsy was also positive 3 out of the 17 sites. He was also started on 0.02% of mitomycin C, and he returned to me after 5 months. I sent the blocks again for second opinion, and the opinion that I received was of microcystic adnexal carcinoma. The map biopsy was negative. The patient was already on 3 months of mitomycin C. This is the report of map biopsy, which just shows some inflammation, some lymphocytes, but no evidence of SGC. He had an MRI orbit with PNS and there was no local lesion. His PET scan was also negative for any systemic spread. So considering the diagnosis of microcystic adnexal carcinoma, the optimal therapeutic approach was considered as either Mohs micrographic surgery or primary surgical excision with intraoperative frozen section, which was done for this patient. The reason is, although radiotherapy has also been reported to have some success rate in a couple of publications, but it demonstrates greatest morbidity because of local invasion. It's a low-grade tumor, and it causes destruction by high locoregional recurrence. Hence, an excision biopsy with intraoperative frozen section and margin clearance was planned, along with a cutler beard reconstruction. The frozen section diagnosis said that the margins are free of tumor. I had mentioned, as the previous diagnosis was of sebaceous gland carcinoma, in my submission I had mentioned that it could be either MAC or an SGC. He was doing fine post-operative, just 1 month post-op visit. He does have some lymphedema though. His histopathological picture was like this, which was focally positive for CK7. CK15 was also positive. CK19 was negative, and androgen receptor, which is for sebaceous gland carcinoma, was negative. This is the image of CK15, and these are some other histopathological images which show cords and nests of cells which are basophilic in nature with scanty cytoplasm and moderate pleomorphic oval nuclei. There were few prominent nucleoli. There was ductal differentiation. If you go back and see into the previous slide, there was ductal differentiation. I'm not able to use the marker. In some sections, we are able to see that there was ductal differentiation as well. It was invading subepithelial tissue, also focally into muscle, and there was a desmoplastic stromal response, which is seen in malignant tumors, and focal lymphocytic inflammatory response as well. Now, due to the differential diagnosis of microcystic adnexal carcinoma are based on the immunohistopathology, could be desmoplastic trichoepitheliomas, infiltrative morphiform basal cell carcinoma, or squamous ductal carcinoma. A sebaceous gland carcinoma often presents with large pleomorphic cells with vacuolated cell cytoplasm. This is just a representative image. Now, what is MAC? Not many people are aware of it. It is an uncommon sweat gland tumor which is locally aggressive and infrequently metastatic in behavior. So not expected to have lymph node or systemic metastasis. It was first described by Goldstein, and it has a propensity for face, like centrofrontal area. Presence with either a nodule or an induratic plaque, averaging about 2 centimeters. Middle-aged or little older age group. My patient was 68 years, which is slightly higher than the common age group that was noted. The histopathology is of stratified histologic appearance with ductal differentiation and presence of perineural involvement, which was reported in the final report of where the margin clearance was obtained. Perineural involvement was noted. It also has deep dermal infiltration and infiltration of skeletal muscles. This is just to show that there's just one report in the multiple and maybe one more, which shows in the multiple reports of 300 cases, which have showed metastasis to the lung. So I read up on it, and the periocular microcystic adnexal carcinoma, 93 cases. There's this report from OPRS just a couple of years back in 23, in which it can also show distortion of eyelid margin as we see in SGC. And in a large majority, there is histopathologic misdiagnosis. One thing we must consider that in 2018, although this is not periocular, there were 3 cases which were published, in which a MAC showed sebaceous differentiation. Because some authors consider a double ecrine and folliculosebaceous apocrine differentiation as in both factors, whereas some authors defend a solely ecrine differentiation. So in this context, when there is a sebaceous differentiation, MAC would probably support the first option, whereas there is double ecrine and folliculosebaceous apocrine differentiation.
Akriti, can we
is required.
wind up the talk?
Yes, just to conclude, an adequate histochemical markers are necessary. Adipophilin was not done. So as a clinician, I think since we don't have focused ocular histopathologies, it's necessary for us to mention the markers that we need. Cytokeratin was positive, which is seen just in mainly in MAC, even BCC and SCC, it is negative. So other cytokeratin markers are necessary, and we must consider that sebaceous differentiation in MAC is possible. So I think I would have to ask for a repeat, call for the blocks again and get a repeat test done. Thank you. I would request the panelists for their opinion, and is there something else that they would have done?
Hi, Akriti. Can you hear me well?
Yes, I'll just stop sharing the screen. Yeah.
So, Akriti, let me begin with congratulating you for this wonderful presentation. And I agree, I definitely agree. You put it into the dilemma in oculoplasty, this case of yours. So, Akriti, here, I just want to make things sure if I missed it somewhere. The pictures that you showed, the clinical pictures, that was when the patients first came to you before he went elsewhere for the histopathological diagnosis that he came with?
Yes, yes.
Okay. And then did we also see the pictures after that?
No, it was an incision biopsy of
So
the
there was
eyelid
no
margin.
change in the like what the pictures you showed initially.
Not much
Where was that?
change.
Okay,
Because
okay,
biopsy was an incision biopsy from the eyelid margin center. Of course, the redness and all had subsided as the cornea healed, but since it was not an excision biopsy, it was not having like there was no loss of eyelid except
okay.
for a small notch in the upper eyelid.
Okay, right. And Akriti, also during the when you told us about the symptoms of the patient,
Yeah.
were you able to elicit any history of, any pain around that area or any paresthesia or numbness? Just thinking about some perineural invasion
Correct.
sort of thing.
Yeah.
Did you get something like that?
No, I did not. I asked the patient for any numbness, which he did not report, but I did not check for it, like maybe with a cotton fiber
Even
or
I'm asking you
yeah.
retrospectively,
Yeah.
that after getting your blogs and then you thought about, Mac. And one last question. Did you also get a second opinion on these paraffin blocks?
I have taken it from two labs. Like after the incision biopsy, I asked for the same block and sent it to another center. And the excision biopsy I sent elsewhere. So that
Okay.
I have like, we have now three opinions, but they are not coinciding to one diagnosis. So what I
Okay.
think I should have done is to specify the markers that are needed to differentiate different types of eyelid carcinomas, which they have done a few, like androgen receptor is negative in SGC, which was there, but they have not done adipophilin. So I
Really
think
sorry to interrupt, Dr. Akruti. I think we can
Sorry.
continue with the discussion maybe on the group or something because glaucoma people are waiting for the session. So is Dr. Akshay around in case he wants to just add one comment? Or else we will just wind up our session. It was a great session which covered oncology, eyelid, lacrimal, orbits, everything. So Darade sir, just a short comment from you as a chairman, and then we'll hand over the session to glaucoma people.
Yes. Congratulations all office bearers and congratulations to all presenters. Very nice and excellent cases that and the comment from all the oculoplasty surgeon all over the Maharashtra. Thank you so much for arranging such a nice session. Thank you, Aditi ma'am.
So thank you so much. And I guess we'll hand over the session to glaucoma people. Dr. Piyush, over to you to go
Thank
for
you.
the
Thank you for
next.
ensuring that we close on time. Excellent session. Let me hand it over to Dr. Preeti Kamdar and Dr. Sachin Darwadkar, who will moderate the 12th session, that is Dilemmas in Glaucoma. Can you invite our chairpersons and panel and just quickly start the next session?
Sure. Yeah. So, welcome to the glaucoma session of our midterm Moscon. Am I audible?
You're audible.
Yeah. Okay. And I thank Dr. Piyush and Dr. Sumit for the opportunity. So, without wasting any time, let me introduce our chairpersons for today, Dr. Rita Dhamankar and Dr. Chanda Hingorani. Both are very experienced glaucoma specialists from Mumbai. Our first case is by Dr. Anamika Agarwal, who is a professor of ophthalmology, KEM Hospital, Mumbai. And the discussants are Dr. Manish Shah from Mumbai and Dr. Cheta Vishwe from Aurangabad. So, Dr. Anamika, if you can please share your screen.
Is it visible, madam?
Yes,
it is visible.
Is visible. Am I audible, madam?
Yes.
Yeah, you're audible,
screen.
but kindly keep the presentation stick to the time so that we
Yes,
can
I will.
have time for questions. Thank
I
you,
will
sir.
abide to it.
Thank you.
I will abide to it. So, good evening, everyone. Thanks, MOS Committee, for giving me this opportunity. I would be speaking on transscleral cyclophotocoagulation, a salvaging bridge for pain relief and IOP control in a complex case. Let's take the journey. This is a 26-year-old female who was operated elsewhere for post-traumatic cataract with no visual improvement and pain in the post-operative period. She had a past history of cricket ball injury to left eye 7 years back. As per the records, there was irisis for which she had undergone laser iridotomy twice in 2022. Later on, she developed cataract for which cataract extraction with IOL implantation and iris cyst removal was done in September 2023. Eventually, she developed pseudophakic bullous keratopathy with pain, so she was referred to us for further management in June 2024 in view of optical keratoplasty. So on examination, right eye vision was 6.6, the anterior and the posterior segment were normal and the intraocular pressure was also normal. Left eye was something like this, the vision was PLPR good projection. She had congestion, the cornea was hazy, vascularization in all four quadrants. However, the anterior stroma was relatively clear. The anterior chamber was shallow, the IOL reflex was hazy, there was a membrane, and the intraocular pressure was 40 millimeters with one anti-glaucoma medications. We couldn't see the fundus, so we did B scan, which revealed no IRD or endophthalmitis. The treatment initiated to her was steroid eye drop, prednisolone acetate, which was given 2 hourly. Atropine ointment was given as a cycloplegia. Anti-glaucoma medications were added sequentially from 1 to eventually 5 drops, and bandage contact lens was also put to relieve pain from bullying. The patient who came with this eye status was given a hope of keratoplasty and referred to us. We had a huge challenge. There were a lot of dilemma. Should we do penetrating or lamellar keratoplasty? But IOL and PC status was unclear. So should we do anterior vitrectomy and IOL exchange standby? Hello, in all this chaos, we were thinking, is really keratoplasty possible with such raised IOP? Already she was on 5 AGMs with no control of IOP. So was trabeculectomy surgery an option for it? However, with this eye status, there was a chance of complication and risk of failure. But the patient had so much of pain. So can you do a cyclocryo in her? No, but then the vision was PL. Then we sought expert glaucoma opinion and transscleral cyclophotocoagulation was advised for her. We did counseling of the patient about requirement of 1 to 2 session and risk of phthisis. The patient agreed and she underwent first session in November 2024. The parameters used were 2000 milliwatts, duration of 2 seconds and treatment for 270 degrees. In the initial first period, say around 2 to 3 weeks, there was a response and the IOP was controlled. However, eventually by 6 weeks, again there was a rise in IOP and persistent eye pain for which repeat session was done in May 2025. So the patient who came to us with this eye status, last follow-up, this was the eye, the cornea was better, the inflammation and IOP was controlled and there was relief of pain. So to speak about transscleral cyclophotocoagulation, this is a diode laser which targets and destroys the pigmented ciliary body epithelium, decreasing the aqueous humor production. It is available in continuous wave and micropulse mode. It can be done in the eyes with vision potential and prior glaucoma surgery across the age groups and all subtypes of glaucoma. The procedure has to be done under peribulbar block. The laser probe is placed perpendicular to the limbus and the laser is delivered 1.2 millimeter behind the limbus over the ciliary body. The power settings, parameters, technique vary based on the surgeon preference. The duration will differ according to the severity of the IOP. Post-procedure treatment would be steroids, cycloplegia, and the glaucoma medications may be decreased, usually one at a time. Literature review reveals multiple studies have been done on both the modes, continuous and micropulse, shows that IOP reduction does happen and there is a mean reduction in the glaucoma medications which is required. Having said this about the efficacy, there are certain limitations. Transscleral cyclophotocoagulation works by tissue destruction and may itself induce more pain in some patients. There is always a risk of hypotony, phthisis, and also vision decrease in some patients. The availability and cost of laser could be a constraint. Alternative treatment for pain management in such cases would be combination of steroid atropine drops. However, it may take long duration for its effect, sometimes as long as 6 months it can take. So my learning and take home message from these cases: in the treatment of refractory glaucoma, transscleral cyclophotocoagulation can be a viable alternative if used judiciously. There may be a role of TSC-PC in IOP control even in the eyes with light perception. However, patient counseling is crucial. Repeat sessions may be required. Anti-glaucoma medications will have to be titrated as per the IOP control. A short story of this patient. Now, at the end of 3 months, when she came to us, and when we were just giving her medical management and no keratoplasty was done, she went and complained to about us to Dean that nothing is being, no treatment. The treatment is been delayed for her, and she went to other institute only to find out that nothing else was added than what we gave. She came back to us and followed our treatment. So to conclude, pain has a huge impact, and any pain relief would be a biggest favor to any patient. These are my acknowledgements. Thank you, and I welcome all the compliments, and I've done in time. Thank you.
Thank you, Anamika. And can I invite Dr. Manish Shah for his comments and Dr. Cheta for her comment? Dr. Manish.
Thank you, Preeti, and thank you, MOS, for including me in this program. And Anamika, of course, is great. She has presented the case very beautifully and doing excellent work at KEM. And I completely agree with her conclusions that TSCPC is a very useful and a very important tool in the armamentarium of a glaucoma specialist to deal with such cases. And just to add to whatever she has said, because she's covered everything mostly, only thing can give, she had less time, I can add a few things, is that you have to be very careful because this is a seeing eye and a young patient. So before you take up for state, very often after a TSCPC, there is nothing much you can really do. So you should first exhaust all the other options. And I'm sure she has done that, but just maybe not having enough time. Because she said when she presented the case, it had corneal edema and bulle. So probably that was because of the raised pressure and a little bit of reduction in pressure, either giving a heavy dose of topical medicines and everything. If the bulle resolved, that means that the cornea is not as bad and patient will get some relief out of resolve of the corneal bulle. And one photograph she showed, the cornea was pretty clear. This is the post-surgery photograph.
Yeah.
And so what I felt was that some amount of that initial corneal haze was because of eye pressure. And if you give a proper chance and if it comes down, then I would prefer to do a filtering surgery. If at all there is visibility, even just superior limbus visibility is enough for me. Even if the central cornea is hazy and you can't see in the center, but if you can see superior limbus, I would be able to do either a trabeculectomy or a Embed valve implant. And that filtering surgery will have a better outcome in the long run. Of course, once you have exhausted that and you're just not able to do a filtering surgery because of poor visibility, whatever has been done by Anamika is perfect. Second word of caution is that, as she pointed out, the risk of phthisis is definitely there. And so it is better, just as she has done, to do 2 sittings and avoid phthisis. Even if you get an inadequate response right in the beginning, that is okay. And only if you have counseled the patient appropriately will they be happy with that. So that is the second point. Third is that immediately after the procedure, there is always inflammation. So that you have to keep in mind and treat appropriately in the first 15 days after you have done the procedure. So that is one thing which you have to keep. So she had said she had started on atropine, and after the procedure also continue the atropine and steroid for some time to take care of the inflammation. After that, you can withdraw as you see.
Okay, so points very well taken. So I think Dr. Preeti will continue with the second case and take Cheta's comments on that, because otherwise we'll be exhausted with the time. So can you, we'll start. Yeah.
Yes, absolutely.
Yeah, you can proceed with the
So our
introduction of Kunal.
next case is by Dr. Kunal, who's a glaucoma specialist from Nashik, and the discussants are Dr. Ketki Purecha from Mumbai and Dr. Gayatri Hoshin from Kollam. Please go ahead, Dr. Kunal.
Am I audible and my screen is visible?
Yes, to both.
Yes. At the outset, I would like to thank Maharashtra Ophthalmic Society for the opportunity. So I'm Dr. Kunal. My case is straightforward, tale of orange spokes. So 35-year male patient visited us in our OPD with the complaints of headache and blurring of vision in both eyes, which was especially after heavy strenuous physical exercises. He had colored halos around the light with pressure sensation for 6 months. That was on and off. Episode occurred once every few weeks, which lasted for 30 to 60 minutes. So he had no visual symptoms in between the episodes. And prior to me, he had visited 2 ophthalmologists for these complaints, and they had given symptomatic treatment in the form of topical steroids and lubricating, which didn't satisfy the patient. Past ocular history, he didn't have any ocular surgery or injury to the eye. Medical history was he was healthy, and family history of glaucoma in his maternal grandfather. So on evaluation, his best corrected visual acuity was 20/20 with minus 4.5 diopter PL in right eye and minus 4 in the left eye. He was myopic. Deep anterior chamber with a few anterior chamber cells could be seen. Intraocular pressure on Goldman's applanation tonometry was 22 and 18 in right and left eye respectively. Since he was more concerned and his symptoms were post-exercise, so we asked him to show us after his strenuous workout, which was on weekends after sports activity also. So he came to us, and post-exercise within half an hour, we could measure the IOP, which was 32 and 28 millimeters of mercury in right and left eye respectively. Central corneal thickness was normal, and eggshell length was on the myopic side. On the slit lamp evaluation, we could see a spindle-shaped accumulation of pigments at the back of the cornea, which was Krukenberg spindle, and mid-dilatation pupil showed mid-peripheral transillumination defects, which were seen as orange spokes. On gonioscopy, we could see a deep anterior chamber with backward bowing of the iris, and dense homogeneous pigmentation of the trabecular mesh was seen, and pigmentation anterior to the Schwalbe's line, which was Sampolisi line, could be appreciated in the photograph. On dilated fundoscopy, the disc was average size, which slightly tilted disc, 0.65 cupping with inferior NRR thinning and sloping was appreciated. And on red free photograph, the wedge shape RNFLD was appreciated. And left eye disc was smaller with myopic crescent. Inferior and superior sloping of the NRR was seen, and nerve fiber layer defects were appreciated in superior and inferiorly. OCT, the same was confirmed on OCT, where we can see a wedge-shaped retinal nerve fiber layer defect inferiorly in the right eye, and left eye we could see a superior nerve fiber layer defect. Visual fields were not very reliable, but still 24-2 showed right eye, early nasal step, and early superior acute scotoma, and defects were normal in the left eye. We proceeded with anterior segment OCT, which showed the deep anterior chamber, and posterior bowing of the iris was appreciated on anterior segment OCT in the both eyes. Ultrasound biomicroscopy, it showed a marked iris concavity with posterior insertion of the iris as seen in the green arrow, and iridozonular and lenticular contact could be seen with the help of yellow arrow. Coming over to the differential diagnosis, we could thought of pseudoexfoliation glaucoma, anterior uveitis, and angle recession glaucoma, intraocular surgery or trauma, and intraocular tumors. But then we diagnosed him as a pigmentary glaucoma, considering the triad of Krukenberg spindle, the orange spoke or transillumination defects, and gonioscopic picture of dense homogeneous pigmentation, especially in the inferior quadrant. So we started him his treatment in the form of topical PG analog once at night, and the patient responded well. He was advised to avoid strenuous exercises, and he was advised to undergo NDR laser peripheral iridotomy at the earliest. So coming over to the discussion, as we all know, pigmentary glaucoma, it's a type of secondary glaucoma developing in the patients of pigment dispersion syndrome with abnormal amount of pigment liberated from the posterior surface of the iris throughout the anterior and posterior chamber. Onset is in case of males, young males with high myopes, risk factors being presence of Krukenberg spindle and initial.
Kunal,
Yeah.
sorry to interrupt you. We just have around half a minute left.
Fine.
Yeah.
I'll just sum up, sir. Yeah.
Thank you.
So management, pilocarpine can be a ideal therapy, but it's not poorly tolerated in young males because of increased risk of RD. PG analogs are first line therapy, which enhances UV scleral outflow. SLT can be a better option in case of mild to moderate glaucoma, as they lower IOP by 20 to 25%. YAG-PI, as I already said, equalizes the pressure of AC and PC, flattens
Dr.
iris.
Kunal, sum up, please. Dr. Kunal, sum up.
Yeah. So the case, because the purpose of presenting this case was how do you diagnose and treat the patient of pigment dispersion syndrome early, so that we can avoid the conversion of this patient to pigmentary glaucoma, because these are young patients. Early diagnosis can surely help them prevention to go to pigmentary glaucoma.
Kunal, the time is up. Kunal, Kunal, time is
Last slide, sir. Last slide.
Yeah. Thank you.
Yeah. So this slide is open for discussion. So thank you most.
So
Okay,
Dr.
so,
Ketki, if you can. Dr. Ketki, are you there?
Ketki or Gayatri, one quick comment in 1 minute, please. Thank you.
Thank you, Preeti ma'am and Sachin, and also MOS for including us in this topic. Dr. Kunal has given a very excellent presentation. I think the case that he showed gave a very good triad for the pigment dispersion. I would just like to emphasize on the last slide, which he wanted to discuss more. Like, we have a dilemma when we have to differentiate between an anterior uveitic or whether the patient is having pigment dispersion or anterior uveitis, and that is the time when we actually have to think whether to give prostaglandin analogs or treat the patient as uveitis. So that differentiation is important, and that can be done by seeing the pigment dispersion type or the gonioscopy, basically, in which uveitic dispersion, the angle looks very different, and the the pigment dispersion or the pigments in the angle during in a pigment dispersion glaucoma, it is a uniform dispersion, a uniform pigmentation in the trabecular meshwork. So overall, with this, then we can diagnose it into a pigment dispersion glaucoma. And in the early stages, if we start him on the patient on treatment, definitely we can prevent the progression into glaucoma.
Okay, point well taken. Anything, Dr. Ketki, you would like to add to the excellent points raised by Dr. Gayatri?
No, all things are actually covered. What I would like to say is we should check for the IOP, and since the IOP is on the higher side, we should not wait till the glaucoma sets in and start on treatment for the patient, because eventually the glaucoma progression is going to happen if this condition persists. We can try peripheral iridotomy, but I don't know how much success they will have in pigmentary glaucoma. But in some patients, they do respond. So if we really want to intervene, we can do this, or medical line of treatment we can start.
Dr. Rita,
Okay.
quick comment. You have raised your hand. Quick comment.
Quick comment from Dr. Rita in 10 seconds.
Your voice, you're muted.
Rita, madam, you unmute yourself.
You're muted.
Okay, I just want to add one thing, that pilocarpine is no longer the first line of treatment in pigmentary glaucoma. That we must all remember, and that we can easily switch over to the prostaglandin analogs that were done very well. Thank you.
Point well taken. Dr. Preeti, can we move to the next case?
Yeah, sure. Now, our next case is by Dr. Pankaj Bendale. He is a glaucoma specialist from Pune. And the panelists are Dr. Bhairavi Raut and Dr. Ashish Thol. Both of them are glaucoma specialists from NAM. So please go ahead.
Yeah, Pankaj, your screen is seen. Can you maximize?
Yes. So it's visible, the slides?
Yeah, you're visible. Your slides are visible. You just have to maximize in slideshow.
Just 1 minute, sir.
Or you can start presenting. We can see the slide so that we don't lose any time. You can start presenting.
Yes.
5 minutes, start.
Yeah. So my case is about the neovascular glaucoma, sir. And
your voice is cracking.
We had a case.
Your voice is cracking, Dr.
Dr. Pankaj, your voice is cracking, and the bandwidth is very
directly start from the case. So we had a case where the 60. Yeah, it's audible now.
No, Dr. Pankaj, not audible, not comprehensible.
Yeah.
I think
so maybe I should be audible now, sir. Yes.
Better. Go ahead.
Can you just stop your camera and then start?
Yes.
Just stop your
so
camera.
we report a 66-year-old person, sir, who presented to us with a with diminished vision, finger counting 1 meter. He had a persistent high IOP with maximal medical therapy for 2 weeks durations. He was having neovascularization and non-resolving vitreous hemorrhage, and he was not getting control on any amount of medications. So we decided to go ahead with the image wall implantation and the vitrectomy. Yes. So we decided to have a combined approach because this case was having a non-resolving vitreous hemorrhage and refractory IOP, which was not getting control on any medications. So once we posted the patients for the vitrectomy with image wall combined surgery, first we made a peritomy. We made a pocket in the superiotemporal quadrant, 8 mm behind the limbus. We placed the image wall with the 9-0 nylon suture. As it was a one-eyed patient, we wanted to give the best for this case because this was the best hope and last hope for that eye because other eye was already an absolute NVG. So we anchored the image wall 8 mm from the limbus and we kept the wall like that. Then my VR colleague took over the case and he did the 3-port vitrectomy and he cleared all the vitreous. To our best surprise, the macula was clear and that was a very good observation for us. We removed all the non-resolving vitreous hemorrhage. Thorough endo laser was done. Disc was also looking okay. So whatever was a dense vitreous hemorrhage which was not getting resolved, we hope that patient will have a good visual improvement or at least he will have a locomotive vision. There was already a lot of PRP was done, but still whatever skip areas was there, we further did the endo laser for that. Disc was appearing good, so that was a good encouraging sign that we should be able to restore some useful vision for this patient. At the end of surgery, my retina colleague gave the gas tamponade for that case. And once he finished his case, then I marked the 2 mm from the limbus. Again, 2 mm behind the limbus, I took a 23 gauge angle trocar. We decided to put the tube in the entry chamber only because I was pseudophakic. We didn't want to put it from the vitrectomy port. So once the tube was put inside, then again the peritubular suture was taken to avoid the peritubular leak. Nice scleral patch graft was put there. And then the eye was closed with the good watertight conjunctival closure. So that's what we offered the best to this eye from the day go, because if we have waited for only vitrectomy, still the eye would have been refractory in post-op period. Only well, that was also approach and tried to give the best for this one-eyed patient.
Yeah, Pankaj, stop the video because your network is fluctuating.
Yes. So at the 1 week post-op, his post-op best corrected visual acuity was 624, IOP was 14, and as first day post-op, IOP was 15. So we started patient on the aqueous suppressant combination, timolol and brinzolamide combination, and the patient was doing good. So neovascular glaucoma is basically a retinal ischemic pathology. As long as we don't take care of the ischemic retina, I think we won't have a good stabilization of neovascular glaucoma. So if media is hazy, if we cannot do PRP, anterolateral cryopexy, or directly going inside the eye and doing good endo laser, that makes a difference. So this is what the interesting case for this eye. This was a neovascular glaucoma with very uncontrolled IOPs, and that's why we decided going ahead together and taking care of ischemic retina, putting the tube and stabilizing the IOP will be the best attempt for this eye, and that's what we could give to these patients. Thank you.
So fantastic case and fantastic presentation and finishing on time. Thank you, Pankaj. So I think we open the discussion, Dr. Preeti, with Dr. Ashish Toon.
Yeah, Dr. Ashish and
Yeah,
Dr.
I'm audible.
Bhairavi.
Am I audible?
Yeah,
Yes.
yeah, you are. Yes.
Yeah.
Thanks.
So Dr. Pankaj, very well managed case, and I think you have done a great job for this one-eyed patient. Just want to highlight how important the preventive part of our clinical practice is. These are the eyes which are already compromised, have high risk either in the form of PDR or maybe patient who has had a CRVO. These are the eyes which are already seen by ophthalmologists, if not us, our colleagues. Patients need to be emphasized the need for regular follow-up. This patient, I believe, had already lost the other eye because of NVG.
Yes.
So,
yes, sir.
Yeah. So very well managed case, but just to put up this point that we have to follow up the at-risk patients very carefully and closely. Thank you.
Yes,
Yeah, I think these words are worth weight in gold. These are very, very important words of wisdom from Dr. Ashish. Now, Dr. Bhairavi, you want to add anything in the next 1 minute? Is Dr. Bhairavi here?
Okay. Dr. Cheta, you are here.
Dr.
You want
Cheta?
to add anything? Cheta? All right. So just one. We have about one.
Bhairavi or Cheta, anybody is there?
Cheta was there. I don't know where she. Cheta was there.
I tried calling her also. I think she's not reachable.
Yes.
Anyways.
Yeah,
Cheta is there.
you
Cheta,
have-
go ahead. Go ahead.
Cheta,
Go
tell
ahead.
me.
Yeah.
Just one question. What will be the role of trabeculectomy in this patient?
So that's one thing. We have 1 or 2 minutes. So even the chairperson, Dr. Rita, Dr. Chanda, Chanda, you want to?
Chanda, you want to come in?
In fact, that was one thing in my mind also. Could we have given a trial of trabeculectomy in this patient?
Yeah, so
there was a dense vitreous hemorrhage, and we wanted to plan a combined surgery. That's why Ahmedabad was chosen. But there would have been an option of trap doing and then waiting for the VH to resolve. Patient was immobile for last almost 1 month. He was doing all day-to-day work independently. Now he was dependent. So early visual rehabilitation was also an important objective. That's why valve plus vitrectomy was chosen. Otherwise, there would have been a gap between trabeculectomy and then the vitrectomy. Vitrectomy could have failed the trap. I think so. Lot of dilemmas were there. That's why we chose the Ahmedabad as a direct go-ahead.
Yes, point well taken. Very nice.
So yeah, I think in the initial stages, a trial of trabeculectomy. Otherwise, this was a complicated one-eyed patient. So going ahead directly with a Ahmed wall implant is a good option. But otherwise, in the early stages, I think we can give a trial of trabeculectomy in most patients, and they do really well in our practice.
I think media clarity makes a difference. As long as we can do good PRP, all NVGs get stabilized. But if media is not clear, I think then that ischemic retina is not handled, then NVG don't get stabilized. Yes.
Correct. I think, Dr. Preeti, in view of time, I think we have to move to the next case. We can come back if you have a few minutes.
The host will give us 10 minutes. We are sticking to time. We should not be punished for
But if the media is clear, we can try the trabeculectomy, no?
Yes, I agree. I do. I am on team track for most of the time.
Yeah, if it is a stepwise approach, if you are able to manage the posterior segment well, trabeculectomy with mitomycin C as well as AGV both have almost equally good outcomes. Yes. But this was a separate. This was a difficult case to manage, and I think he did a great job.
He did a great job.
Thank you, sir. Thank you, sir. Thank you.
Okay. So we move on to our next case, and the next case is unilateral pseudophakic pigmentary glaucoma by Dr. Sunny Wadhwani. He's a glaucoma specialist from Akola, and Dr. Janvi Shah and Dr. Pooja Bhomaj. They are the discussants for this case.
Yes. Am I audible? Yeah, you are audible. Yes. Your screen is seen, not the presentation as of now. Yes. You can maximize it and start.
Yes.
Yeah, and please stick to time of 5 minutes. Thank you.
Yeah. So after a complex case, I am presenting a simple case of unilateral pseudophakic glaucoma. A 53-year-old male complaining of blurring of vision in left eye since 2 years. He came for second opinion for IOP rise in left eye. Patient was diagnosed with secondary glaucoma in left eye and referred here for further management. So there were a history of 3 intraocular surgeries. First in January 24, cataract surgery, followed by first trabeculectomy 2 months later, and second trabeculectomy after 8 months. So currently he was using brimonidine and timolol eye drops and bromophenol eye drop. So his visual acuity was 6/6 and 6/9 with N6 in both eyes. So anterior segment of right eye was fairly normal with PPC cataract, and in left eye showed 2 traps, flat blabs superiorly with cornea showing pigments on endothelium. Anterior chamber was deep. There were few pigments present, and iris and pupil there were 2 PI present, and lens showed pseudophakia with PCR. So in left eye there were 2 scarred blebs superiorly. Gonioscopy was of right eye was open angle with 2 to 3 plus pigmentation, and in left eye shows heavy trabecular pigmentations with 2 stomas superiorly. So fundus was fairly normal in both the eyes. In left eye it was 0.6 CDR, otherwise NRR was fairly healthy. Intraocular pressure of right eye was 15 and left eye was 28 with pachymetry within normal limits. Coming to fields of right eye was fairly normal, left eye was also fairly normal with few depressed points. So based on our findings, differential diagnosis of pseudophakic pigmentary glaucoma or inflammatory glaucoma or steroid-induced glaucoma or pigment dispersion syndrome was made. To confirm this dilemma, we did a UBM which showed a single piece foldable hydrophobic IOL in the sulcus, which was optic and haptic was closely proximated to iris, which may be causing this clinical scenario of raised IOP and dense pigment dispersion in left eye. So UBM showed single piece IOL with one haptic at 1 o'clock and other at 7 o'clock, close to iris ciliary body tissue. The other finding were hyper effective echoes noted in trap side at 10 o'clock position.
Hello, ma'am.
So IOL in sulcus, extensive pigmentation at open angles, and UBM shows iris IOL proximity pseudophakic pigmentary glaucoma was confirmed. So he was added on one other anti-glaucoma drug, travoprost, and other brimonidine and timolol was continued. So at third follow-up, he was doing well with IOP of 16 millimeter of mercury, and he was advised for regular follows. Even after 6 months, he is doing well with both the drops. So I think there should be no dilemma when there is inadvertent event like PCR while doing cataract surgeries. If you have good capsular support, then we should avoid this single piece IOL in the sulcus. For that, either 3-piece IOL or a rigid PMMA IOL should be used to decrease this post-operative pigment release and further IOP rise. So I think should we proceed for further discussions?
Dr. Sunny, that's a great case which many of us see day to day. So, Dr. Pooja, I invite your comments, and Dr. Janvi, your comments, please.
So I think the case was covered well. We should, it's a very important point that the hydrophobic lens single piece should not be placed in the sulcus. And if at all there are issues related to that, it is better to remove that lens and maybe do a SFIL if possible. And if possible, we can do a posterior optic capture. But I think first of all, we should not place a single piece lens in the sulcus, hydrophobic lens.
Yes.
Yeah, that's the message.
Janvi, Dr. Janvi, are you there? Dr. Janvi was just here.
Oh, sorry. Am I audible now?
Yeah, you are audible.
Yes,
Go ahead,
Yeah.
please.
So the first trabeculectomy in this case was done immediately 2 months post-op. Probably at that case, the primary surgeon could have intervened and done an IOL exchange, and this whole process of increase in the IOP could have helped at that stage, because it would have been more like a UGH syndrome at that kind, and then slowly it goes into that chronic pigmentary phase. But in the late stages, obviously, what Sunny has done is absolutely okay.
So in short, what do you feel is the time when you can just get away with removing the lens, and when is the time when you may have to just go ahead and do the trabeculectomy?
As early as possible, the first option will always be, if it's in the immediate post-op period, then the first option will be lens removal and maybe medically manage the glaucoma, and then plan for a trab if not managed medically.
Okay.
But
So if
one
you
thing we
detect
have to
earlier,
remember that the vision was good. I mean,
Yes.
telling a 6/9 patient that you have to remove your lens and do whatever is a little diff. So we need to have very good counseling that even after removing the lens or a lens exchange, you may still need something for your glaucoma.
Yes.
Right?
Yes.
Yeah.
Yes.
Can we go on to the next case?
yes,
or there's
yes, point
any
well
comment?
taken. You can go ahead. Then we can add later on, because we'll have some time
We
left
will
over.
have
So
time, yes.
we'll get
So-
all the panel experts on board again for some few tips.
Yes. So our next case is sudden bilateral simultaneous blurred vision. And that's by Dr. Jyotika Mishri-Kotkar. She's an ophthalmologist and a glaucoma specialist from Aurangabad. And the expert panel is Dr. Mohit Gajbhie from Gadchiroli and Dr. Anupam Deshpande from Mumbai. So, Dr. Jyotika, please. Yes.
Good afternoon, everyone. Thank you for including me in this glaucoma session. Are my slides visible and am I audible?
Yes. Yes, yes, both.
So I'll be presenting a case of sudden bilateral blurred vision. This young man came to us in the casualty at night complaining of sudden bilateral painful diminution of vision in both eyes, with redness of eyes associated with severe headache and vomiting since past 2 days. He was from a rural area. He had taken some treatment with a local physician for same but felt no relief. There were no similar complaints in past and he never used glasses in past. There was history of head injury in past followed by vague complaints of giddiness for which he was started on tablet Topiramate 75 milligram twice a day since last 3 weeks. On examination, the visual acuity of both eyes was found counting finger 2 meters. The presentation in both eyes were almost similar. Right eye affected more than left eye. And there was severe ciliary congestion, corneal edema with microbully, anterior chamber was shallow uniformly with grade 2 to 3 reactions. Pupils were semi-dilated, not reacting to light. Gonioscopy and fundoscopy at that moment were not possible and intraocular pressure recorded in right eye was 62, left eye was 54 millimeters of mercury. So based on the age, bilateral presentation, drug history, we came to a provisional diagnosis of drug-induced bilateral acute angle closure glaucoma and started him with IV hyperosmotic agents, tablet acetazolamide, corticosteroids, and painkillers because he was in severe pain. Locally, alpha-adrenergic agonists, beta blockers, cycloplegics, and steroid drops were started, and tablet topiramate was discontinued. This is the picture which we could take when he was feeling a bit comfortable. You can see the anterior chambers are very shallow. And now we could hazily examine fundus, which seemed normal. Gonioscopy angles were closed, and B scan showed mild ciliochoroidal effusion in both the eyes. Third day, after 48 hours, the pressures were in right eye 20 millimeters mercury and left eye 18 millimeters of mercury. So IV mannitol was omitted. Rest all treatment was continued in slightly tapering dose and patient was discharged. At 1 week follow-up, he came to us very happy with having right eye vision as 618 parts and left eye 69 parts. Intraocular pressure was 16 millimeters in both the eyes. And on gonioscopy, angles were grade 3 to 4 with mild pigmentation in angles, and fundus and B scan were within normal limits in both the eyes. After 3 weeks, patient was not using any medications. All the medications were over. Only steroid, systemic and local, that too in tapering dose. His vision in right eye was 6/12, left eye 6/6 parts. Intraocular pressure was controlled, angles were open in both the eyes, and fundus was normal. A word about bilateral simultaneous acute angle closure. We should investigate in these cases for posterior pushing mechanisms like uveal effusion syndrome and posterior segment space occupying lesions. Bilateral simultaneous acute angle closure is due to pupillary block is very rare, may occur if myotics or strong myotics or mydriatics have been instilled in patients predisposed with shallow anterior chambers. There are certain group systemic medications with sympathomimetic or anticholinergic activity, which may cause mild pupillary dilatation, but these are very, very rare conditions. Why it is very important to differentiate between primary and secondary, because the treatment strategies for each are very distinct. Cycloplegics are preferred treatment for secondary angle closure after withdrawing the offending drug, while they can precipitate angle closure in cases of primary angle closure. A word about topiramate. It is a sulfamate substituted monosaccharide, very valuable these days as it is add-on therapy or monotherapy in resistant partial or generalized seizures, migraine, depression, bipolar disorders, neuropathic pain, etc. Some important ocular adverse effects are acute angle closure glaucoma, acute onset myopia, uveitis, visual field defects. How does it cause acute angle closure glaucoma? Given in literature is that it causes an idiosyncratic response which leads to ciliochoroidal effusion. This causes forward rotation of ciliary processes, leads to anterior displacement of lens iris diaphragm, which precipitates an attack of secondary acute angle closure glaucoma. It's also mentioned that pre-existing hypermetropia is not a prerequisite for development of this type of glaucoma. The treatment protocol is immediate discontinuation of the inciting medication, decrease the intraocular pressure by anti-glaucoma medication, corticosteroids, cycloplegia. All these may help relieve the attack. PI is not indicated because pupillary block is not an underlying mechanism of this syndrome. Key points to remember: the first step in treating topiramate-induced acute angle closure glaucoma is prompt diagnosis. Neurologists, psychiatrists, ophthalmologists should be aware of the diverse ocular side effects of this valuable drug, and any visual complication to be taken seriously and followed closely by an ophthalmologist. I would end with that the effects of topiramate on vision are not only a simple category of side effects, it necessitates a joint effort on the part of practitioners and researchers to address this issue. Thank
Okay,
you so
wonderful.
much.
Thank you, Dr. Jyotika, for that excellent presentation. I think we open up the discussion with Dr. Anupam Deshpande. Anupam, are you there?
Yeah. Am I audible?
Yeah. Go ahead.
Okay. So
Quickly.
wonderful. Wonderful case. It is not very common to see bilateral angle closure. So, and the main thing here is history. Now, we see that, if there is angle closure, we will think about pilocarpine, we'll think about doing iridotomy. But taking history is very, very important, because we know that the treatment is poles apart. It's exactly opposite. So here we need to take history very well, and then you can come to a conclusion and then treat the patient likewise. Here, history of even undergoing any surgery, that is undergoing general anesthesia before, maybe a week or so before, is also important. Then pregnancy, sometimes I have seen cases in pregnancy. So all those things are important. And here we have seen that cycloplegics and steroids were the main therapy, and not the LPI and pilocarpine. So I think the case was very well managed.
Dr. Mohit, your comments, please.
Yeah, thank you for inviting me. I'm from Gondia, by the way.
Gondia, I'm sorry.
Yeah, very well managed, Dr. Jyotika. I think you are very fortunate that you had that history of topiramate use. Otherwise, people, they don't have any records, or they don't bring any tablets also. A similar one thing I just want to add is, if you are sure enough on V-scan that you have got there is uveal effusion, what you can add is intravenous methylprednisolone can be added. That will relieve the symptoms faster. And I have a similar case. Patient has history of detox supplementation, and they have I am not aware about that. Same patient presented to me, same like that, the same condition that came to you. He had a history of detox supplementation. Then later on, I came to know that there is something called as MSM, methyl sulfonyl methane. So it was supposed to cause this drug-induced angle closure. It was very well managed. Only thing is, you can add IV methylprednisolone.
Long back, we had a patient who was using fluoroquinolones for typhoid. She was an elderly woman. It was very difficult to diagnose that it was drug-induced, bilateral simultaneous presentation. She had come with this. So being in an institute, we come across such kind of variety of cases.
Dr. Rita, you want to add something?
Anybody in the expert panel, including the chairpersons, please.
Yeah, you know what?
Dr. Manish, Dr. Rita.
Sorry. I wanted to make a point. Whenever you see bilateral simultaneous angle closure, I think you have to remember all the drugs. The point made just now was absolutely fair and very well made, that at this point in time it was topiramate, but there are many drugs. It's a huge list of medications that you have to remember, which can give rise to uveal effusion, which can ultimately give rise to a bilateral acute angle closure. There has been a case of a child reported, a very small child reported with just Diamox. Acetazolamide was given to him. And remember, even acetazolamide is a sulfur derivative.
Yes.
So all sulfur derivatives you have to remember. And even, when the pressure is risen and he's been given Diamox, the pressure rises even more and he goes into a bilateral angle closure. So it's not just about this one drug, topiramate, but I think we've got to remember, when you get a bilateral acute angle closure, think of all the drugs. Just go through the list. If you don't remember it at that point in time, that's fair enough, because the list is really exhaustive. But make sure that you don't normally see bilateral angle closure as a primary angle closure attack, because it's very, very rare to have all the factors acted together in both the eyes, giving rise to a bilateral angle closure. So whenever you see bilateral angle closure, please keep your minds open. That's all that I would like to add.
Yeah, just a word of caution here. Just a point, as ma'am said, giving acetazolamide in such cases is may not be a
Controversial.
good choice. Yeah, yeah. So
No,
we have to
not
be
at all.
careful while giving acetazolamide.
Not at all. Yeah, I agree.
Fair enough. So that was a beautiful case, well managed. And let's now, we have about, can we have about 8-9 minutes? If Dr. Piyush and Dr. Sumit, we started a little late, so can we have some 5-7 minutes more, please?
Let's take five, ma'am.
5 minutes? All right, fine.
We have to be
Okay.
trendsetters by getting the fresh.
We are the benevolent ones. Okay, 5 minutes.
All right. So now, first case, your comments, Sachin. First case. We'll have each case. There are 5 cases, 1 minute. Let's have a take home for the for the audience. First case on TSCPC.
Yeah, so TSCPC, as was already pointed out by everybody, it is important. Counseling is a must, and the parameters also have to be time tested. The placement of the spots is also very important because it's a blind procedure. So transillumination of ciliary body is very important, and that there is no linearity in the result, and multiple treatments may be needed. It's something that you have to convey to the patient very clearly. Having said that, doing it in seeing eyes is very tricky, and you have to always counsel about the risk of phthisis. So all these things I think were very well covered, and I think that's what should be known. And 270 degrees is what we treat normally. So not the whole 360 and avoiding the 3 and 9 o'clock position. Yeah.
Just one more thing.
Micropulse?
When you're doing a repeat procedure, I usually keep that same 1/4 quadrant untouched. So if you're doing it repeat, so mention what you're doing, because that 1/4 quadrant is enough to prevent phthisis. And I have done so many, I have got only one phthisis, and that's the patient in whom I violated my own principle and did 360 degrees. So that's one thing you should keep in mind. So now let's go to the second case, Sachin. It's a tale of orange pigmentary glaucoma. Dr. Rita, any comment? And Sachin, your comments also. 1 minute we'll have per case.
Okay, I think that pigmentary glaucoma, which was shown, that was a spoke of orange,
would you do an iridotomy, no matter at which stage it is? Will you do an iridotomy?
No, I will never do an iridotomy. No, I will not do an iridotomy because that is not going to sort the issue at all. That's not going to get the iris to fall back. The IOL haptic that was in the...
No, I'm talking about pigmentary glaucoma.
Oh, you're talking about pigmentary glaucoma.
Pigmentary dispersion.
Yeah, pigmentary, yes. So what, before the onset of glaucoma, if there is just a pigment release, you see Krukenberg spindles, and if you want to change the posterior bowing of the iris, then definitely iridotomy can be done. But once the onset of glaucoma takes place, I don't think it will have much role.
Sorry. I missed the case.
Chanda, you would do an iridotomy? Yes or no? I think Chanda is not here.
Yeah, sir. Before the onset, we can go for the iridotomy, no?
Exactly.
Yes,
that's what I said.
That's right.
Yes,
that's what I said.
That's right.
Because
it was a different case, she thought.
Yeah, I thought of a completely different case.
Yes.
She was with the UGH, and we were on the pigmentary.
Yeah.
And both lead to pigment dispersion. That is common.
That's
Because in that previous case, I think iridotomy is the first line of the treatment. So to control the IOP.
Yes, before the onset of glaucoma.
Yes, that's true. So third case is neovascular glaucoma. For the audience, I would like to say that yes, PRP, when you see first a neovascular glaucoma, PRP is the first line of treatment. It is not anti-VEGFs. It is, and of course, controlling intraocular pressure. So your comments, Sachin?
So actually the sequence would depend upon the media clarity. If you have a clear media, zap the retina first. That is the priority. Before any vitreous hemorrhage or bleed precludes the treatment. So first thing is do the PRP because that is the basic control of the etiology. And then whatever treatment has to be done on the intraocular pressure can be simultaneous, and definitive treatment to elevate the IOP can be done as is required. As Pankaj has pointed out, in this case, you can do a AGV, or in cases where the NVG is regressed completely or the new vessels regress completely, you can do a trabeculectomy as well. But for that, you need to have a very good control of the neovascular process. Yeah.
Manish, you have raised your hand.
Yes, I would like to disagree with Sachin. In the first scenario, when I see a clear media and I see florid neovascularization, I would first like to give an anti-VEGF and then do the PRP, because PRP will take 2 or 3 sittings, number one. Number two, the effect of PRP will take time to set in. In the meantime, if the blood vessels regress, I don't get the zipping up of the angles and all that. So I would like to give a anti-VEGF first and then do the PRP.
So these are a little, you can have
Difference
difference
of opinion is welcome, I suppose.
Exactly. Yeah.
Absolutely.
So if you have the facility where then and there you can start PRP, yes, but you have to refer it after 3-4 days, then maybe that's the time when you can first do an anti-VEGF. But if you have the facility that's sitting on day 1, day 0, start a PRP, it really helps. So
then
now,
adding to that, the second scenario where we often commonly faces in media is not clear, and you don't see the retina, definitely it's a PRP glaucoma surgery, anti-VEGF glaucoma surgery followed by a PRP. So that will be the reverse sequence. So that is not something you have to remember, but the essence is the time is very important. Extremely high pressures will lead to ischemic optic neuropathy. So the treatment has to be on an emergent basis. This is one of the rare medical emergencies in ophthalmology. That is something that you should remember.
and just that in the era of anti-VEGF and PRPs, neovascular glaucoma, we can still salvage vision, they can still have good vision.
Very
not
much.
like the
Yes.
not like the earlier where neovascular glaucoma, you've lost your eye. That's not the thing. And I think it's 402, and Dr. Piyush must be saying now wind up.
He's on gas.
So, yes. So thank you everybody, the panelists, Dr. Sachin, and of course the audience for a wonderful session. Sachin, over to you.
Yeah. Okay. So I think we can hand over to the next team that is waiting to take over from us. And I again thank all the experts, all the case presenters for a wonderful job. And I think the listeners would have benefited immensely. So thank you, MOS, and we hand over to the next set of panelists. Thank you.
Thank you.
Thank you.
Bye.
Thank you so much, Dr. Sachin, Dr. Preeti. What a marvelous session. So, Sunilji, can you hear me? Sunilji?
Yes, sir, all good, sir. We can move, sir.
This session is ended. Now, what do you need us to do? So, we start with the next session, or you want to
Yes, sir. Yes, sir.
So, we can just go on to the next session?
Yes, sir. All good, sir.
Okay. Take care. Zain is here. So, we begin with the next session, which is one of my favorites, the YOSI session. And we have a galaxy of young ophthalmologists from the YOSI Council. So over to you, Zain, to moderate the session, introduce the chairpersons and the panel.
Thank you, Dr. Piyush. So hats off to you for running the show so beautifully and, all sessions being on time. It's like, really been a very educative kind of morning the whole day. And now we move on to something, away from education. We're going to talk about YOSI. And I'm very glad that we got the opportunity to include a YOSI session in the MOS midterm this year. And as you said, we have a lot of YOSI office bearers and a lot of important members of YOSI as well as Moscon being part of the session. So it gives me great honor that chairpersons for this session are our current secretary president combination for Moscon 2025. That is Dr. Shirish Thorat sir and Dr. Viral Shah sir. I'll be moderating the session. For the panel, in the young panel, we have our important YOSI members, who have been contributing to YOSI. Dr. Aarti Heda, Dr. Neeraj Israni, Dr. Yash Gala, Dr. Ashish Ahuja, and of course our own Dr. Sumit Lahane. And in the expert panel senior, we've got Dr. Digvijay Singh sir, who is past president YOSI, Dr. Avanish Upadhyay, who's past treasurer YOSI, Dr. Nikhil Nasta sir, who's current treasurer of BOA, of course Dr. Piyush Bansal, current chairman scientific committee MOS, and Dr. Sean Chinkole, who's the treasurer of current MOS. So we've got a good panel, good set of panelists from MOS and YOSI both. And for the speakers,
let me interrupt you one second. I'm so sorry about that. We also have Dr. Usha Johri joining, past president of BOA. She's also going to be one of the chairmen.
Okay.
Chairperson, so chair lady.
Thank you. Good to have you here, ma'am.
Yeah, thank you.
So for the speakers, we'll be introducing the speakers as we go ahead. So I hand over to Dr. Shirish and Dr. Viral Shah and Dr. Usha ma'am to just give brief comments before we start the topics. Dr. Shirish sir, over to you.
Am I audible, Ben? Yeah, Dr. Shirish.
I'm audible
Sharan,
then because
Yes, sir.
network quality is very
yes,
poor.
sir. Yes,
I'm
sir.
audible?
You are audible, sir. Yes,
You're audible,
yes,
sir.
sir. Go ahead.
Yes, yes. I welcome you all to this important session. As Dr. Piyush said, this is one of the interesting and is close to my heart is the YOSI session. I welcome you to, all to this session. The YOSI, the future of MOS, the future of the India, the future of the ophthalm. The enthusiasm of YOSI is fuels our progress, and your collective presence makes really this event truly special. Piyush must be agreed this thing. I really impressed the work done by the YOSI, the enthusiasm and the clinical acumen of our young friends. And I really wanted to know many things from these young chaps. Thank you, Jen, for inviting me for these sessions. Over to you, Jen. We'll start the session.
Sure, sir. Viral Shah, sir, and Usha, ma'am, you want to say a quick comment before we start the topics?
I think it's been wonderful, to having me as a part of this session. And more than, the youngsters learning from me, this is an opportunity I'm looking forward to learn from the youngsters, because I think we need to, move away and give a chance to the youngsters. So, in fact, I thank Piyush and the whole team of, Moscon Mid-Term for having me here. And I look forward to learn a lot from you. Thank you.
Thank you, ma'am. Vidal, sir.
Yeah. Thank you, Zain, and the scientific committee of MOS for having us here. It's such a pleasure to see a dynamic participation from YOSI. The session truly reflects the evolving phase of our profession, driven by fresh ideas, global thinking, and a strong sense of purpose. From innovative education to leadership development, today's talk promises to deep insights and inspiration for all of us. I congratulate all the speakers and welcome all the speakers, and thank our panelists for accepting our invitation for supporting this journey. With that, I hand over to our moderator, Dr. Zain, to guide us through the session. Thank you.
Thank you, sir. Thank you so much, all. So we move on to the first topic. First topic is by a very dynamic current secretary of YOSI, Dr. Nilesh Kumar, and he's going to be talking on YOSI membership. What's in it for me? Nilesh, you can share your screen and you can start.
Thank you so much, sir. Thank you for inviting me. And thank you, Piyush, for providing YOSI this opportunity and the entire MOS Governing Council. So I'll start with why join YOSI. So I am the current secretary from 2024 to 2026, and as per YOSI, we are a registered society that is also affiliated with All India Ophthalmological Society and the International Council of Ophthalmology, and it caters exclusively to the need of ophthalmologists in training or under 40 years of age. This acts as a bridge between senior leadership and young ophthalmologists, and we try to positively impact the lives of young ophthalmologists. And this is how it began. It began with the idea from Dr. Tarun Arora and Dr. Vijay Sharma, and it started as a Facebook page on New Year's Eve. And these are the founding members. And it continued as a Facebook page for discussion and networking till 2018, and it was doing a very good job. Posting about clinical cases and different opportunities that are available, and doing some amount of leadership job as well. And now it has become one of the largest, in fact, it is the largest VIO group of the world. And anybody who's joining YOSI will have access to YOSI publications. There are various publications, including VIO Times, YO Slides, and YOSI Flash Notes and all. And it also gives you access to the online repository of essential reading material. Apart from that, you get to be a part of the community, the WhatsApp group that is there, where all the discussion regarding your exams, your Viva, and your career opportunities, everything happen. And you also get to participate in YOSI sessions, webinars at international, national, and state levels. You can also submit your videos to YouTube to get a wider popularity, which has a following of more than 5K, I think, right now. You can also submit flash notes and VIO slide to the YOSI publications. You also become eligible for the annual YOSI, that is YOSI VIO Award. And now we are going to make it more grand in this YOSICon that is coming up. It also gives you access to YOSI Fellowship Help Desk, which has now been rebranded to YOSI Help Desk, and we are giving all kind of help there from your career to mental counseling and your any kind of mental support also that you want. We have collaborated with a startup that is doing that, and you also get to participate in annual YOSI writing competition, and there are much more. So let's see what all is there. So this is the first formal team that was made under the presidentship of Dr. Digvijay Singh sir is here, and Dr. Sonal Kalia was vice president then. And after 2 years, Dr. Sonal Kalia took over as president, and Dr. Devakant Mishra as vice president, and Dr. Karan Bhatia as secretary, who is right now our current vice president. So now the current guard from 2024 is Dr. Devakant Mishra as president, Dr. Sonal Kalia ma'am as Dr. past president, Dr. Karan Bhatia as vice president, Dr. Nilesh Kumar as or me as secretary, Dr. Sethi as treasurer, Dr. Prasanna as joint secretary, and a very vibrant group of executive that is taking all the initiatives that are there in YOSI to another level. So this is the first session of YOSI we got in 2014 at DOS annual conference, thanks to Dr. Rajesh Sinha sir. And that mentorship continued, and we had a AIOS YOSI forum in 2023, which graduated to become the first YOSI Con in 2024. This was a completely physical event, the first full conference that YOSI held under the leadership of Dr. Sonal Kalia and Dr. Karan Bhatia in April of 2024. And now we are in full preparation mode for this second YOSI Con. This is going to be the largest YO meeting across the globe, and we have more than 600 submissions and counting. We have national and international delegates that are coming from 6 to 7 different countries right now, and around we are hoping 10 to 12 more countries to join in. And we are also going to have sessions for all the supporting societies, all the senior societies that have helped us throughout the YOSI journey. We are going to invite them for their own session, and there are also multiple new initiatives that can be found on yosicon2025.com. Also, ongoing is YOSI essay writing competition right now, and it has a very vibrant topic that is, does artificial intelligence make a better ophthalmologist? If yes, how? And if not, why? And I'll like to tell a personal anecdote. This is the first, in Indore, I had participated in this YOSI essay writing competition, and I was second in that. And that was my first YOSI engagement, and that wasn't when Sonal Kalia ma'am was taking care of that, and is still doing so. This is the first EO pavilion that was given to us in Indore itself, AIOS 2019, and now that has continued throughout. And this is the latest when we got the international YO pavilion at APO AIOS in Yashobhumi, New Delhi, and we had multiple events and participation from all the international delegates, international YOs that came. So apart from these are the glimpses from last YOSICon, the academic and the fun part both are being there in YOSI. Also, you get to have a lot of international exposure. The latest being Dr. Prasanna V. Ramesh representing YOSI and YOSI and India at Taiwan, the global YO summit that was there. This started with Dr. Taruna and Dr. Mayank Bansal going in the first ESCRS meeting in London. There are also opportunities where you get to be interviewed by international media agencies like Media Mice. Also, you get to have an exclusive access to YouTube. This is actually a free community, but anybody who is YOSI member actually can upload. And with that, you will get more eyeballs to showcase your skill and your topic. This was the first YO time that was brought out. And now we have, this was the final issue of the first first volume. This was the oculoplasty issue in April 2024, and the volume 2 started in UPCon in November of 2024, and we called it First Steps, and it had a unique approach where a senior person, expert in that field, and a first timer both gave an interview about how the difficulties and how to overcome it. It was headed by Dr. Prasanna V. Ramesh. And YOSI in 2024-26 is also going with offbeat collaboration. Like we have collaborated with Policy Bazaar to provide indemnity insurance to all our members at very, very cheap rate. And also financial planning, like sessions with Sharon, the financial influencer. We also have collaborated with international societies like Ophthalmology Foundation, where we will get more discounted rate for appearing in the Ophthalmology Foundation international examinations, and also the collaboration with Retina World Congress, where you get an opportunity to be the part of Retina World Congress annual meeting at Florida, USA every year. There is also newer initiative like IROC being taken care by Dr. Nupur Goyal ma'am. The prelims are already over and we are now heading into semi-finale. So these are giving opportunities for residents. We have fellows face-off by Dr. Apurva Ayachit. Bio is being taken care by Dr. Niranjan Karthik. Then there is Future Leader Academy, Say Yes to Podium, and YOSI Eye Skills Academy that is being done in for YOSICon. So all these new initiatives are exclusively for YOSI members. These are the sessions that we part of, and the open form is rolled out for anyone. And you might get your first faculty tag through these sessions, because as YO, we are not actually eligible to be talking in the senior podium, but through YO, we get that faculty tag, and it gives us a boost and a confidence to be a part of that elite group. There are also upcoming events, YOSI session at IIRSI, YOSI session at AIOC Mid-Term Amritsar, and multiple state society sessions. So if you want to be a part, become a YOSI member, and please drop in a message to any one of the governing council or executive member, and we will try to include you that. Also, the upcoming is YOSI iSiksha, that is the physical CME, one-day CME and conferences that we are organizing. One on 6th July is in Eye Care Noida, headed by Dr. Nupur Goyal, and I am taking care of this Retina Conclave on 20th July in Patna. Also, most active social group, most active YOSI groups or the presidential working groups, that was the brainchild of Dr. Sonal Kalia and now has been taken care by Dr. Devakan Mishra, is YOSI Socio-Cultural, then YOSI Journal Club, YOSI Medical Legal Series.
Nilesh, I think your screen is frozen.
Frozen, okay.
Yeah, it's on upcoming events. Is that the screen?
No, YOSI online activities.
Yeah.
I just reshare just one more slide is there.
Yeah.
Is it visible?
Yeah. Now I think we need to sum up because
yeah. So I'll again invite you all to YOSICon 2025, and this is a QR code you can scan and become part of YOSI, or you can just log into www.yosi.in and become a member. Thank you, and I invite everyone for further merriment at YOSI.
Thank you so much, Dr. Nilesh. So that was, you've very brief summarized everything. It will take a long time to describe all the activities ongoing with YOSI. That is what YOSI stands for. But very well summarized, and I'm sure it's given a lot of youngsters a reason to join YOSI, those who have not joined. So we have Dr. Digvijay sir and Dr. Aarti as panelists for this talk. So Digvijay sir, what would you like to say about for members wanting to join YOSI? Do you have one good reason for members to join YOSI?
Yes, absolutely. Thank you, Zain, for having me here. But I think the need and requirements of the young ophthalmologists are quite different from what the senior ophthalmologists or established ophthalmologists have. So it's probably very, very important for you to get access to that. To be able to get your needs fulfilled, you need to be part of a young ophthalmologic society of India, because that's something that maybe the AIOS or your state society or your specialty society may not do for you. So there's a lot here for you. Join and see. Trust me, we set it up and it's grown like anything. Wouldn't have happened if there was nothing in it. So you'll really get something out of it. You must join.
So so I'll say that I second Dr. Nilesh and Dr. Digvijay has said. Just to add few points, I'll say that today's generation is very lucky to have something like this available to them. Like, we joined YOSI when we were out of our residency and fellowship, but you are lucky that something is there. It will help you connect with your own colleagues from other part of the country. You will know what is happening there, which you might be missing in your institute. On top of it, it brings out a lot of qualities which you might be hidden in you. You might not even know. Like, I may not be able to make a presentation. I may not be able to take a lead. So YOSI will give you opportunity where you will find your own strengths and that will help you grow. This I'm telling from my own experience. And beside that, it's not only state exposure, it's national and international. You would have seen how YOSI has grown in last 10 years. COVID time when everything was closed, but I think YOSI was shining very well, keeping the morale of young ophthalmologists that, we are there for you. Wet labs were happening. People were getting new ideas how we can learn even when we don't have patients to work on. So once you explore the website or once you speak to somebody who has been part of YOSI, you will not think even twice before taking the membership. So I'll just say that you really don't have to think because there's nothing to lose. It's only you're going to gain. So I think that's it.
Also, just before signing off, I'd like to add the YOSI membership is dirt cheap. It's like 2,000 rupees for your lifetime. So it's nothing, right?
Yeah, it's
And
practically
Nilesh, if you
free.
can
I
say
mean,
how
you
many
eat that over
members we
dinner,
have
yeah.
currently in the society, that
we
would
have
be a...
around 1,900 registered members, and we have a community of 5,000 on Facebook.
Wonderful.
Nilesh, can I ask one thing?
Yes,
Yes,
sir.
sir.
I'm 55,
Yes, sir.
still young at heart. Can I get membership of, yes, can I get membership of YOSI as also members? I'm 55, but still young at heart.
Nilesh, that is over to you.
Sir, we would love to have you as YOSI mentor.
Mentor.
Yeah.
We need a device to reverse aging. I'm sure all seniors actually want to become YOSI members now. They hope it was there at their time. I mean, that's
Okay, so we shall go ahead. We just have a slight change in the program. Dr. Sonal Kalia ma'am is going to be speaking next. So she's very graciously agreed to be part, and unfortunately she's down with COVID. So thank you so much, ma'am, for joining. So Dr. Sonal ma'am is past president YOSI, and she's currently associate professor of ophthalmology. Thank you so much for joining, and she's going to be talking on shaping the leaders of tomorrow with YOSI. I request all speakers to stick to the 6-minute time so we can have discussion as well. Over to you, Sonal ma'am.
Is my screen visible, Zen?
Yes, ma'am, it's visible.
Is the entire screen visible? I don't know. I'm getting some sort of split view over here, actually.
It's visible and we can see your desktop background as well.
That's what I'm not able to remove it, actually. So how do
You
I...
can stop and share again. Now we can't see your screen.
Yeah, I've stopped it. And I'm trying to go with the keynote.
Ma'am, once you share your screen, just click on the green color box on the top left, the green color arrow.
It will maximize it.
Yeah, it will maximize your full screen.
Okay, done.
Not...
Yeah, we can see your screen now. It's full. It's
Yeah, I know,
in
but
full screen.
it's not going full. Is it full screen now?
Yes.
No. I don't know what happened. I'm so sorry.
It was full screen for us.
Is it full screen now?
It's full screen, doctor. You can start, please.
Yes, it's full screen.
Okay, thank you so much. So let me begin by thanking Dr. Zen for graciously inviting me to this event and for acknowledging that YOSI should be, getting a full session at state societies like MOS, even in their, midterms. And thank you so much, Piyush sir, for letting YOSI be a part of this particular event today. So the topic given to me is, shaping leaders of tomorrow with YOSI. And what I want to say here is that I will begin with my own journey in YOSI a little bit. It's a bit of nostalgia for you, but I'll just start and say that, is my slide moving or not?
No, doctor, not moving.
It's not moving ahead.
Okay, so is it moving now?
Yeah, now it's moving.
So I'm beginning with a bit of a nostalgia here again. And I was a part of the initial Biotimes team that Tarun had formed. And the very first issue also had my own article in it. At that time, I was a freshly minted PG. I passed out in July 2013 and had begun my SRship and got in touch with Tarun and started getting involved in all these activities. Within a year or so, I was also, sent for the LDP program. And I got in touch with Professor Natarajan sir, who saw so much potential in young people, and he started the first edition of AIOS YOSI writing competition. It appears like a very small thing to anybody, but just look at the people that it has brought forward. I would want to congratulate Divakant for the umpteen, things he has achieved personally, but much more that he has done for YOSI per se. So the first time that I was in touch with him was at the Coimbatore conference, and we were planning for things ahead. And the writing competition was at this particular around this time, and the prize ceremony was in Jaipur. And he got the third position. There were other winners. Apurva was there, and Ms. Kaur is there. So many people that came out from this. Nilesh is there as a second prize winner in one of the other competitions. So many people. Pranesh. I mean, I really feel that this competition brought out a lot of ideas. Why? Because it was not a set pattern. You didn't have to present a case. You had to present your own vision in some way or the other. And that is why probably it brought forward people who had a vision in them. And we went on and on with the various, sessions of this competition year after year. And the various judges that came to get involved with it, they also, in a way, played the part of a mentor to these particular winners. And all these prize winners, Prasanna, Dr. Bharat Gunani, they are all doing very well in their own profession and also contributing to YOSI in a very good way. I just want to share these the photos of these winners, not because this is how any person can come forward, but this is one way that YOSI has brought these people forward. And then came the initial brainchild that was, how I became part of the YOSI community was through the YO Times, where we used to write down so many things and pen our thoughts. That YO Times has now gained so much traction coming forward with the subspecialty issues that again Divakant started. So it was a great achievement. And what YO Times taught me personally was that it is through teamwork that we all can move forward and empower more and more people. When they get an opportunity, the entire community moves forward in a way. But I would be amiss if I do not recognize that there have been seniors like Dr. Rajesh Sinha sir, Dr. Namrata ma'am, who have acted like a bridge. They have brought us forward and they have helped YOSI move forward also. When they bring us forward, we have acted like a bridge between them and the juniors who are now coming forward and taking leadership positions. They have given umpteen opportunities to the entire group that we have, and not just at various their own conferences, but at various other levels also, by showing us the path, how to communicate for these industry partners, how to get sponsorships. They have helped us handheld literally through so many different things that I and Dr. Digvijay and Dr. Karan have witnessed personally, and Nilesh and Prasanna will be witnessing shortly, I suppose. So for me personally, I have realized that the teamwork that began with Dr. Vijay, passed on to myself and Divakant and Digvijay sir's, brilliant mentorship for me has instilled in me the confidence to start something called as the presidential working groups. I started all these working groups and they brought forward so many brilliant stars, I should say. One amongst them is Dr. Nupur Goyal. I know her through residency, but she really shone through in the General Club and Socio-Cultural. She mentioned that she will do this regularly. And I thought, okay, if not very regularly, at least it will come out once in 2 to 3 months. But it has been bang on. Every month there has been an event or the other. So 3 cheers for her teams. 3 cheers for medical legal team by Dr. Dipanshu and Dr. Aarti. They have done such a wonderful job. The ocular trauma team, and they're all continuing that job. That is something that gives me immense satisfaction, that although I'm not a part of each and every presidential working group now, but all those working groups are continuing in a much bigger way than they started off. And the YOSI representation at the midterm and the AIOC main conference has been continuing, and I hope that it continues to grow. And we have had a plethora of events at various, national level events, at various national level society events, be it Delhi, Rajasthan, be it, Moscon. All the societies have given us a 1 hour, 2 hour session, and that has really boosted the confidence, because it gets in local students, local PG students, an opportunity to not just bind with YOSI, but also present, where they were not getting maybe a faculty role, but now they would get that through the session at YOSI. So that is what I feel has been really immensely helpful. Next, coming to AIOS LDP nomination. Thank you so much, Nupur and Aarti, for sharing this journey with us. And I hope that you have gained immensely from this. And Divakant would be perhaps the person to share much more regarding this. But I just want to say that he is the sole person who has moved forward with this foreign society work in a very big way. He has helped so many societies in Asia Pacific and all over the world. And he was instrumental in starting the ICO, liaison along with Digvijay sir. They both deserve a real applause for starting this entire thing. And from my side, I want to say that with the help of mentors like Dr. Digvijay, Dr. Namrata ma'am, I have moved in my personal journey also. And in while moving in this personal journey, for me, I think the biggest lesson was that what I want for women bios in future is that through societies like YOSI, they should never have to feel left behind because of family reasons. I have traveled with my family at various events and people have made me feel welcome. People like Dr. Karishma, Dr. Zain, when I was traveling with my 1-year-old kid. And so similarly, I hope that YOSI is also able to take that forward for the millions of females who are probably not able to, think even that they should travel at such a stage in life. I'm not trying to be privileged over here. I'm just saying that, yes, if we show people that this can be done, 3 more people may come forward tomorrow despite the constraints and move forward. So along with that, I wish to mention that
Dr. Sonal, can we sum up because we have
sure.
the
These
next
are
lecture.
just last 2 slides. So I'm really thankful to Dr. Prasanna and Dr. Nilesh for bringing forward new ideas like Say Yes to Podium and the Future Leaders Academy. I wish Dr. Divakant and his team a great successful tenure ahead. And thank you so much. For me, the journey has been about YOSICon, when seniors used to ask, what is YOSI, to the first ever YOSI conference. And I hope that it's going to be a bigger collaboration this year with Divakant at the helm. Thank you so much. And all the best to the entire new team also.
Thank you. Thank you so much, Dr. Sonal ma'am. That was fantastic. And, your journey truly is an inspiration for all of us. I request my good friend, Dr. Prasanna Ramesh Venkatesh, to get ready with his presentation. He's the current Joint Secretary. Meanwhile, is Dr. Sean here? Dr. Sean, sir, current Treasurer of MOS. Is sir here? Okay, so we'll move ahead to the next talk. Dr. Prasanna, you ready?
Yes, Zain.
Yeah. Prasanna is the current Joint Secretary of YOSI. He'll be talking on something which he's very good at, that is connecting globally, outreach and networking strategies. Over to you, Prasanna.
Yeah, Zain, as Dr. Sonal Kalia rightly pointed out, leadership is not only about titles, it's about influence. And it is so heartening to see YOSI grooming future leaders who will shape the direction of Indian ophthalmology. Thank you for excellent presentation and all the best to the YOSI. All the members who are still thinking whether to join this YOSI group or not, they must join it. Thank you.
Speakers, please 6 minutes, okay? 6 minutes, follow the 6 minutes. We have a 1-hour session only. Yeah.
Zain, is my slides visible?
Yes, visible.
Yeah, thank you. Thank you to Zain. Thank you, Piyush sir, and the whole MOS team for this wonderful opportunity. I did have a few of our candid clips, which I cherish the most. Thank you for all these wonderful memories. So the objectives of the next 5 minutes: engage, collaborate, inspire, represent, and network. So these are the international networking things that I have learned, especially from Dr. Divakant, our president. And why do we need to collaborate globally? We need to bring long-term collaborations, especially in terms of clinical and research practice, opportunities, fellowship, and innovation exposure. So that is what really puts us on the globe, and we need to engage. Again, I would like to thank Divakant and Nilesh, as well as the previous office bearers here for identifying me and giving me the opportunity. I'll just stick to some of the personal, benefits or what really put me forward. So in 2019 was the first time I moved out of India for an international presentation as such to the World Glaucoma Congress in Melbourne, where I ended up learning the minimally invasive glaucoma surgery 6 years back. And that put me on a global scale today, where I am on the other side of the spectrum, teaching people. So it helps you learn early, and scientific, semantic, scholarship work, surgery or medical will always put you forward from leader to learner you'll be able to, move forward. And this is another person, well-renowned Malaysian Glaucoma Society secretary, who came recently to me for mixed training. So that is one way to network. Second thing is collaborating. In the Asia Pacific Congress, if you see, for young ophthalmologists out there, AOS as your own travel grant, which you can see that was one of the route channels that I started entering. So try to tap in the travel grants and go to congresses, which gives you a lot of global recognition, be it your awards or be it your network, your channel, chief instructor. These congresses, they give you a lot of offers like photograph competition, which you can really pitch in yourself, and it opens door for you. When you win a grant, the registration also gets freed and you also get your travel as well. It builds visibility, creates connections, and that's one of the pivots of how my journey started shaping, where I was able to reciprocate the same in the World Glaucoma Congress, where you get free registration and you win a €1,000 grant, which covers your travel as well to an extent your accommodation. So anybody out there, until you're 40, 45, you can tap in these grants. Go and network with these people like Clement Tam, the Secretary General of APAO, Dr. Aik Ahmed, who's very well famed for it. And you also have the accommodation grant by ASCRS, which are some of the grants that, being a young ophthalmologist, is something that you can win. And you can see this is my checkout bill that I wanted to share with all the residents out there. As a young ophthalmologist, you get a 5-star hotel in US if you are able to win a grant for 5 nights in congresses like ASCRS, WGC, which is happening in Hawaii next year. And all these are my own personal experiences. So towards global networking, when you travel, where we had the global YO last year, where the current office bearers of YOSI went along with myself as well, where I was able to meet Dr. Professor Ong Tin. And, you go into SNEC, share your work and what is that you are really pitching into it. And that makes you a lot of exposure as to what is the work that you're taking through. And once you build your network, once you take positions where I am the joint secretary of YOSI, we were able to negotiate and as well as collaborate with the Nepal Ophthalmic Society, which was something that I was able to foster, going in the shoes of Dr. Devakant Mishra, our president, who has collaborated many such networks like this. And you also get more opportunities like this. So this is a recent invitation letter where I got for the APGC as a faculty, first time going there as a faculty. Once you network with people, once they know what is that you have to offer, you'll start getting opportunities as well. Inspiration is one, and you can inspire people. You can get inspired, when you meet all people, audiences, and that has an impact on you. And you start aiming. For me, it was Shark Tank that I was aiming, and recently I was able to win $5,000 in a Shark Tank competition, which I was planning for last 5 years, and I was able to crack it this year on the global scale. So it's only a matter of, going to these congresses, networking, what is that they want, what is your niche that you're looking at, whether it's a competition or whether it's a memorandum of understanding between two associations, or, trying to aim for the grants that I talked about and whatnot. And putting your work out in a romantic way, be it the ACRS podium, whatever you get, whatever scientific podium that you are going to get, inspire, leave something behind. And this year, when myself, my good friend Zain, we all came out with a book, and we have placed this book wonderfully in the Asia Pacific platform as well, where it has been well reached among 28 countries here that you see, are all APO, LDP batchmates of mine, and it has shared many continents. So that's another way of networking. And always say yes to opportunity is one of the penultimate summaries that I want to give you. Participate in congresses, make yourself more active, make yourself more proactive, and then the awards or the recognition will follow. And this was one of my most cherished moments, where I was able to do the APAO LDP after completing my state, my national AOS. I was nominated for the APAO LDP, which is one of the pinnacle of networking that I would say, where you get to meet 28 countries and you travel with them for 1 year. And after you graduate, you get a prestigious badge as well, and you get this relationship for lifelong. That really put me on the global map, and that really fosters a lot of bonding, a lot of networking opportunities, and that gives you a chance to represent more. And as you saw in the media mice that my friend Dr. Nilesh also was sharing, so once you get yourself visible, media mice recognizes you. I was one among the 50 in ASCRS, one among the 20 in APGC. So you get these recognitions, and all these will follow once you start putting yourself on the pedal. Be it the congresses that I am active in is APAO, ASCRS, and then once you organize something, you can bring all these countries in. So we had one state global
Prasanna, you need to sum up.
last 20 seconds. So where we were able to bring them, and in your times as well, when we came out with this first steps issue, we had 5 international people contributing for our council as well. So you participate, you know, and this is something that Nupur ma'am will agree with me. Recently, socio-cultural is something that I am taking forward for the globe to see what Indians are really there. And whenever you get a podium, leave no stone unturned. And this is the last week where in Taiwan, the Indian contingent, Pooja Kamar, myself, Dr. Anujun, were performing the Why This Kolaveri song as well. So leave no stone unturned, my dear friends. Indians are right up there, and global networking is the way forward. And if we can, I think we are the team YOSI, which is going to take everything forward. So thank you once again, Zain, for giving me this wonderful opportunity. I would end with this picture, my third Yo Global Summit, where I was able to represent India, which is a very proud memory that I cherish. Thankful to Devakant and Dr. Nilesh for this wonderful opportunity to represent India among the whole global YO leaders. We had 50 countries or more participating. Thank you once again, Zain, for this beautiful opportunity.
Thank you. Thanks, Prasanna. So, see, if you want to attend as many conferences as Prasanna, you have to win that many travel grants as him also. So, you know, a lot to get inspired by, Dr. Prasanna. We have 2 panelists, Dr. Avanish sir and Dr. Neeraj. I just would want your quick comment on, you know, what are your opinions on how young ophthalmologists can network better internationally?
Should I go first?
Yes, sir. Yes, sir. Yes.
So a couple of things which I just want to add, like what Dr. Prasanna said, that participation is a must. And how do you actually go about, like first either you want to go for congresses or you want to have a fellowship. So these are the 2 things where, you know, you actually pitch in, where you want to add it to your CV. So to get into that, I think participation from your state conferences and, you know, going to your national conferences, and then getting into what Dr. Prasanna was rightly talking about is getting into those grants which they provide. And there are a lot of places where you can actually pitch in, where you can actually send a mailer as well, stating that you have your, like you have sent in a case or maybe a research paper where it has got selected, and then you can actually ask for some, what do you call, so if they can sponsor or they can help you out in that. So there are some societies which they actually help you out. They go in and they do that. And I think the most important thing what he talked about is having a good network would actually come in when you start attending these sort of conferences. So these are the conferences where you actually have good people who actually come in forward, and if you have a good resume and if you have letter of recommendations, they will actually help you out and they will get you to the bigger stage.
Thank you. Thank you, sir. Neeraj, quick comment from you.
Then I think the first international conference should be attended in a residency. That's very important, because I attended my first international conference with the intention to roam the entire city. But once I entered the conference hall, I was there for the next 3 days. I also won the best paper over there. And yes, that is how it should begin, because that, like Sir said, it adds to your CV. So like Prasanna said, it's very important to start taking slowly steps as early as possible. Networking happens on its own. If you're passionate about ophthalmology, you'll keep meeting people and you'll keep growing as an ophthalmologist by attending these conferences. That's what I feel.
Thank you. Thank you both panelists for your comments. So now we go on to the next topic, that is YOSI Beyond Ophthalmology, Socio-Cultural Perspectives. And we have another YOSI heavyweight, Dr. Nupur Goyal, who will be talking on this. I don't know how she gets time to manage socio-cultural with so much of, academic work as well. Over to you, Dr. Nupur.
Am I audible?
Yes, you are.
And my slides are visible, I hope. So I'll just quickly, so what do you understand by creativity? So creativity is intelligence having fun. That was said by Albert Einstein. So a very good afternoon, everyone. At the outset, I would like to thank the entire MOS leadership team, Dr. Zai and Dr. Piyush sir, for giving the opportunity, the entire YOSI team. And it's a privilege to, present this in front of Dr. Usha Johri ma'am, with whom I think when I was in Bombay, my journey in academics and cultural started. I remember performing in BOA 2019, in the thing. So it's an absolute pleasure. So thank you, ma'am. All work and no play doesn't make just Dak and Jill a dull. It kills the potential of discovery and lot more. So, when I stood for this executive election way back in 2022 in the last term, so I had this, vision that I want to start an extracurricular wing for the Young Ophthalmology Society of India. And so two people who, Dr. Harshul Tak, who started this Live Beyond Ophthalmology, and Dr. Sonal Kalia, who's one of my best friends since PG, and also the immediate past president, then the president when I was standing for the executive and I won the election. She, realized his dream and she said, yes, let's go ahead. And, she helped us form the socio-cultural group. But she said this has to be different from the Live Beyond Ophthalmology. So we are the socio-cultural group. She also created a lot of presidential working groups, as you can see, and the socio-cultural was one of them. So the main thing with socio-cultural was it was dealing with extracurricular for the young ophthalmologists, but relating to ophthalmology. So this is the previous YOSI Governing Council and the executive team and the current team, which has been very, very supportive in all our activities. So thank you so much. This was the previous YOSI Social Cultural team, and this is the current dynamic team with me, Dr. Priya, Dr. Raki, and Dr. Sunandani. So this is a bunch of, crazy people who are running this team. So we've come up recently with our logo, the vibrant logo. So what we are, I'll just, take you further. So the biggest challenge when we started was to think something out of the box. We were doing this something for the very first time. So we thought, why not start with something creativity? So we had the first, activity from socio-cultural on the World Sight Day, which was, the theme was Love Your Eyes. We had the creativity contest. Dr. Namrata ma'am presided as the chief guest, and we rolled out a Google form. Within 2 days, we had some amazing 7 to 8 entries, right from poems to artwork to Prasanna had submitted a beautiful comic strip. And so we also had a webinar on Love Your Eyes where we had a quiz, we had, makeup tips and a beautiful poem presentation. We also released, as Dr. Sonal had depicted, the special YO time celebrating the creativity of young ophthalmologists. So after that, there was no looking, backwards. So during that tenure, we did a plethora of activities. So how do we do it? So it's a thought process. So it's just really very abstract ideas, let's do this. And then we plan it. Okay, this is how we do it. And then we execute it. So we had another activity on Yoga Day. So with the first Yoga Day celebration, we had a guest speaker, Dr. Mohit Sharma, who's a cardiologist who spoke about facts and myths of yoga. And also we had a yoga and meditation session by an ophthalmologist, Dr. Soumya Ganeshanaya, who's a certified yoga trainer. Then the second year also, we had a very interesting yoga webinar wherein Dr. Prasanna, Dr. Karthikeyan spoke about the effect of yoga in glaucoma. And we had the YOSI Yoga Saga contest. This year too, we are celebrating the International Yoga Day, which was yesterday. So 3 of our young ophthalmologists have sent in yoga reels, and you can vote for them. This is an Instagram contest, and really inspiring to see, about their yoga journey. So laughter is the best medicine. So International Joke Day on 1st July, one of our team members, Dr. Manushree Gautam, suggested this YOSI LOL, wherein we had this webinar with young ophthalmologists submitting jokes, memes, their personal anecdotes, dance relating to humor in ophthalmology. And as you can see from the photos, we had a blast in this webinar, and this was the second season last year. Again, photography is so important for ophthalmologists. We have so many imaging competitions. So we thought, why not reverse it this time? Rather than having, imaging in ophthalmology, we decided to have ICI Everywhere contest, where we asked young ophthalmologists to submit nature photos relating to eye in any form. And we had brilliant, amazing. We had a great time. And we also collaborated this with Do-It-Yourself Photography in Ophthal Clinic. And we had the season 2 of this, where Dr. Zain collaborated with his YOTube team. And again, the results were fantastic. It was amazing. And so this is just an example of, how one of the contestants had sent one photo. So she correlated this picture that she had taken with a case of PCR scene. She says that the C is like the vitreous and the rays of light are like the cortex. So you can just imagine, so you can just see how imaginative and creative our young ophthalmologists are. Then we had the Creativity Season 2 contest on World Sight Day. Again, a beautiful presentation and a very successful. We celebrated Diwali in the form of Rangoli contest, where we asked young ophthalmologists to send their Rangolis on Facebook, YOSI Facebook page. They were asked to vote, and it was also judged by a panel of judges. So as you can see, the beautiful presentations of Rangoli, and it was so heartwarming to see how they correlated it with ophthalmology. So these were the prize winners. We celebrated the Glaucoma Week webinar in the form of glaucoma awareness through art and real contest. So what is the modus operandi? So we've seen that if we do it through contest, then people are more looking forward to it. We send out Google Form links so that it's very democratic. So everybody gets a chance to participate if they're a YOSI member, and they can, they fill the form. We come out with flyers. We tap the responses. We create WhatsApp group with all the response people, and we identify the appropriate judges, and we also stream these webinars on YouTube. So this is the example of the Google form, and then these are the responses. So it's there with me throughout, and that's how it works. So these are the flyers we create once for inviting the entries, and then for the webinars. So we generally do it, I generally make all these flyers on Canva, and we have a good flow before the webinar. We have a good flow of the entire webinar, so it is streamlined and it goes well. And we've already discussed. So what has really worked for us? Inclusiveness. So the biggest thing that I think has worked for us, be it a resident or a young ophthalmologist in practice, everybody gets a chance to practice, and there's absolute transparency. Also, we follow up. Anybody who is submitted, we personally follow up with the person, what they are presenting and how it is to be done. And we do a lot of meticulous planning and coordination. We get a good flow of events. There's absolute transparency. None of our results, have been questioned till now because we are very transparent in it. And of course, the personal touch of the social cultural team. We've had a lot of
Nupur, you need
international
to sum up.
Music Day, and we had the creativity contest. This was international creativity contest this time. We give appreciation to all our award winners. We release flyers, give them certificates and awards. What is the way forward? The power of social media. We've got a lot of Instagram contests, like the Youth Day. We had the Rangoli contest on Instagram. We had the Holy contest on Shades of Eye, and the ongoing Yoga Saga contest. So collaborations, teamwork make the dream work. So this is the presidential working group team. We had a lot of collaborations with the Corneal focus group, the tourism group, and the pediatric focus group, and the glaucoma focus group. We've had a lot of blessings from seniors. We had International Women's Day, wherein the senior women ophthalmologists gave their bites. We celebrated the Mental Health Day, wherein seniors, they gave their nuggets on in mental health, and we had physical beyond sessions. We also had the Bio Night at the YOSI Forum, and this was the annual YOSI Con, where we did the Bio Night.
Nupur, we need
as
to
you
go
can
ahead.
see. Yeah.
Dr. Nupur, we
Yeah.
have to finish
So,
in.
yes. So we've also come up with a band. We released a calendar, and we celebrated Christmas. We celebrated Mentors Day, and this was the Beyond session. And yes, so this was the last webinar we just concluded last night, Dance to Express. And so why we tried the mandatory YOSI reel, which is always there. So passion is energy. Feel the power that comes from you, focusing on what excites you. So this is socio-cultural for you. And we invite you to the Bio Night, Yuva Night at the YOSI Con. So this is YOSI socio-culture for you. Reels, photography, creativity contest, Rangoli art poems, and beyond sessions. Thank you so much.
Thank you, Dr. Nupur. So very difficult to pack in all what you guys do in 5 minutes. That's a lot of work, and hats off to you and your team. A quick comment from our panelists, Dr. Nikhil Nasta sir, who himself is into a lot of socio-cultural, and Dr. Yash Gala, who's a young YOSI member. Nikhil sir.
Then, first of all, congratulations to you. I have said something for you, which is Young Ophthalmologist Society innovates, interests, and inspires. So all of you are doing a fabulous job. I had a personal interaction with you all at Bombay, and it was phenomenal. Me and Karobi ma'am started socio-cultural back in 2017. We faced some opposition. It was unheard of. Lekin over the years, it's gone very big. I feel, when you're connecting without the pressure of white coats and PowerPoints, you connect better, you bond better, and it's a lot of fun. So I totally resonate with everything Nupur does. And Nupur, itna sara info, you have to, now I'm giving you a challenge, 45-second reel on all you do in socio-cultural should come up, not just a dance reel, okay? So I think Zen, it's pretty fabulous. And yeah, you guys are really doing a great job. Socio-cultural is very important.
Thank you. Thank you, sir. Yash, are you able to talk or not able to? Okay. So Yash, for some reason is not able to speak. No problem. We'll go ahead. We have the last talk of this session by a very dynamic treasurer of YOSI, Dr. Aditya Sethi, my good friend. He's going to be talking on innovating education, futuristic approaches to learning. Adi, over to you.
Hi, Zain. Thank you for the opportunity. Thank you, Dr. Piyush. Thank you, Moss. Can you see my slides?
Yes.
All right. So always the best comes last. So we'll start with innovating education and futuristic approach to learning. So the whole concept of having YOSI and all young ophthalmologists together is about promoting skill development and learning. And I think we are in a very nice zone today where skill, surgical skill, medical skill, everything can be taught from millions of miles away. And you don't have to be in the same room with the same person. So we have to be innovative, we have to be futuristic, and that's what we are trying to do. The tale of two Rams. So Dr. Ram in 1995 was somebody who used to travel to city libraries or watch his surgeries on VHS tapes and learn phacoemulsification. So attend conferences physically, takes handwritten notes, observe senior surgeons OT, no hands-on until he got his fellowship, limited global exposure because going abroad was also a luxury. But the same Dr. Ram in 2025 learns flax, smiles, MIGs, everything by just opening the right chat room or the right Zoom room, and gets feedback from AI graders, collaborates with his virtual ORs, has friends all over the world, including Japan and Europe, attends hybrid conferences, and already has a lot of publications. And he's also collaborating with doctors different places. So there's a difference in the same learner because of being in different eras. And this is what innovation does. So why should we innovate in ophthalmology? The challenge is that we are in a branch of science which is always progressing. There's new technology all the time. You buy something, another better thing comes up. That's how technology, and so should education. Because education, if it starts lagging and technology starts taking over, it may be soon that we will be having a backlog of human resources for the technology as well. So surgical techniques, devices evolve faster than the traditional curricula. And the opportunity is that we have AI, we have VR, we have AR, we have simulators, we have global networks. So all the right short forms are already there for you to make sure that you learn everything and there's no excuse that you couldn't. So build cost-effective, accessible, and personalized learning paths are already started. And the risk is that you're going to have inequality in surgically trained and you have a lot of burnouts in physicians all over the globe if you do not inculcate in the right technology for learning as well. So this is a graph, and that's how you see the technology change. So the changing learner today is not just somebody who is taking down notes. He's a Gen Z alpha ophthalmologist and he grew up with devices. They're very prone to jumping to a device rather than a pen. And this is what you have to value. And they also don't mind traveling the distance, going to different places just because they want to get the right mentorship or the networking. And sometimes they do it just online by dropping an email, as you saw in the previous talks, that sometimes global networking just be that by writing the right email or getting the right grant. So new expectations are there. And what that means is that they want to learn more at home. They want to have a gamified experience. They want to have immediate feedback of how they're doing. They want to have a total control over their own training. And a lot of articles have suggested that this is something that is a preferential way of doing the practice today. So technologies that are already there is VR and simulators. You have the IC, VR Magic, Help Me See. You have AI-driven feedbacks. You have a lot of YouTube channels like Cataract Coach, Touch Surgery, AI analytics. Of course, ChatGPT is already there and a lot of us use it. You have gamification. We have, even in conferences, we have a lot of gamification happening. The global networks, there's CyberSite, this APO, YOSI itself is a big forum for learning online. We have VR simulators reduce. This is an article that I came across that they saw that a fewer number of PCRs and cataract trainees if they were doing VR simulators as per doing more on more numbers. So it is slowly going to replace a lot of what and how we learn. Another few articles about retinas, about specialities, even in extraocular muscles, you have a lot of VR simulators available for learning squint surgery, retinal surgeries as well. And they're doing really well, and they're low cost and of course much better. This is a resource that's available online. This is the AR VR education app. It's already available in the Meta store as well. So metaverse in ophthalmology is you have the Fidelis, you have the Help Me See, you have the haptic VR, standalone VR, collaborative VR, all for fundamental surgery now available for ophthalmology as well. And it's all over the globe. India is a forefront runner in AI and as well as VR, adapting to VR as well. So we should also embed it as fast as possible. There's a lot of personalization and adaptive learning. It's not just with your patients, it's with you as well. It basically means that you have to adjust everything to the person's personality and the customization rather than, a blanket way of treating, oh, go through this, go through that, do ECC, do your sutures. It doesn't work anymore that way. And VR actually makes it more easier to do customization because you don't really have to make the extra effort as a teacher as well. And it can be beautifully structuralized. Languages, again, is somewhere where AI and simulators have worked very well. Going to different countries, it's much easier to converse today thanks to AI, and you can get your education happening right there, right then. So again, a little bit of global collaboration. I think Prasanna has covered this beautifully. So it breaks barriers and it teaches you things that you won't. Prasanna made a very simple statement that he learned MIGS by attending a conference. I think that is how most people learn phacoemulsification once upon a time. So it is getting there. And the balance has to be maintained. And the challenges are there. There's access is inequality, cost barriers are there, accreditations are not there yet, standardizations are not there. There's no control about how you're going to do it, which is the better one, which is not the better one. No ratings are there. So it's very important. And the future is going to be more into fostering public-private partnerships, getting these startups going, investing in them, and you're making things happen. There are a lot of global game-changing stats, which I can show you, which is about 60% now are going towards VR trainees, and surgical errors actually shot down to a large extent. And what we have to do is embrace this, not let it go. And best way to predict the future is to create it and not just wait for it to happen. This is something which requires another talk, is about MAL. Americans have already started using this. We have a lot of articles and a lot of ways of now stimulating, especially in emergency rooms, how medicine can be, perceived. And my last slide is the journey ahead is that we have to evolve as fast as our technologies are evolving, as far as learning is evolving, and innovation is the ability to see change as an opportunity and not as a threat. So I think this is very, very important for all of us to understand that AI is not a threat, it's just an opportunity, and VR simulators and all are here to stay. Thank you.
Thank you, Aditya. That was very comprehensively covered. A lot of new technology going on in the education sector as well, and hopefully YOSI is going to take up some of these.
Yes.
Over to Dr. Piyush Bansal to just conclude this YOSI session and hand over to the next.
Thank you, Zain. What a lovely, lovely session. So it's so nice to see everyone over here. Thank you so much to be over here, first of all. I generally don't make these sort of comments, but YOSI always kind of makes me a little emotional. So me being a YO member since 2019, I think when we attended the first YOSI Con, and having known Divakant far before YOSI was something really cool, and then literally seeing the evolution of YOSI early stages with Divakant, with Avnish, with Indivar from here in Mumbai, who's now not to be seen very active. But seeing them taking it through this initial journey was something that I have seen evolve. Me receiving a YO travel grant via YOSI for an international conference, I think in 2019. So that was something that I appreciated at that point of time as well, echoing my sentiments with all the whatever the speakers have just said. So it's a great opportunity to form new friendships, bring strong bonds, because it forged very strong bonds for me between other YOs. I'm obviously very grateful for my deep friendship with President Divakant, with Karan, with Dr. Vijay, Colonel Vijay, Prasanna, Sonal, of course, Aditya, Nilesh, Nupur. I mean, fantastic. Nupur, the amount of work that Nupur does. When I look at her smiling, I just forget about any sadness that I particularly have. So many YOs, the election, the ECs, some of them are my best friends, which I, sometimes I go through difficulties, I still share things with them. YOs from Maharashtra, Rohit was very active, Akshay, of course, now we got Zay, Neeraj, Ashish, Nikhil. So these are the YOs that are actually going to take it higher for AIOS in the future. They're the budding leaders. So as for support for YOSI and use in MOS, this is a start. We would want to do more sessions, joint webinars. This is my promise that all the support that I can offer. Our team is fantastic, whether it amounts to surgical training, our secretary, our president. We would definitely have. I've already informed Diva that we'll have a YOSI session, a physical YOSI session in Moscon, Goa as well. So with complete freedom of keeping some surgical training sessions or anything else that YOSI needs. We'll probably sign a MOU very soon between MOS and YOSI. And of course, the Maharashtra chapter of YOSI, which we tried to get started earlier, we would want it to, write faster and make sure that we have more representation from the state that has the highest number of trainees and ophthalmologists in the country. So thank you very much, everyone. Thank you for being over here. If nobody has any more comments to make, then we'll...
Can we take a quick photo for YOSI with the symbol?
Yeah, sure.
Okay. Yeah.
So with this, we hand it over to the next session of a lot of practical significance. Dr. Ashish, are you there?
Yes. Yes, thank you, Dr. Piyush. So we move on to the last session for this MOS midterm meet. And I request speakers to please stick to their time of 6 minutes. We'll be discussing on insurance queries and practice management, very relevant topics in the current scenario where there are takeovers happening by corporates and difficult for smaller clinics to survive. I'll first introduce our chairpersons. We have Dr. Suhas Haldipurkar. Sir has been one of the pioneers of phacoemulsification in India, and over 3 decades, his name has been synonymous with world-class cataract surgery. And then we have Dr. Jagannath Buramani, sir. He has more than 15 years of experience and has established a state-of-the-art eye hospital in Navi Mumbai. So it will be very great and useful for us to get their insights. And on the panel, we have Dr. Nikhil Nasta, we have Dr. Arjun Ahuja, Dr. Anaga Hirur, Dr. Vaishal Kenya, and Dr. Santosh Bede, sir. The speakers I'll introduce as we go. So without wasting much time, we'll start with the first presentation, that is by Dr. Santosh Agarwal. Sir, I request you to please share your screen.
Yeah,
Dr.
thank you.
Santosh.
Yeah, thank you, Dr. Ashish. Good evening, everyone. Just I will share my screen.
So sir has set up a very big practice in Aurangabad and faced a lot of challenges initially and has a phenomenal practice, and it will be useful to get the insights.
Can you see my slide?
Yes, sir.
Okay. So thank you, organizers, for giving me this opportunity. I am going to speak on pearls for successful private practice. Whatever I got the experience throughout my career, that I am going to put forward. So success begins with the first step forward. Take the first step. So well begun is half done.
So sorry to interrupt. Can you please make it slide share, please?
Slide is not visible.
Full screen actually. It's the PowerPoint show mode actually.
1 minute.
Or from the beginning on the left-hand side top corner. So left side पे ऊपर top पे.
It says from beginning.
From beginning.
Sir, file के नीचे लिखा
Okay. 1 minute from the beginning. Okay.
Click on
visible now?
No, Santosh, click on it.
Yeah, already I clicked.
No, you haven't. Go there, click on it.
Sir, I'm just stopping it for a minute. Next time, Abhi, just click on share screen and select the entire screen.
Okay, 1 minute.
When you share, just share the entire screen, not the PPT. Just share. When you share, just choose the first option, entire screen, and then share. Now you can open the PPT, sir. Yeah, from beginning again. File के नीचे से.
Is
Good,
it
sir.
visible?
Thank you. All good, sir. All good, sir.
Okay, thank you. So my topic is Pulse for Successful Private Practice. I am going to put forward whatever little experience I got through my career. So what is successful practice? It begins with the first step forward. Take the first step. Well begun is half done. So how to start your practice? Arm yourself with good knowledge and skill. Be confident initially. Select a right place where there is a demand and relatively less competition. Start with low to moderate investment. If you are from a middle class, start with low investment first. Work hard. Once you pick up the practice, invest more and more. Go like a step ladder. See, in practice, everything matters. You should be all-rounder. Your personality also matters. Your behavior, your attire, your language, body language, your fluency in speaking, everything matters. Your communication skills are equally important with the staff, with the patients, with your colleagues, and with the children. Sugar-coated tongue and ice on the top of the head makes you successful. About the staff, they are the backbone of the hospital. Recruit right person at right place, train them, encourage them, and also watch them. Have courteous relations. If you take care of them, they will take care of you. Now your workstation, that is your hospital itself, your consultation room, your OT, your indoor, outdoor, everything should be neat and tidy. Now there are so many interior things are coming up, so it should be fairly good, elegant. Now, very important, time management, because as your practice grows, you become more and more overloaded and you don't get time for many things. So don't be workaholic all the time. Make a timetable, listing your work, do prioritize your work and do the work which is more important. Plan your day, plan your week, plan your month and your year and life as well. Planning is essential in all walks of life. Fix desired goals and objectives and have definite time-bound action plans for heading towards them. So time is very important. So give importance to your each and every minute. So also you should offer some precious time for your health, fitness, to your family, your academics, research, and also social work as well. Now as the practice grows, you should digitize whatever softwares are available. You should utilize all the newer gadgets to make it paperless. Now connect and grow. If you connect with the people will connect with you. So social attachments are very important. You should be social. You should not be aloof. Do attend functions, be courteous, helpful, and confident and cheerful. Greet the people at occasions and enjoy the life. Social media is also a very good option to connect with the people. Now, very important, work is worship. Whatever you are doing, love that work. Strive for excellence. Honesty, efficiency, and cheerfulness is very important in your practice. Your sincerity matters a lot. Welcome criticism and hints from the patients as well as from your colleagues. Increase your brand value. That is very important. As the Amitabh or Shah Rukh Khan, they are known for their brand value. So you alone is your best asset. So update yourself and upgrade yourself. What it means? Update with your knowledge and skill. Upgrade your practice with the newer technologies so that you can cater the latest paradigm treatment to your patients. Happiness and knowledge are the two sides of the same coin. Endeavor to increase your qualification, qualities, and values. Always strive for learning newer things and be the best doctor in your area. What you should do in your practice? Always be humble, be polite, and well-mannered. Always try to help the patient in all respects. Update knowledge and skill. Always grab the opportunities. Take the decisions fast but carefully. Face the challenges and try for the solutions. Do the best possible in spite of limited resources. This is very important sentence because many times you don't have OCT, you don't have many things. But in spite of that, whatever sources are there, you should do comprehensive eye checkup. Enjoy your work, your family, and whatever you do. What you should not do, not be angry all the time. Don't spend the money before you have it. Don't be after money. Money will follow you if you are sincere and honest in your work. Many times we go on purchasing the machines, newer technology, but really they are worth. We should have a project report on that, and then only you should go for newer things. And very important, don't abuse your colleagues. Build assets through savings and economics. So economic growth is also equally important. Money saved is money earned. You save money as much as possible. Don't spend it before you have it. Saving through small and regular basis, that is SIP, from the very beginning in your career makes a lot of things in your career.
Hello.
It should be diversified.
So I request you to summarize your talk.
Okay.
Yes.
So to avoid medical legal problems, proper record should be maintained and give some time to the patient and don't argue with the patient. And at times you should have second opinion as well. Advertisement is very important. You should market yourself, but it should not be fancy. It should be about your facilities. Then in your practice, you should have spiritual attitude. And what you should do if poor patient comes to you, try to help him, try to give optimum discount. If patient is dissatisfied, listen to him, don't argue with him, explain him properly and have second opinion. If patient is VVIP or you are very near and dear one, so give some VIP treatment. Remember, follow the rules and regulation of everything you do when you will be successful. As said in some of the lecture of Dr. Kulin Kothari, consider each patient as your father and mother and do the best possible as you can, as said by Dr. Lahane sir. We are sailing in the same boat, hence don't abuse our colleagues, as said by Wangekar sir. How much is too much and where to stop? That principle was given by Dr. Paranjape sir. Very important is group practice in a single hospital, rendering all subspecialty services under one roof. So investment and responsibilities are shared. It is a joint venture you can have like LASIK center or ROP screening as we are already ventured on. Take home message. I believe that honesty, tolerance and patience are fundamental virtues in practice. We should promote holistic human development as part of building intellectual capital in our hospital. We should be committed to build culture of excellence and world-class standards through benchmarking and continuous enhancement of our performance standards. Do something different, make your own identity, then you will be successful. Thank you very much for your patient listening.
Thank you, sir. These were indeed pearls of wisdom. I would request comments of the expert panel. We have Dr. Neeraj Israni as a part of young panelist and Dr. Nikhil Nasta as a senior panelist.
So, Ashish, I think whatever sir spoke was very valid, very, especially the point where he spoke, two things resonated very well. One, he spoke about investing in too many machines. So make a project report, whether you really need that machine or you can rent it. Ahuja sir also highlights this very much, that you should not be over investing in things which are not giving you that much ROI just because you have to. And he also spoke about marketing, which also resonated very well. Okay, marketing karo, but thoda. And what is relevant, what is actually related to your practice, utna hi. Right? And I think he gave us very, very good tips. Let's see what Neeraj has to say.
So Ashish, I've been fortunate enough to work in a charitable institute and in private practice. And the first thing I was told when I started my private practice was two rules. One is ABC. A stands for availability of the doctor, behavior, and clinical skills. This is something that every private practitioner should have. The second thing I was told was the 1,000-day rule. That is, if for 3 years you can stay on in private practice, you can stay on for life. Again, it's very important to have that, like Sir said, you need to have that cool mind, because there are times when you will not be able to outperform. Lastly, I would like to say that we are blessed in ophthalmology to have 4 modalities, that is OPD, surgery, pharmacy, and optical. We should utilize all these 4. This is something I learned from corporates, because as a private practitioner, we don't utilize these, because for the first 6 months, 1 year, we are not going to do 30 surgeries in a month. We are not going to see 100 patients in a month in private practice. So I believe that it's very important to have a holistic approach of and utilize all these 4 modalities, which no other branch in medicine has. So that's my take. Thank you.
So Neeraj, if I may add over there, the 4 modalities you spoke about, na? At this recent DOS conference, I was with my friend. He's here over here, Sushrut. So he is doing all these 4 modalities, and young people really inspire, you know. So I was asking and taking tips from him. All of those work for you, for your income in a very good way. So we should really get all of them moving in our clinics. Sushrut, you want to say something?
Hello everyone. I would like to add to this that all the 4 things, our OPD, our OT, pharmacy, as well as our optical shop, they help us add a lot of income to our all the to our total earning. So we should utilize them as and when possible, and make it into a particular system, so that neither the patients nor our staff nor ourselves feel that we are taking what is not ours. So that is how we should make it I mean to say a proper system connected to each other, and thereby gaining maximum profits.
Thank you, sir, for your expertise. We'll now move on to the next presentation by Dr. Praful Chaudhary. He has set up again a very big center in a town called Ahilya Nagar. So he'll be discussing on how to transit from a small to a big center in a very short period of time.
Hello everyone. Is my slide visible?
Yes.
Okay.
You can just full screen.
Yeah.
Share full screen.
Okay. So thank you everyone for giving me this opportunity. In this Dr. Santosh Agarwal sir has already covered whatever important tips was required to start up a practice and to grow over a period of time. So I will be only touching the points which are necessary to grow from a small to a larger clinic. So, growth from a small OPD to a significant clinic to an institution doesn't really require a very large amount of time. Usually, if you have a good plan and you have a good intention, you can achieve all this in a very short time period of 5 years. So these are the I'll be sharing a story of my journey, where I started with a small rented clinic where I took a space from a orthopedic surgeon, where he gave me a small OPD and asked me to utilize his OT for ophthalmic surgery in between whenever it was possible. So working here, later I realized that I need to have my own clinic after 3 years of practice. So I started working on another project where I thought of procuring a commercial space of around 3,000 square feet like this. So I owned this place, but I planned this over a period of 3 years when I was working in a rented space. And to achieve this, there was some planning done, which I will be sharing in the next coming few slides. So after working in this space for another 3-4 years, I thought this place is again less and is not enough for my aims and goals which I wanted to achieve in future. So I thought of developing an excellence center where I can have a teaching place, as well as I can have all the possible subspecialties, all the services under one roof. So this is our center of excellence, which is supposed to be inaugurated on 15th of August. So why I wanted to share this story, because I belong to a very low middle class family. I probably in 2014 January I started with my private practice. I finished my fellowship. My last salary for fellowship was 10,000, and with that I could grow up till here. So I can certainly tell you from my experience that everyone can reach up to here, even if they do not have any experience from their families, or even if they do not have money. So how did I achieve this, and why it is important to grow this big? Uh, as we all know, bada hai to behtar hai, because the expectations of the patients are changing day by day. They want something better. They want all the value-added advantages from you, other than obviously having a good clinical experienced doctor. Also, as previously mentioned in the previous talk, that corporates are overtaking, and it would be very difficult for a small clinic to survive over a period of next 10 to 15 years, because we won't be able to provide all the norms as per the government, and we may not be able to cater all the cashless and government services at our setup. And also with a larger space, we can have better technology, better equipment, and all the subspecialties. And again, it gives a very good impact on your personality as well as for your legacy. So what is exactly this 5-year dream which everyone can dream of? And I'll be sharing a roadmap how we can do it. So we should aim for 3,000 surgeries in a year. We can have 4 to plus 5 specialties, subspecialties at our center. We can go for full NABH. We can set up a training center and have a charitable wing to run a good training center. What are the common roadblocks while we thinking of all these things? So major is financial limitations. But trust me, it is not that difficult even if you don't have money. If you follow these simple tips which I have mentioned here, you can really build a large setup without any taking much risk. Out of which is like, making your civil good to take good loans from the bank, taking your from friends and family, give them an interest, don't take it for free, because you will need it in your future also. Studies are your capacity to repay the loans. Discuss financials with your colleagues, peers who have done this in past, and appoint a very good CA who can make a good project report for you. Obviously, everybody has a fear of failure while taking a big risk. But trust me, in still society, we need a good doctors with a good setups. There is no competition as such for good doctors. And it is important to select your city according to your aims. Also, to have such aims, you need a very good team. For building up a good team, you need a very good staff. You need to nurture them. You have to give them opportunity. You have to give them freedom to grow under your roof. Then only they will help you to grow together. Having a big center also gives you a pleasure which money can't buy, because if you have 2, 3, 4, 5 doctors working together of a different specialty, you have DNB students, you have fellows together. So this is something which you cannot, buy. This happiness, this is a different kind of happiness if you're working with so many doctors at one place. And I've seen that after certain years, doing same thing becomes boring and challenging at times. And having all these facilities under one roof is really pleasurable. So how to achieve this? So during the foundation time, it is important that you follow a very ethical practice, follow all the evidence-based practices, try to be giving as good as treatment as possible, and do timely referrals without delaying the treatment. Audit your practice, set up a good digital EMR, build up a strong team of staff, start recording your data, outcomes, satisfaction, and volumes, and even invest in your reputation by taking good Google reviews and show a good social media presence. Scale up your services. As I already said, have subspecialties, have visiting subspecialty doctors at your place, so as to give a 360-degree services at your place. Plan to buy all the advanced equipment which are necessary for your practice, and begin eye camps and outreach programs. Systemize and streamline your hospital by having SOPs, by going for a full NABH, do staff training every month. Consider to have your own diagnostic center, or outsource your OT to your colleagues to have surgical surgeries at your place. Launch a website, have online appointments, and also do your financial tracking for profit and loss. There is also an importance of branding and exposure, which was mentioned previously by
Dr. Praful, the time is up.
Yes. Only 2 slides left. Yeah. So why to institutionalize that? You make move to a bigger facility, have multiple branches, apply for full NABH, create your own team, start DNB and research wing, and have mentors for junior doctors. So this is a quick wins to start today. Open clinic as early as possible. At least start rented at a rented place. Do multiple camps for better reach. Collaborate with optometrists and GP doctors by training. Monthly social media content, awareness, success stories. Get patients' testimonials on videos and make educational videos. Thank you.
Great. Thank you, Dr. Praful. That was indeed an inspiring journey. And I would be more optimistic for young ophthals. See, India has recently become the fourth largest economy, crossing $4 trillion. And very soon we'll cross 5. So there'll be more money in the pockets. The per capita income is only going to grow over the next 10, 20 years. So our younger colleagues will not have that much difficulty if we plan in a logical manner. I would request expert comments from Dr. Aarti Heda and Dr. Arjun Ahuja.
So I'll go first.
Yeah.
I would like to congratulate Dr. Praful for this wonderful journey which you have covered in 5 years.
Thank you, ma'am.
Thank you, Dr. Nikhil and Dr. Ashish, for the opportunity. So I'll just say one thing, that please keep in mind that all the big chain of hospitals today, like LV Prasad or Arvind or CFS or Dr. Agarwal's, everybody must have started small. They must not have started 10 centers together. Everybody must have started small and grown to this big chain of hospitals. So it's very important for you to start. You may start small, but aim big. So if in case you aim, you are planning start for that on the day one of your small clinic. So whatever said and done, don't leave your ethics and etiquettes if you want to really grow quickly and fast and be successful in life. That's it.
Thank you.
Hello.
Yes, Dad.
Yeah, sometimes I wonder the 1-inch organ eye requires 3,000 and 10,000 square feet of place to operate and do all the consultations. So it was very well presented. One thing I would like to add, if you want to have a magic growth in your practice, then whatever you earn, 10% of the amount you should do the charity. And most of the religious literature, especially in the Sikhism, they have said this one should be devoted for the poor patients. You should operate free or at a discount rate. So this you should keep in mind, however money you may earn, but do 10% charity every month from your income and see the magic of growth. That's all.
Yes, sir.
Thank you for those comments. We'll now move on to the next presentation by Dr. Asmita Patne. She is a second generation ophthalmologist and she'll be discussing on how to scale up practice, and they have had a corporate tie-up as well in the recent years. So Dr. Asmita, we would like to hear about your journey.
Good evening, everyone. Is my screen visible?
Yes.
Okay, great. So I thank MOS for this opportunity because despite being a second generation ophthalmologist myself, I had never really done such an extensive research into this topic myself, and I've learned a lot. So why are we talking about the second generation here? Because practically the second generation can either make or break this family business. It's the first generation that is going to take over from the founder. It's the first generation that's going to convert an entrepreneurial business into a family business. And it's the first generation that has to also take care of the family dynamics and see that the family is aligned with the business. So the responsibility is to leverage the resources in the family-owned venture and also be an entrepreneur to escalate the growth of this traditional entity through newer ideas. So this not only sounds complicated, but it is. So this is for all of them who kept saying to me and say is, तुम लोगों का क्या है, सब अच्छा है, सब तो ready है, क्या tension है. And now, after listening to Dr. Praful, if anyone says that to me, I'm going to direct them to him that you can do it as a new generation as well. So in addition to all that he said, there are extra things that you should be aware of, Well, in India, the family-owned businesses, FOBs, contribute to more than 75% of the national GDP. That's the highest percentage in the world. But it's very discouraging, these figures, that it's only the 12% of them which thrive till the third generation. And so the understanding of the dynamics of a family business is crucial. So if you're one who's looking forward to get into a family business, join soon. Ask yourself, are you ready? By ready, I don't mean if you're a good clinician or if you're an expert surgeon. You may be one, and if you are not, you can hire one. But are you ready to take on this management of a complex ecosystem? If you have someone in your family to do it, excellent. If not, you have to have a very clear roadmap, which begins from the first day of your post-graduation. So you need to have that mindset. In other businesses where we see that the children of the founder, they begin from the bottom level, become the junior manager, and then go up the hierarchy to reach the top level. But for us, once we join, we're already a super specialist maybe or a consultant. So there's no chance to start from the bottom, but you can do that from the day one of your post-graduation. That's when you work closely with the optometrists, you work with the receptionists, you can work with the counselors, you understand how the system works. So by the time you are finish your fellowship, you are ready to join your family business, at least you are halfway through. In an analysis of 300 publicly listed Indian FOBs, they compared the top performing, the top 20 percentile with the rest of the firms, and they gave a list of 5 points on what makes the difference. And the first one is the operational efficiency. And this is the core to any business performance. Now, unfortunately, this is not a part of our curriculum, not a part of a syllabus. So you have to go an extra mile to know the fundamentals of business management. You need to at least understand the basic terms like what is an MIS, what is ROI, what is EBITDA, what is EBITDA. So it is highly recommended that before you really join, work elsewhere, work as a consultant, maybe in a corporate setup or in an institute where you can learn these things. And it will be surprising to know that there are specialized MBA courses, postgraduate courses, specifically for family business management, and not one or two, they're all over. The next point is a smooth, effective transition from one generation to the next. All right, I understand that you're all excited and you are energetic, young. You have, you know the new market. You want to bring in the new innovations, and you want to see that growth. But hold on to that excitement, because you can't on the day one join and start commanding. You first need to be a proper listener. The employees otherwise are not going to listen to you. They are there in the hospital probably even before you were born. And it's not going to be a mere handover of the position, right? So the trust has to be earned, the trust from the patients, the founder, the investors, the employee. And it's going to take a while till the patients stop saying that humko bade madam ya bade sir ko hi dikhana hai. You need not take it personally. That will fade off. Eventually the patient will come searching for you. So be patient and be sure that whatever ideas and interests you have come with, that aligns with the company philosophy and the principles. The third is diversifying the capital. So like we in the previous discussion, we were talking about opticals and pharmacy. This is what was implemented here since almost last 25 years, which came out of need. So the opticals, you can also now venture into the manufacturing of glasses, lenses, manufacturing lens frames. There are some hospitals who have their own brand of lubricant eye drops. You can run an optometry college and so on. The next is bringing in professionals much earlier. A study says that third generation onwards, you appreciate the value of bringing in the professionals, but shedding that mindset is critical. You need to start trusting the outside professionals and bring them in. And a very robust governance mechanism is important. Now, in this framework, it is advisable to have, yes, a last slide, sir. This is important to have a non-family confidant who is a most trusted non-family member who can help you separate family and the business issues. And do not underestimate the impact the family dynamics has on your business. So align the family, have in-depth, clear, transparent communication, resolve the disputes. And in conclusion, yes, family businesses do face unique challenges, but they also have inherent strengths. Through robust governance, succession planning, and fair HR practices, you can build a family legacy that can go on for generations. Thank you for your attention.
Thank you, Dr. Asmita. And yes, there is another report where 75 to 80% of the billionaires in the world are actually self-made. So just we'll have a one quick comment by Dr. Anagha Madam.
Yeah. Yeah, hi, and excellent presentation, Dr. Asmita. So I am also a second generation ophthalmologist. My mother-in-law was an ophthalmologist and she set up the hospital in 1972. So I myself are now 28 years into practice, and I remember when I took over, she wanted to stop practice immediately. So one thing what I would like to say is whether you are first generation or second generation, you should not just consider whatever you have as yes, mere ko to mail mil gaya. In fact, this was told to me by somebody that tere ko to mail mil gaya, tere ko kya farak padta hai. But it's not that. You have to think that it's just the treasure that you have, and you have to see how you can contribute to take it to a different level. Okay, whether it is the level is here or here, you have to take it much higher. One thing is you should not have any ego. Do not think that just because somebody, your father or father-in-law or mother-in-law, whoever it is, you have to have zero ego, and that holds true for any kind of practice. In fact, I didn't have the opportunity to do any fellowships. I had to start practice the next day. So whoever is already doing fellowships have an extra edge. You can put in your contribution with your own technology, your own clinical skills also. And another thing is there's already a setup. So there are already staff, there are already people working. So you have to see how you can adjust to that. Just like a new daughter-in-law will adjust to a new family. It's like you're not building it on your own, right? It's already there. So you are like the daughter-in-law and you have to see how you can adjust and have respect for everybody. Take their inputs and give them your inputs in such a way that it is a very good ecosystem. So it's very easy to have differences. It's very easy to, things can blow up, but it's so important that you have to coexist smoothly, peacefully, and then as a team, you have to take over. So finally, it is how you take over, become the team leader eventually, and then build up the legacy. So there's so many things we can say. I think time is short.
Yes, madam. Thank you
Great topic.
for your comments. We'll just have a comment from Dr. Shushul.
Yes, thank you for. So I would like to add just one thing after the presentation, that as a second generation ophthalmologist, the fight or the challenge stays that you are going to sit at a place where a 30-year-old experienced guy was sitting. So the way he used to practice, you have to reach at least at par with him, if not above him. So it is a very difficult and a different journey to those who are starting fresh. So as a second generation ophthalmologist, the challenges are different, but it's a fun
Thank
journey.
you.
It's a fun
We'll
journey.
move
So
on
all the best. Okay.
to the next talk now. Thank you. Next talk will be presented by Dr. Jay Shah, and he is personally managing multiple centers on his own. So we will have interesting insights from him. Sorry, we are running short of time. So we'll have to move a bit faster and request the speakers and panelists to please give short comments.
I shared my, am I audible?
Yes.
My slides are visible?
Yes, please. You may proceed.
First of all, I would like to thank Moscon faculty for inviting me for this presentation. The topic is how to run multiple eye hospitals successfully. So, I don't know. Again, that slide is visible or not? Because I am not able to see here. Okay, fine.
Slides are visible, so
okay.
Please proceed.
So, first of all, Dr. Santosh sir already told us the pearls of starting the practice and how we can build the practice. followed by Dr. Praful sir, who gave us the idea how you can change your small practice to a larger mode of practice where you can have all the facilities available with you and you can have an institution. Now, topic given to me is to run a multiple hospitals. So the challenges in managing multiple hospitals will be a bit different, and here my objective is to share proven strategies for efficient multi-center management. So these are the key pillars which I have followed in my practice, which has brought me here to this level. First is clinical excellence. The second is patient-centric approach. Third is standardized operations and strong leadership, robust technology, and financial sustainability. I will take one pillars, and I will have I will add on some points onto that. So the first thing one should think is clinical excellence. We should have a protocol-driven treatment across all the locations. We have to make sure that whatever treatment and whatever the facilities we are providing to our patients should be of the best. And we should have a regular training and CMEs for all our staffs, medical, paramedical staff. And third important thing is to have all specialty services at all your centers. If you have a specialty services, then you don't have to refer your patients to a different hospitals, and you can provide best possible treatment to your patients at your clinic only. So second most important point is patient-centric approach. So first and most important is personalized care tailored to diverse socioeconomic backgrounds. This is what I have followed in my practice. If patient is not that great in economically, not financially strong, then also I make sure I give them the best possible treatment which I can give them. So truly patient-based approach, respecting individual circumstances, ensuring dignity, accessibility, and optimum outcome for all. Third important is feedback. We have to make sure that we take a feedback from our patients, so we will be able to improve ourselves by following that feedback. And next will be a standardized operations. In this, if you want to run a multiple centers, we have to make sure that we set the protocols for all OPDs, all OT procedures, everything. Second important is quality audit. We have to make sure that quarterly audits are done for everything. Compliance tracking, which is also very important for all medical legal documentation and all. So all that standardized operations, we have to make sure that we standardize that operations. Fourth important is leadership. So the most important thing which I follow in my practice is centralized hiring and decentralized supervision, because one person is not going to go everywhere and do the supervision for handling the hospitals. So what I follow is I hire at one place, train them at one place, and then I send them at my multiple centers. And I have one unit head who follow all this. I train them and I take all the informations related to the center from single person. Because for me, going to 3 centers and managing all this work is a bit difficult task. So this centralized hiring and decentralized supervision is very important if you want to manage a multiple hospitals. Third important, even this is staff retention strategy. This is the most important in recent scenario because of the Gen Z. They are like, wherever they get a bit improvement in their salary, they just run away. So make sure you don't allow them to run away by giving good perks and returns, because if they are smart, they will ask for it. So we have to pay them. Then leveraging technology. So basically, we should have an integrated hospital information system, centralized data dashboard. And the third important stuff to start a multiple centers, if we want to start a multiple centers, first and most important is cost-effective technology that will deliver a reliable and efficient results, and which make quality care more accessible with resource limited settings. Because if you have a lot of money, then you can buy a Centurion and start a cataract surgery. But if you want to practice where you don't want to invest a lot and you want to start a multiple centers, then you have to have machines which are at a low price and gives equivalent results. and this tele-ophthalmology and ERS based screenings will be in future. Right now we are not following anything. And the next important part is financial management. So unit wise profit and loss accountability, revenue cycle optimization, cost control via bulk procurement, all this every one of us must be doing. The
30 seconds left.
Yeah, if only one thing I wanted to inform here is what I follow is I give 1,000 days of practice. Like what I do, if I want to start a new center, I will make sure I will pay my staff everything for 1,000 days, even if I don't earn anything, because that's, if I spend that 1,000 days, then I am sure that that center is going to run forever. So this is the expansion strategy. Risk management and compliance, we have all this C form and NABH equivalent legal compliances, all that we have to follow. So the conclusion will be, after achieving the clinical excellence, take patient-centric approach and set the protocols with robust technology and strong leadership and achieve your goal. Thank you.
Thank you, Dr. Jay, for sharing your insights. I will request Dr. Vaishal Kenia, sir, to share his expert comment.
Yeah, so can you hear me?
Yes, sir.
Yeah, so multiple centers to have, first and foremost, you have to invest in your primary center. For primary center, it has to be not personal branded center. It should be a brand-based approach. So once you expand, the brand should be known, not that person should be known. So you have to decentralize yourself. That's the first thing. Second, it's a culture building. So what kind of staff are you investing in? And you have to nurture that culture in that staff. It's very, very important that it's a human touch. And the same culture is there in all the centers. You know, it's like going to a McDonald's, you feel the same culture elsewhere in each and every branch. So it should be a replica. So basically in a multiple center, you are building up replicas. And for that, what Jai said was very right. You have to build your foundations in your SOPs. You have to have your systems in place. For that, accreditation is most needed. And instead of, rapidly expanding, you expand first into a one center and see what, and then the subsequent replicas become much faster. The last point which I want to say is building multiple centers in a primary center or a second two-tier city or a tertiary tier city is totally different. In Mumbai, if you want to do, you have to have clusters because people do not travel even 1 kilometer today. So cluster having multiple centers makes more sense. People have at a short distance in Mumbai. So that is making more sense than having multiple centers at widespread population. So you can control it much better. And that is my take.
Yes, sir, I agree. Dr. Zen, quick comments from you. Even you run multiple centers.
Yeah, just a quick addition to the presentation would be that EMR, you can take a cloud-based EMR, which will be working on all centers. That is something that is important. So you get data of patients everywhere, and as much as possible, try to take equipment which is portable. Eye care tonometer, for example, is something that I carry to multiple centers, so I don't have to invest different kinds of NCTs in each center. So these are just two pearls I would like to give.
Yes, agree. Thank you. We'll move on to the last presentation of the session by Dr. Swapnil Vedate. He's a friend and colleague of mine. He'll be sharing his insights on setting up a new practice in Nasik, primarily a retina surgeon. Dr. Swapnil, you may please share your presentation.
My slides are visible?
Yes, slides are visible. You can make it full screen. Yeah.
Okay. So thank you, MOS team, for giving me opportunity to present my personal experience of setting up a new practice in a Tier 2 city. So to start a first generation ophthalmologist practice, these were the checklist made by me to start a new practice. So it is a location And to have a location, either you should buy or rent it. What are the financial concerns, hospital registrations, how to manage the cash flow, and about networking and social media influence on the practice. I'll be speaking on these steps to build a personal practice. Most important step to start a practice in for a first generation ophthalmologist is have a self-confidence. So starting a practice as a first generation ophthalmologist with no family background in medicine or a practice ownership requires more than just a clinical skill. So you should have, you should be facing the unknown with the courage. As a first generation doctor, your confidence assures the patients of your competence, even when you don't have a big hospital name behind you. You might compare yourself with seniors from medical families or established practices. Confidence helps to fight the inner voice that says, am I ready for this new venture? And it replaces it with the, I have trained for this and I am capable. So with this self-confidence, I started looking for the locations. So I started my practice in growing suburban area. It has a good accessibility from various highways, railway stations, and airports. Their rental affordability was there because for the new practice, you should have a rental affordability, and it always has a good footfall potential. As where I am practicing, it has a multiple hospitals with other than the ophthalmology, so I get a good referral from those hospitals. So either you should rent or buy the property to start a practice. Rent, usually it has a lower initial investment. It frees up the capital for medical equipment, staff salaries, and marketing. It has a faster setup time, flexibility, easier to relocate or expand if patients' inflow or location demands change. There is no property tax. Typically, it is borne by the owner. Disadvantage is that no asset creation, rent escalation, or there is a limited control or structural changes may need a landlord approval. And there is always a risk of eviction or non-renewal. Also, there are branding limitations and less scope for the long-term branding and in non-owned space. So what to choose, either rent or buy the property. So if you are renting, it is just starting with the you have a limited capital to require. When you buy, when you plan to buy, it should be well capitalized with good financial backup with a long-term vision. And when you rent a property, you should have an advantage that you can test the location before the long-term commitment. Another challenge faced for the new setup is hospital registration. So you should have a proper Bombay Nursing Act registration. You will have the delays in fire NOC, change of use certificate, biomedical waste tie-ups. So always look for the building completion certificate while renting or buying the property. It will help in faster registration. When you plan for the finance, you should have a total budget which is dedicated to OPD, diagnostic, and OT. You should always have the emergency fund for at least 6 months. As when I started my practice, within 2 months, COVID lockdown started. So luckily, I have kept my emergency fund for 6 months so that I manage my finances. While taking the loan, it should always have the mix of term and personal loans. I opted a longer tenure loan of 12 years so that my EMIs were within 25 to 30% of expected monthly revenue. So I never had any tension to pay my EMIs on time. I joined medical colleges for the part-time to get a regular salary, peripheral visits to reach suburbs, and always look for a regular income sources which covers my expenses, including my EMIs and staff salaries. When planning for the equipments, I usually plan my equipments which are familiar to me or I'm well trained in my fellowships. I try to negotiate for long-term warranty and CMCs so that any repairs are there in early days, I should not pay from my pocket. Plan for equipments rather than real estate investment, and always take a demo of equipments. And if you have verified review and service, you can invest in refurbished equipments also. While hiring the staff, I feel minimum one optometrist, one OT nurse, one admin, receptionist are required initially. Rather than keeping a highly experienced staff, you should keep a newcomers and train them well so that it will save your salary. And those staff will remain with you for a longer time. I outsource my pharmacy, few diagnostics like optical biometry, perimetry, YAG laser to reduce my upfront cost. Always have an optical shop to start with. It will definitely add up to your revenue. And other than your setup, you should organize screening camps, partner with the local NGOs like Rotary, Lion for the eye checkups. It always builds trust before scaling your services. In today's era, you should have online platforms for appointment bookings, Instagram, Google Business for outreach programs. Maintain a digital patient record, which will definitely help for your practice.
Please summarize. The time is up.
So what worked for me is I started lean, which helped to manage my cash flow, even in days like COVID. And loan helped me to cover my early cash burn. Financial emergencies like COVID are rare, so you should always prepare in advance. Community goodwill will build a long-term trust. So my take-home message is starting a practice is not just a clinical, it's entrepreneurial also. So plan unexpected delays, stay ethical, serve consistently, and be patient. Growth will definitely follow.
Thank you, Dr. Swapnil. And yes, those indeed were a very wise approach. I would like Dr. Santosh Bede sir's comment on this presentation.
Thank you, Ashish. Before I comment, I would like to congratulate Team MOS, Dr. Shirish, Dr. Piyush, Sumit, Neeraj, Nikhil, Zain, everybody for an excellent midterm Moscon, online Moscon. So kudos to you all, and Dr. Viral also. And Dr. Swapnil has covered all points in an excellent manner. And my best wishes to him for a great practice. In today's era, you should have a good knowledge. You should have a good training from a good institute. Like fellowship is a must, and I know that he is a retina fellow. So he has a very good future. Selecting a location is most important thing before you start the practice. Because if you select a location in such a way where there is a thinly populated area, then you will not have footfall. And as Vaishal has said, like in cities like Mumbai or Pune, traveling from one place to second place itself takes 2 to 3 hours. So patients become reluctant. Though they want to come to you, they are reluctant to come to you because of the time which they have to spend. So select location properly where it is thickly populated. Be ethical, be sincere, and all points are very well covered by Swapnil. Excellent talk, Swapnil.
Thank you, sir. I would request Dr. Anand Bhosle sir to also give a comment.
Excellent talk, Swapnil. Fantastic points and additional points by Bidesh sir. I really don't have any much more to add. Lot of take-home messages from the presentation. Thank you.
Yes, it was a very varied experience of almost 3 decades in different aspects of private practice. I would at last also like to have quick comments from our chairpersons of the session. Dr. Jagannath sir, you can please give a comment.
Yeah, good evening and thanks the MOS team. In the beginning, Dr. Ashish told that time in private practice for 19 years. You can easily add 20 more years. I am practicing for 39 years. The era when we started the practice, we straightway used to start practice after MS. There was no fellowship. Now people have to do super specialization fellowship and then enter the private practice. The difference again is now in our times, these big corporate hospitals were not there. And the trend was to have a small setup, small clinics, small setups. But now the things have changed. Especially a beginner who doesn't have a medical family background, it is really difficult for him to practice and compete with these people, the corporate hospital who keep advertising right, left, and center, announce free eye checkup every month or once in a while. It becomes very difficult. So I think today 1 hour is very insufficient for such a big topic, practice management. We should have one big full day seminar or webinar. Second thing about the renting or buying of the place, Dr. Swapnil was talking about renting or buying. I don't know which is financially wise, but people say it is financially wise to have a premise on rent. It is interesting to note that most of the big chain hospitals, they take the new premise only on the rent. Even the banks who always coax us to take rent, they don't take a loan, they don't purchase the premise. They always take the premise on rent. That's all.
Thank you, sir. I would request Suhas, sir, Suhas Haldipurkar, sir, for your comments, please.
Hi. Well, it's indeed been a wonderful, discussion on practice management. Like, we when we look at practice, practice has two aspects. One is the organic growth of a practice, and another one is inorganic, or something that we discussed today. But at the end of the day, we all should remember that we are in a service industry, and where our profession continues to be a noble profession. So even when we are, in a hurry to increase your practice or grow your practice, we should not miss, that link that you have with your patient, because at the end of the day, the practice that you have grown by getting the trust of your patient, or your practice grows from mouth to mouth, like one patient who goes out of your clinic happy and he goes and brings in another patient, that becomes a solid foundation of your practice. Unfortunately, that organic practice doesn't grow very rapidly, and that's the reason we resort to all these things. Like where you want to grow your practice from a single practice to multiple practice to a large hospital. Of course, that's how the change is today in this world. But at the same time, remember that when the practice is going from a small practice into a corporate practice, there's still going to be that boutique practice where a patient would come asking for you. A trend would come when patient would look at a big corporate chain, will come to a hospital where he will come to the hospital and not to the doctor. But if you want that coming to a particular doctor should continue, then your bonding with your patient should be very strong. And that is what we should strive to retain even when we are in a hurry to grow your practice. Because as you start growing your practice, our focus gradually shifts from this beautiful sacred relationship that you have with your patient to making a bigger practice or bigger money or bigger establishment. There's nothing wrong in making it big. At the same time, please remember that that beautiful bonding between you and your patient should never be strained. So that's all I would like to tell you. This session has been really good. And it's very interesting to see that most of the speakers were all young upcoming doctors. So that means, it's an era where the young ophthalmologists or YOSIs are taking over and taking over beautifully. My best wishes and congratulations for conducting this seminar or this particular session so well. Best of luck.
Sir, I have a question for you, Hadipurka sir. Very nicely summarized everything. You said that your relationship with the patient should always stay. But when like Dr. Jai has other branches, and when people are expanding and you personally may not be able to there in the other branches, then how do you maintain that principles or the relationship, or how do you go on the same path which you started fundamentally?
You cannot, because your bonding would be with your patient, because we are not like an industrialist who will start 10 industries at different places. Finally, because the patient comes for you. So naturally, if you're going to sit there and see that patient, that's when you have that bonding. But you still want to grow. So what happens is when you have multiple places, your system, like you have created a brand, and that brand works, and the patients comes to that brand and all your centers start working. But in the heart of your heart, your patient is truly that patient who's come to you and you are treating. Like I always say, as you grow senior in your practice, let's say, like presently, I'm practicing for last 44 years. So in my practice today, almost 75% of the patients are my follow-up patients and only 25% are new patients. So if you look at financial viability, the follow-up patient doesn't bring you revenues, only the new patient brings you. But what that follow-up patient brings you is a lot of wisdom. Now, he comes to you just for a small issue. He'll sometimes travel a long distance to come to see you. That means with so much of trust, he comes to see you. So my advice to all young doctors is never look at your patients, the follow-up patients, with less interest because he's not going to bring you a lot of revenue, but he brings you a lot of wisdom. And finally, practice is where, it's like bonding and it's like feeling happy about, it's the end of the day when you've seen, let's say 50 patients or 30 patients, whatever number of patients, you should come home very happy because that happiness comes when you have a good bonding with your patient. So that should never be lost in our hurry to grow the practice. The practice will grow. If your systems are in place, if you're true to your patient, the practice is bound to grow. But always remember, you are in the service, and service, say, medical practice is service to your patients, and it's a noble profession at the end of the day, and never forget that.
Thank you so much, sir. And yes, truly inspiring. I thank all the speakers, panelists, and our chair members who made this session, so informative. And thank you for sticking to the time. I'll hand over the session now to Dr. Viral and Dr. Piyush to proceed with the valedictory function.
Thank you, Ashish. Viral sir.
Thank you so much, Ashish. So that brings to the last session, and it's now time for our valedictory function. So I request our Chairman Scientific Committee, Dr. Piyush Bansal, to do the proceeding.
Thank you, Honorary Secretary Viral sir. Before I express my vote of thanks, I would request Honorary President Dr. Shirish Thorat sir to express his opinion and address us.
Thank you, Vijay. Good evening, everyone. Respected Professor and dear friends. As we conclude our 2 days of midterm conference, I want to extend my heartfelt gratitude to each one of you, our speaker, our coordinator, our dedicated delegates, and our mentor, our managing and scientific committee members, and tireless organizing committee. My special thanks goes to Piyush and Sumit, Dr. Vare Madam, for all the hard work they have done. Thank to Viral sir and Shivan sir also. I think our aim to take the knowledge and technology to the smallest town and periphery is fulfilled. Though the large gatherings and physical conferences have their own role in propagating knowledge and technology, this type of online conference has certain benefits along with less economical burden on everyone. In all, our scientific committee has done a wonderful job. A big thank and congratulations to all. I would like to appeal everyone to get involved in all MOS programs and grow together. Thank you. Thank you, Vijay. Over to you.
Thank you so much, sir. Yes, truly, as you said, it was a 2 day of academic extravaganza that we had. And as the theme was dilemmas in ophthalmology, it was explored in depth, nuances, and real world applicability through spirited debates, fascinating guest discussions, and thoughtful panel interactions. So, Dr. Piyush, sir.
Thank you, sir. So it was a daunting task, and as we come to the end of the third midterm conference of Maharashtra Ophthalmic Society, I'm happy to share that we had 2,092 registrations. The number itself is more than the number of registrations that we generally receive at the All India Midterm Congress. Now, especially it's important because this was a purely academic meet. It does not have any trade exhibition, which is, as we all know, a big reason why a lot of ophthalmologists also attend the midterm congress or the annual conference. We had 189 faculty. It was, of course, a slightly different program. We had young speakers, like Haripurkar sir mentioned. Majority of the speakers were young, and seniors were there to guide them. And what it was heartening to see all the advice that seniors shared with all the young junior ophthalmologists wholeheartedly, teaching them the points that would perhaps take much longer for them to learn. So, like I said, all the scientific content that we've recorded is all going to be available on YouTube. This is going to increase our academic collection drastically. So that is, it's very, all the future generations also can have access to all of the data. Now, before I step into thanking everybody, one aspect is thanking the sponsor over here, because generally those tend to be left behind. Entod has been sponsoring our academic meets, whether it is the webinars, sometimes at the last minute, going through a lot of difficulties and making sure that that gets sent across in time. So a big thank you from all of us to Team Entod, and to Sunilji, who's there right now with us, right from early morning, from 8:40 in the morning till right now, and even yesterday, trying to troubleshoot each and everything. There's absolutely no lag or delay in any troubleshooting or problem solving. So big thank you to Sunilji from Zadtiotech. Next, I would like to thank the best president that I could have hoped for, Dr. Shri Storat sir, the honorary president of MOS. For me, the secretary, honorary secretary, Dr. Viral Shah sir, treasurer, Dr. Shon Chinchole sir, incoming team after Moscon Goa, Dr. Anaga Hiruz, the vice president, the president-elect, I'm sorry, the vice president, Dr. Atul Kadane, our editor of JCOR, Dr. Rajesh Joshi, Dr. Preeti Kamdar, who took up such a lot of responsibility for the glaucoma sessions, the joint secretary, and the joint treasurer, Dr. Ajay Lohia, sir. Of course, I would like to thank our patron, Dr. T.P. Lane, sir, our advisors, past presidents, because who are there in the background and always helping us with the nitty-gritties and all the difficulties that are in our face. I would like to thank the zonal managing committee members from all the zones, the scientific committee members, which include Dr. Professor Archana Vare, who's been doing so much of work in the case presentation series that we've been doing, Dr. Aditi Vatwe, Dr. Manish Bapai, who despite having difficulty at home was there to help us out during the entire conference, Dr. Saurabh Mundra, and of course, my pillar of support, Dr. Sumit Lahane, who I don't think this meeting could have gone any smoother or anything close to what it has without he being involved in each and every step, trying to be the engine of the car, as he says. So thank you, Sumit, for everything. Our co-opted members, Dr. Manjari Malika, Dr. Dharmeshkar, Dr. Shubha Zawar, Dr. Shamik Makadam, Dr. Mukesh Paryari, Dr. Manish Wankhede. Of course, it will take a little time. Give me a minute more. I would like to thank all the subspecialty committees who've taken so much of effort. Despite the fact that we had released Google Forms for people to submit their abstracts, the number of submissions as compared to what we expected was comparatively less. So catching hold of young ophthalmologists who could and push them to make those case presentations was comparatively a daunting task. And this is where our subspecialty committees have done so much, right from gathering younger ophthalmologists to reminding all the moderators, reminding the expert panels, whether young or senior, and basically making sure that every session begins on time. So I would like to thank the glaucoma subspecialty committee, which included Dr. Preeti Kamdar, Dr. Sachin Dharwadkar, Dr. Sanket Deshmukh, Dr. Siddharth Kambre, Dr. Pankaj Bendare, the VR subspecialty committee, Dr. Swapnesh Sawant, Dr. Suhas Sonavne, Dr. Manoj Sasore, Dr. Preetam Samant, Dr. Girish Gadre, Dr. Abhishek Desai, Chetan Bidekar, and Anant Bhosle. The Oculoplasty subspecialty committee, Dr. Shubha Zawar, Aditi Pujari, Namrata Dulkar, Akshay Nair, Nagendra Sir, Mangesh Dobekar, Richard Dharap, and Sompal. The Refractive Subspecialty Committee included Dr. Natasha Pahuja, Zain Khatib, and Nikhil Kandurwar. Zain also took a lot of efforts for making sure that the YOSI session was very smooth and was very informative. The Cataract Subspecialty Committee, which included Dr. Nikhil Nasta, Dr. Vinayak Deshpande, Dr. Amit Kumar, Amar Bhaskare, Kunal Shinde, Dr. Satish Patil, and Swapnil Kothari. The PISK committee, which included Abhilasha Parkhe, Dr. Prasad Varimbe, Dr. Milind Kiredar, Dr. Rishikesh Mai, Dr. Siddharth Kesarwani, and finally the UVA Subspecialty Committee, which included Mayur Morekar sir, Dr. Swapnesh Sawant, Hitesh Sharma sir, Samyak Milkutkar sir, and the Cornea Subspecialty Committee, which included Anand Pimparkar sir, Mitesh Jain, Parul Deshpande madam, Swapnil Bhalekar, and Mahesh Sonpedkar. So a big thank you to all of you all. We would also like to thank the Cultural Committee of MOS, especially Dr. Karobi Lahiri and Dr. Nikhil Nasta, all the zonal in charges and coordinators for the fantastic show that they had put up. So I won't take much more time. We have the results of the free paper session. This is the first time the free papers comparative session was done in the midterm Congress. And the winner is Dr. Pallavi Garg, and the runner-up is Dr. Nikhil Darade. The video competition winner is Dr. Neeraj Israni, and the runner-up is Dr. Amit Nene. We will, of course, be awarding for all four of them at Moscon, Goa. So just briefly, in addition to what lies next after this, in addition to the case presentations, subspecialty webinars, and the MOSPEP lectures that are going on, we'll be soon starting with the financial series after the AIS financial series is closer to getting over, and practice webinars, practice management webinars, as well as podcasts with the leaders, which we will be initiating. So with this, I thank everyone from the bottom of my heart and invite everybody to participate, as Turat sir has mentioned. Be a part. We are already close to the evaluation process for Moscon, completion of the process for Moscon Goa, which is going to be a spectacular event. So please be more involved with all of that. Any new ideas, please feel free to send it to anybody from our team. And see you all in Moscon Goa for the next big annual conference.
So Dr. Piyush, before we wind up, there are some prizes from the cultural committee, cultural event that we had also yesterday. If Karobi madam or Nikhil Nasta is there, they can do the honors, or we will announce the winner. Is Dr. Karobi or Dr.
Karobi has sent it to me in case if madam or Nikhil is there, then they can.
So the winners were for singing from the central zone, it is Dr. Ranjit and Dr. Sabyasachi jointly. From the north zone, it is Dr. Nitin Kanade. From west zone, it is Sachin Athalye, and from Vidarbha, it is Dr. Hita Bhagwat. These are all for singing. For dance, from Marathwada, it is Dr. Mumbai. From west zone, it is Vardhman and Shrutika, and from north zone, it is Darshana and Ragini. For the instrumental prizes, Dr. Nikhil Kondurwar from Vidarbha zone, Dr. Mihir Vaidya from central, and Dr. Yashpal Lamba from Vidarbha zone. For the MyMat, Dr. Karobi, Dr. Nikhil, Manish, Dr. Usha, Dr. Ashish from central zone, and Dr. Samir Datar from the west zone. Poem, Dr. Rupalia Benkar for the poem, and the runner-up for the best team was north zone, and the winner overall, the best team was central zone. So these are the prizes for the cultural event that we had for this midterm. Thank you, Piyush, for letting me speak on behalf of the cultural committee.
Where else Sunera madam is there?
Yeah, Sunera madam was the coordinator for the Marathwada. There is also a special judges prize for Dr. Sharan Vartikar from the central zone. Sunera madam was.
So,
yeah. Yes, sir. Over to you.
So we have very senior stalwarts, past presidents of MOS also among us. If you all can
Malik madam is our advisor.
Do advise us and do express
mentor for
improve the conference, or
Dr. Santosh Bede sir is also there. Yeah.
Or what your opinion was about the conference. You're muted, ma'am. If you can unmute.
If you ask me, this has been a wonderful midterm conference, and it's such a useful tool. I know we started webinars in my tenure when COVID struck, and we shifted to webinars, and I think they're here to stay now. My team, which included Santosh Bede and Preetham and Vardhaman, we had a wonderful time organizing those webinars, and I'm reminded of them whenever I attend the midterm meetings, because we did a virtual VirCon. That was the first time in India or anywhere that it had been done. So I think this meet has been great, including the cultural program. Everything has been perfect. Piyush, Shirish, Viral, you all are doing a wonderful job. Just keep up the good work.
Thank you.
Congratulations, Team MOS. Congratulations to Shirish,
Thank you, sir. Thank you.
Viral, and Sumit. Sumit is a very silent and hardworking fellow. And of course, the young team, YOSI team is doing great job. As Madam has mentioned, we had done webinars and we had done first virtual conference. And in fact, our paper was published in Indian Journal of Ophthalmology, if you remember me. And this first midterm conference of MOS was done for the first time during my tenure as a president, when Vardhaman was the chairman, scientific committee, Dr. Anaga was secretary, and Vivek was our treasurer. So it's a very good platform, excellent, and it's mainly meant for young. It's mainly meant for young ophthalmologists to showcase their cases and showcase their talents, and they are just amazing. So it's excellent. Kudos to you, and best wishes for our Moscon and Goa.
Thank you, sir. Thank you, sir. Anaga is there. Dr. Santosh is also.
Yeah. Hi, and congratulations to the team, Dr. Shirish, Dr. Viral, Dr. Shon, Dr. Piyush, Dr. Sumit. You all have done just amazing, and year on year, you're raising the benchmark, and I think that is the way to go. Very inspiring work and wide variety of topics. Right from you have included even practice management in this. Excellent, good selection of topics also, including the cultural program. So power pack 2 days. So great, lot of effort that has gone into it. Kudos to you. Great, looking forward to Goa. Yeah. Yeah. Thank you so much for a great conference.
Thank you.
Santosh sir, Dr. Santosh.
Heartiest congratulations, Dr. Shirish, Viral, Piyush, and Sumit. This team is very much, they have put a lot of efforts to make it successful, and there are a wide variety of topics. And we learned, not only we presented, but we learned a lot of things from this conference. And cultural night was amazing. So this midterm conference was started in Santosh Bede's time, and we continued it in our tenure, and now you are also continuing the same thing. I think this is a very good platform for the young generation to present their work, and they are doing excellent work. What we are going through this conference, we observed that, and thank you very much for giving me the opportunity to present my work also. So thank you everyone, and looking forward to a great conference in Goa. All the best.
Thank you, sir. Thank you for your kind words.
You, sir.
Conclude now.
Yes. So, Vigal sir, Sumit, are you there?
Sumit, special thanks to you.
Special thanks to Sumit.
Yeah, Sumit, you need your camera on.
He's done tremendous work.
I think he's on a phone call.
Very humble person, ma'am.
He must
Very
be
humble.
right now also.
Silent worker is.
Silent worker, right?
Silent worker and
but
hardworking person.
May I request Viral sir to conclude with the
Yeah. So thank you so much. So it was an amazing 2 days of our academic extravaganza, and it would not have been possible without the scientific committee led by Chairman Scientific Committee Dr. Piyush, Secretary Dr. Sumit Lane, and all the team members. And thank you, Dr. Shirish Swaraj sir, for leading from the front and always be there to guide us. And जो भी होगा देखा जाएगा, कर डालो प्रोग्राम. हमेशा कभी भी सर को बोलो कर लेंगे, डोंट वरी, कर लेंगे. कहाँ से कर लेंगे, कैसे कर लेंगे, वो बराबर हो जाता है. So thank you so much, Shirish sir, and all our advisors and fellow managing committee members and scientific committee members. See you all soon in Goa physically, and before that, we will be meeting virtually as and when Dr. Piyush sir commands us. Thank you.
Bye, everyone.
Thank you.
Bye.
Thank you.
Bye.